morning. Good morning. I am Dr. Setabi Eden Michael. I am the treasurer of the Association of Surgeons of Uganda.
Good morning, everyone. I am Emmanuel Bua. I'm representing Eastern Uganda on the Asou Council.
Good morning. I'm Guapus John Robert, an SHO Year 3.
Good morning. I'm Kalongo Michel. I'm SHO General Surgery, 5th year.
Yes, good morning. I'm Dr. Tapem Emmanuel, SHO General Surgery, 3rd year.
Good morning. I'm Okal Robert, SHO Year 3, General Surgery.
Yes, morning, ladies and gentlemen. My name is Matov Brian from Makerere Biomedical Engineering Unit. I'm happy to be here.
Yes, good morning. I'm Kato Hussein Wabi, Biomedical Engineer from Makele Biomedical Engineering Unit.
Good morning. I'm Dr. Mbaga Chigongo, a urologist. I'm with Eurocare Hospital.
Thank you. Good morning. Dr. Innocent Orimonsi, Senior House Officer, Makerere University.
Good morning, Mohoz Rwakadebe, Pediatric Cardiac Surgeon, Uganda Heart Institute.
Yeah, good morning. I'm Dr. Kasaga Brian. I'm a surgery resident year 2 at Makerere University.
Good morning. I'm Ikoru Jane Rachel, GIT surgeon, Mulago Hospital, member of Asou, treasurer of SUJES, female doctor.
Good morning. Kakwoza Francis, General Surgeon, Kayonga District Local Government.
Ronald Bisegera, anesthesiologist, Secretary General elect of the Association of Anesthesiologists of Uganda.
Cornelius Sendagire, anesthesiologist. Thank you.
I'm Phyllis Kisa, senior lecturer at Makerere University and pediatric surgeon, pediatric urologist.
Good morning. My name is Nsubuga Yakobo, 5th year medical student from Guru University.
Good morning. My name is Joseph Kariuki. I am the program manager for East and Southern Africa for Smile Tree.
Olivia Chituka, a hepatobiliary and upper GI surgeon and lecturer with Makerere College of Health Sciences.
Good morning. I'm Dr. Sekawira John, pediatric surgeon in Mulago National Referral Hospital.
Good morning. I'm Nasa Kakembo, senior lecturer at Makerere University College of Health Sciences. I'm a member of the executive of Asou, representing the Central Region.
Good morning, colleagues. Dr. Nasali Goretti, a surgeon at Nagalama Hospital and a lecturer with Uganda Martyrs University, Mother Kevin Postgraduate Medical School.
Good morning, I'm Olive Kobsinje. I'm an injury epidemiologist. I'm the board chair of the International Road Traffic Injuries Research Network. Yeah. A surgeon.
Yes, morning. I'm Patrick Chamanywa, Professor of Surgery, now a student of Global Health and Vice Chancellor at Uganda Martyrs University. Pleased to be here.
Stephen Kijambu, retired plastic surgeon, but I have the best of company in this room. I have a Vice Chancellor on my left and a Chancellor on my right.
Good morning, ladies and gentlemen. I have the pleasure of sitting near my boss. It was, like you all know, was chair of the Department of Surgery, Makerere University for some time. I'm Moses Galukane, President-elect for Asou.
I'm sitting in front of the chancellors and in front of the first plastic surgeon in this country. My name is Rosa Lenya. I'm a plastic and burn surgeon.
Thank you so much for the introductions. The people on the front row are our special guests, so we will introduce them when the time comes. I'm going to, next on the program is...
Just a few people haven't introduced themselves.
I think we might have to move on because men are still walking in. Christine is actually the next on the program. She's the chair of the scientific committee of this event. So I want to welcome her to the podium so that she can give her remarks alongside, they have been working alongside with Professor Moses Galukande. So Christine, kindly come to the podium, and you will also take the pleasure of introducing the guests you invited for this event.
Thank you, General Secretary. Good morning, everyone. You're almost welcome. We are very happy to have you. I would like to start by welcoming our special guests, our keynote speakers, and our guest speakers. We have Professor Gregory Bellman from the University of Minnesota. Please, you're most welcome. We have Dr. Richard Jennifer from the University of Minnesota as well. You're most welcome. The two landed last night at 10:40 p.m. So on my right, we have Professor Salome Masimwe from the University of Cape Town. Please, you're most welcome. Their detailed profiles will be given by the session chairs that will be presenting them during the different sessions. I would also like to take the pleasure to introduce and welcome the scientific committee to the podium. I'm sure they don't want this, but kindly, I had the pleasure of serving with these, allow me to call them amazing, resilient, geniuses that have cooked up this thing for these 2 years. We had the pleasure of hosting the last scientific conference, that was 2023, and the one for this year. So please allow me to welcome Professor Patrick Chamanywa, the Vice Chancellor of Uganda Matters University. Please allow me call you to the podium so that we can have a photo for the scientific committee for 2023 and 2024. Yes, please. Next to him is Professor Moses Galukande, the Chancellor, Clark International University, and Chair, Department of Surgery, Makerere University. Next to him is Dr. Flavia Luwede. He's based in the East at Soroti University. He's a lecturer there. Next to him is our General Secretary, Dr. Kakungulu Edward. He's based at Uganda Cancer Institute. And next to him is Dr. Rosa Lenyo, the burns and plastics surgeon. He's based at Chirudu National Referral Hospital. And in absentia, I would introduce Dr. Victor Chigonya. He's our publicity secretary. And Professor Sebufo Robinson is based at Mengo Hospital. So kindly, let's put together our hands and thank the scientific committee. So without taking a lot of time, I would like to welcome us all to the 2024 Asou Surgical Landscape Exhibition, the Scientific Conference, the Charazi Memorial Lecture, the AGM, and a gala. I hope you'll all stay through all those sessions. It's an honor to convene an esteemed gathering. Together with the Scientific Committee, we are pleased to present this year's conference theme, Advancing Access to Safe, Affordable, and Timely Surgical Care. This theme underscores our commitment to promoting global surgery in Uganda and fostering collaborations with all international surgical initiatives. And that was one of our pushes to having this conference, is to engage all local and as well as international initiatives. The primary objectives of this conference were to promote multidisciplinary network, and that's why you would see within our congregation we have different people who offer services to us. We have anesthesia, we have the biomedical engineers, we have health epidemiologists and all that. So we wanted to have this in this conference. We also wanted to disseminate knowledge on advances in the various fields of surgery. The exhibition is majorly to showcase the diverse range of surgical services that are offered in the country and the new innovations that people have. As you've seen in our highlight, we keep quiet about this and we don't share what we do. So I think everyone now knows we really need to share what we do and also increase awareness in our public. And central to our mission was promoting the multidisciplinary approach, which I've mentioned, and we recognize the invaluable contributions from all the disciplines, like nursing, anesthesia, laboratory and diagnostics, radiology, and public health, both in the private and the public sector. This conference serves as a platform to reinforce and promote collaboration among all these stakeholders, ultimately advancing access to safe, affordable, and timely surgical care. We extend our heartfelt appreciation to the Ministry of Health, who have been our partners in this, and Smile Train in organizing these events. And this collaborative effort brings together healthcare leaders, clinicians, academicians, scientists, policymakers, and private sector players. And this exhibition was open to the general public, and we were happy to even see some school-going children actually attend the exhibition yesterday. It was quite amazing. So I would like to...
Thank you so much, Dr. Namugenyi Christine. Dr. Namugenyi has left me a big task and a pressure. You see, these days we move with our heads high up in the sky. We keep we keep all the how should I say it? We are honored as Uganda to have the president of the College of Surgeons of East Central and Southern Africa to walk among us every day. Not many people have this pleasure. So I'm proud to introduce Dr. Fualal Jane Odubo. in the many years of ASEA and COSEXA, I think Uganda has had only 3 presidents. Professor Maswa, Professor Mutiaba, and Miss Jane Fualal, and only 1 female president. So we are very glad to have her here today. So it's my pleasure still to invite the president of the Association of Surgeons of Uganda, Associate Professor Frank Asimwe, to give us his welcome remarks. Professor, you're welcome.
Good morning, ladies and gentlemen. It's a good day, a cold day, and because of that, we have a few issues of delayed start. And because of that, I'm going to be extremely brief. Regarding the delayed start in Uganda and a big chunk of Africa, when it rains, there is a problem. When it is too hot, there is a problem. I think when you reach a point when it does not matter, when you can say, come rain or shine, this is going to happen, that's when we will have achieved some bit of progress. So on behalf of those who came late, I would like to apologize to those who were on time and promise that we'll do better next time. Distinguished surgeons, our visitors, you're most welcome to Uganda. You are most welcome to the Asou Scientific Conference. This group of activities started yesterday with a landscape. You know, it's a new thing. We have to get used to how to say it. The surgical landscape, like an artist painting, the surgical landscape exhibition. We're having issues with the speeches. The speech I wrote yesterday is relevant today, and the speech for today is relevant for tomorrow. So we must be very malleable. But we thank the committees which have given us all these opportunities, this tapestry in which to shine. But the activities began yesterday with a surgical landscape exhibition. As has been said, and as was said yesterday, we're trying to showcase what Uganda does in the theaters, which some of us don't know. I don't know what happens in plastics. I was told of tummy tucks and the otolaryngologists, cochlear implants, the whole tapestry. Today, we are concentrating on the science. And then tomorrow, a little more science and the annual general meeting, which is an election annual general meeting. But today we're concentrating on the science, and I don't want to spend a lot of time talking about that. I just want to say that the difference between me and my grandfather used to practice medicine. I don't know whether to call it medicine or something. Actually, he used to take care of people with prostate issues. Interestingly, but I never got his concoction. Maybe it just came in the blood. My mother used to take care of women who were having issues with delivery. It is also said she used to sort out people who were having children of one sex. You know, that's also a problem in Africa. Girls. She was about to fail to sort herself out. She popped 5 girls and only 2 of us. So she used to handle those things, and so on and so forth. The big difference between us who practice medicine now and them is science, period. Evidence-based, peer-reviewed science. And that is why we are here. The moment we lose focus on that, we are nothing less than the traditional birth attendants, the traditional practitioners, the ones who move by hunch, the ones who say, this medicine works. But what is the evidence? That is why we're here. And that's why we want to thank the scientific committee for putting together the topics, gathering all of us who are going to present. And that's why I would beseech those who are on their way, if they can hear me, and those who are delaying to come, please come and listen to the evidence-based science of the practice of medicine, which if we lose focus of, then we are practicing traditional medicine or something else. So please let us sit, listen in, ask questions, and see what science is happening in Uganda. I thank you, and I welcome all of you to the scientific conference.
Thank you, Mr. President. We are going to start with, we're going to have a slight modification in our program. When you look at your abstract books, so those ones who have the digital version of it on your devices, we are going to start with session 3 that looks at advancing access to surgical care. So I'd like to invite Dr. Muhozi Rwakariebe Mbaga in front to take over the moderation of this session. Dr. Muhozi, you are welcome.
Thank you very much, General Secretary. The session that I'm chairing is going to have interesting speakers, and I'll take this opportunity to invite our first speaker, who will present assessing prioritization of surgical, obstetric, trauma, and anesthesia, SOTA care in Uganda. Uganda's health policy documents, a bibliometric analysis, Dr. Brian Kasaga. Dr. Brian Kasaga is a focused senior house officer and a promising young surgeon. Dr. Brian, please welcome.
Yes, good morning, everyone. I'm very happy to be here, and I take this opportunity to welcome everyone here to the conference. And as the moderator said, my name is Dr. Kasaga Brian. I am the Chief Resident of the General Surgery Training Program at Makerere University. I also happen to be the Research Chair of Incision Uganda. It's a national working group for global surgery. So where we have a group of residents and medical students interested in global surgery. I also happen to be the SUGES, that is the Society of Uganda Gastrointestinal and Endoscopic Surgeons. I'm the SUGES affiliate lead, and what we do, we try to educate and also promote advocacy for enhancing minimal access surgery and endoscopy in Uganda. So I'm very happy to present, to be the first presenter today. And okay, maybe some technical glitch. Okay, it's up and running. Thank you. So I'm presenting today a topic on assessing the prioritization of surgery, obstetrics, trauma, and anesthesia care in Uganda's policy documents. So as a surgery resident, currently in year 2, I remember very recently when I was at home on Christmas evening, I was having my meal with my mother. So I was called at casualty. So this is a common story. I'm just giving one of them. I was called at casualty for a 14-year-old who had had a road traffic accident. And this child was in a very bad state. So I had to quickly finish up my meal and get a border and rush to casualty. That's the emergency department of Mulago. So when I reached casualty, the child, of course, wasn't well, was hypotensive. So we had to start running fluids, took off blood for labs, and started working them up. And it was apparent that this child had a perforation. So as we were trying to prepare for theater, we were trying to look for blood, which wasn't available at the moment. And also when we tried to contact the theater, we did not have sutures, we did not have some anesthesia drugs, we even didn't have gowns. So this is a mother who had traveled from Luero, about 100 kilometers from Kampala. They did not have any sundries to use. So we had to tell these facts to the parent, and at the moment they did not have money. So it took another 3 hours to call their relatives, many of them, to raise around 200,000 to buy these sundries. So in that time, this child actually became worse, but thank God, when we went in, we worked on the child and they improved. So this is one of the many stories. And as a surgery resident, as I hope to become a surgeon, so I asked myself, how are we going to reverse this trend? So, and I believe that as a resident, when I become a surgeon, it's not all about operating, so we also need to work outside of the theater to try and advocate for different things in the surgical landscape, especially increasing the materials that we use in surgery and so on. And that prompted me and my fellow medical students and residents to carry out a project like this one. So we are all aware about the Lancet Commission on Global Surgery. It was in 2015 that highlighted the stark disparities in surgical access. Around 5 billion people having no access or limited access to surgery. So, and of course, Uganda is one of the countries, the LMIC, so where we have limited access to surgery. So, and actually, the same paper projects that there will be an anticipated rise in the burden of surgical conditions. And of course, countries like Uganda and other LMICs disproportionately bear this brunt. And of course, advice from this paper and of course other papers, they suggest trying to put surgery on the forefront in trying to push it and such that it is covered under universal health coverage, and also for the individual countries to kind of make national surgical plans to address these burdens. So, Uganda last year, we had an opening, the first workshop of the ENSO plan, and the process is still ongoing. But as we are making an ENSO plan, we need to know where we are currently. So as we embark on this process, we don't know how our policies in Uganda, key decision documents, how do they prioritize surgery? So the objective of our study, our group, was to determine the prioritization of surgery, obstetrics, trauma, and anesthesia care in Uganda's policy documents. So what we did, this is part of a bigger project that we are doing, and I'm sharing part of the results. So in this project, we only looked at Ministry of Health documents, but of course we know that there are other players in health, development partners and so on. So we did a bibliometric analysis, and we looked at, we identified keywords that refer to surgery, obstetrics, trauma, and anesthesia in these policy documents. And also for comparison, we looked at the non-surgical keywords. So we compare the two groups, and after that, the surgical mentions were also categorized within the domains of the health system, that is surgery, workforce governance, information systems, and so on. So we kind of expressed the results in quantitatively, and we also did some kind of a mini thematic analysis by looking at the documents that talked about any component of surgery, what aspect of surgery is talked about. Is it something to do with workforce? Is it something to do with information systems or service delivery and so on? So our inclusion criteria, so we included key decision-making documents. So for this presentation, we included strategies, strategic plans, policies, guidelines, and roadmaps that are available on the Ministry of Health. There is a portal of Ministry of Health that has all these documents. And only documents were available, full text were included, and we excluded those ones which were acts and documents which were incomplete. So that is a flowchart of what we did. So, of course, the stakeholders in health, there are many. We only included Ministry of Health. The others, like academia, development partners, we did not look at them in this study. Then we looked at the decision-making documents. We looked at the policies, strategies, guidelines, roadmaps. And once we collected all these documents, we found some of these documents were acts, and some of them had missing data, so we had to remove them. So in the end, we remained with around 64 documents. So as I said, we compared surgical keywords and non-surgical keywords. For the surgical keywords, for example, when you talk about surgery, we looked for anything to do with surgery by finding, we found within these documents, we type and find for keywords like surgery. For cesarean section, we use synonyms like C-section, cesarean. For injury, we looked at trauma, fall, and so on. Then for comparison, for the non-surgical keywords, for example, for HIV, we looked at synonyms like HIV, AIDS, and so on. For TB, we looked at TB, tuberculosis, malaria. Child health, we looked at child immunization, and so on. So for the results, we found that for all the surgical terms, we found a total of around 2,361 mentions, whereas for the non-surgical terms, we had about 9,791 mentions of non-surgical terms. So it is actually 4 times, non-surgical items were 4 times more common than the surgical items. And also markedly, in the titles of these documents, 18% of them contain non-surgical keywords, but we didn't find any document that contains specifically anything to do with a surgical keywords. So again, as we categorize them, as you can see in that graph. So for example, the mentions of anesthesia were 273. For example, we looked at cancer, around 565, burns, around 116. So the ones in red are the surgical ones, while the ones in blue, malaria, you can see the numbers are going beyond 1,000. And of course, as we also looked at those ones that were measuring surgery, obstetric, and anesthesia, we also tried to characterize them into the domains of the health system. So most of the surgical mentions were concentrated around service delivery, that's around approximately 50%. Infrastructure and workforce were around 12% and around 15% respectively, and the lowest were governance and financing. So for the implications of this study, as you can see that from these key decision documents, we see that surgery, obstetrics, trauma, and anesthesia, there is lack of emphasis on these aspects in these key documents compared to the non-surgical fields. And of particular attention, we found very few documents talking about the surgical health workforce, and we are well aware that from the Lancet paper, they recommended some key indicators, like for example, the surgical workforce of around 20 per 100,000, but for Uganda, it's about 1.05 for every 100,000. So there are very few documents that are talking about improving health surgical workforce. In addition, there are also very few documents talking about financing. So most of the documents we are talking about implementation of budgets for different non-surgical terms like malaria, HIV, and so on. So the implication of this is that because you have a lesser focus on surgical items, of course the funding is going to be reduced in that line. So, and therefore, it is imperative that in Uganda, we develop holistic policies and plans that incorporate surgical care as an integral component of universal health coverage. And also, again, most of these policies had a siloed approach that they focus on specific diseases, but we think that maybe for policies that are maybe plans and documents talking about, for example, child health or maybe HIV, you can also incorporate other surgical items like talking about safe male circumcision for HIV prevention, or for example, there are a lot of documents about non-communicable diseases, but there was little mention about cancer, so which is one of the non-communicable diseases on the rise. So by improving or prioritizing SOTA care and incorporating either surgery, obstetric trauma and anesthesia care in policy documents and existing framework, Ugandan can take significant strides towards improving access to surgery, to access to safe, affordable and timely surgical care for all its citizens. And limitations of this study was maybe the keywords were used may not fully depict the prioritization actually. It just gives, it's kind of a proxy. It's not accurate, but it gives an idea. And we did not include documents that were not available online. So the next steps, we are doing a larger study, a scoping review that is also incorporating other key players in health. I want to acknowledge my SOTA team, especially my mentors, Dr. Ilobu Emmanuel, Dr. Nabukenya Mary, Dr. Mutatina Boniface, and Dr. Ekwaro Buku, and my other colleagues, the residents and students. Thank you so much for listening to me.
Our next speaker is going to be an online speaker. He's going to take us through an interesting topic exploring the global pediatric cardiac surgery workforce and the global burden of congenital heart disease. Dr. Jevan Francis has got an interest in congenital heart surgery, and he's currently working on research in the global burden of congenital heart surgery. He will be presenting online. Hope the IT support is on. Thank you. Welcome, Dr. Jevan.
Good morning. Can everyone hear me?
Yes, we can.
Hello, hi, my name is Jevan Francis. I'm a doctor working in Scotland and UK. And today I wanted to speak about the global pediatric cardiac surgical workforce and the global burden of congenital heart disease. So, to give a bit of a background, 28% of all major congenital abnormalities are heart defects. And of these, over 200,000 children die each year globally, and most of these deaths take place in low middle income countries. Given the mortality rate, 66% of all CHD related deaths are preventable with better access to surgical care, with around 70% of children born with CHD care requiring medical or surgical treatment within the first year of their life. In terms of equity to access, 90% of children in LMICs lack access to treatments they require or receive suboptimal treatment as a result of resource limitations. This is for a population for just over 6.4 billion people. Each year, over 300 million operations are performed globally, but only 6% of these operations take place in the poorest 1/3 of the world's populations. These figures highlight some of the social injustice patients face in low-income countries. So, the overall objectives of the study were, number one, create a global registry of pediatric cardiac surgeons. Number two, ascertain the number of surgeons available in each country and World Bank region. And number three, conduct a scoping review to understand some of the discrepancies in service provision for congenital heart disease in high-income countries and low-income countries. We explored this issue for two reasons. A, quantify the discrepancy in the availability of trained personnel, and B, think about how we can bridge the gap in congenital cardiac surgery at a global scale. The fundamental issue here is how can we deliver quality care for the average child living with heart disease, living in a resource-constrained environment. So, Cardiothoracic Surgery Net, or CTSNet, was searched in 2021 to look up all congenital cardiac surgeons that were registered on the website. This included surgeons who operated on adult and congenital patients or those who operated on congenital patients exclusively. Data including their name, email, sex, center, and if the surgeon operated on congenital patients exclusively was extrapolated. We tried to validate the CTSNet data by contacting as many individual health boards as possible. We then use the World Bank data to classify each country into the appropriate income group and to ascertain the country population. A scoping review was conducted later to provide context in such disparities. So what do we find? Our findings showed that there were 12,180 adult cardiac surgeons registered in CTSNet. Of those, 33% operated on congenital patients, 93.4% were males, and only 6.6% were females. Of the surgeons who operated on congenital patients, only a quarter of them operated on congenital patients exclusively, of which over 75% resided in high-income countries or upper middle-income countries. So we made a heat map to demonstrate the number of pediatric cardiac surgeons per country per million people. We found that low-income countries have only 0.03 pediatric cardiac surgeons per million people, compared to 1.67 pediatric cardiac surgeons per million people in high-income countries. To give a few examples, the US has 278 surgeons for 332 million people, whereas Guatemala has 1 surgeon for a population of 55 million people. Looking at this data, we must ask, what is the meaning of having over 400 pediatric cardiac surgeons in North America, but only 20 in sub-Saharan Africa? We found that although the prevalence of CHD is very similar between low middle-income countries and high-income countries, which is around 0.8% of all births, most deaths, and again largely preventable, were occurring in low middle-income countries. The critical factor between these two World Bank regions were the number of surgical teams available, and this table illustrates this a bit more. Sub-Saharan Africa had roughly 0.08 pediatric heart surgeons per million population, compared to 2.08 pediatric heart surgeons per million people in the US. Important points to highlight include the fact that 47% of Sub-Saharan Africa is under the age of 15. Excluding South Africa, this works to roughly 1 surgeon for 38 million people under the age of 15. We found a 55-fold increase in the number of pediatric cardiac surgeons available in high-income countries compared to low-income countries. Finally, we conducted a scoping review to comprehend why some of these differences exist. We found that although the prevalence of CHD is very similar between low middle-income countries and high-income countries, most deaths were occurring in LMICs. Due to socioeconomic constraints in LMICs, CHD services are often grouped in tertiary or quaternary centers, which means they're only available in specific locations. We found that CHD care have largely been left to NGOs to address. This is because of the challenges surrounding cost, technology, availability of trained personnel, and the expertise required to effect change. In LMICs, most CHD cases are not diagnosed before birth, owing to a lack of antenatal screening. Early diagnosis of simple lesions could result in early referral and treatment before the onset of irreversible sequelae, as over 70% of CHD cases require medical or surgical treatment within the first year of life. In LICs, many patients travel to neighboring countries for surgical care. For example, in the Pacific region, island nations spend between 4 to 12% of their total health budget on sending patients with rheumatic heart disease to other countries for the surgery. And the main limiting factor we found were the lack of resources and personnel. Studies showed positive correlation between mortality rates and the number of congenital cardiac surgeons available in their country. Again, this is not just limited to surgeons, but other members of the multidisciplinary team, including anaesthetists, perfusionists, nurses, and critical care staff. So where do we go from here? Firstly, there exists a moral axiom for providing surgical care to low middle-income countries. To heal should have no borders. Current inequalities, conflicts, and disasters continue to disadvantage those living in the poorest of countries. The right to health is a global issue, and the cost of not doing anything is too catastrophic. There needs to be a paradigm shift in thinking from humanitarian surgery to global cardiac surgery. We must acknowledge global cardiac surgery is a two-way street. Education and research can be performed in a more global framework. High-income countries can benefit from understanding how LICs provide surgical care cost-effectively, providing real-world data on choice of clinical strategy and improving overall service delivery. We need more collaborative research. There are currently no structured, evidence-based recommendations for the development of quality pediatric CHD care in resource-limited settings. There are very few open-sharing international databases which provide real-world data on the number of operations performed in LICs. To give an example, the IQIC collected data from over 100,000 operations with 64 participating hospitals worldwide. Through weekly education webinars and structured classes, this improved post-operative outcomes and reduced mortality significantly. Finally, with the globalization of the pediatric cardiac surgical workforce, globally coordinated training programs, including those in low middle income countries, will enable the next generation of global surgeons to understand the disease process in a broad spectrum of patients and support research development. In light of recent technological advancements, virtual multidisciplinary team meetings, online training, simulation training, and online mentorship will allow for a truly global training curriculum. Future research should look into quantifying pediatric cardiac surgical trainees to plan long-term and prevent serious healthcare shortages. A truly global pediatric cardiac surgical workforce will allow us to bridge the gap for CHD care between high-income countries and low-income countries. Thank you.
Dr. Olive Kobsinje, consultant trauma surgeon and injury epidemiologist, senior research fellow, Makerere University School of Public Health, and the Institute of Social and Health Sciences of University of South Africa, head of trial project, Makerere University. You are most welcome, Dr. Kobsinje, to take us through the changing role of surgeons in healthcare. Most welcome.
Thank you very much. I almost didn't recognize myself from that intro. So I am going to attempt to do in 10 minutes what I would probably need an hour to do properly. So the practice of surgery is as old as the hills. As long as there have been people on this earth, there's been need for surgical intervention. And most ancient civilizations recorded birth defects that likely required surgery and difficulties in childbirth that called for surgical remedies. But today, a surgeon occupies a different space altogether. While cutting was synonymous with the practice of surgery, today's surgeon might not use a knife, a scalpel. And terminology that was a permanent fixture on the surgeon's notes, such as opening, closing, find themselves redundant in a lot of surgical procedures today. So some surgeons might spend more time outside of the operating room, bringing into question the old assumption that the surgeon's place is in the operating room. So do we need to redefine the role of surgeons? Do we need to redraw the boundaries? Is the field of surgery attracting the right type of individual to fit into today's role? How will yesterday's great surgeons provide appropriate inspiration for students who will work in a space and use equipment that their role models never saw, never used? The surgical community needs to acknowledge and address these questions in order to move the field forward with humility, with confidence, and with wonder. So this goes forward. Perfect. Okay, thank you very much. So I'd like to begin from the beginning. So most people that performed surgery at the beginning were not even surgeons. They were called barber surgeons. Yes, so the person that cut your hair would also do an amputation if you needed one, which is the reason why British trained surgeons were called Mr. instead of Doctor, because they actually were not doctors. And so from this crop of barber surgeons, a good example is Ambroise Paré, who lived between 1510 and 1590. And he accidentally stumbled on ligatures for amputations. So at that time, hot oil and hot irons were used for hemostasis in amputations. And so one day he found himself with a patient that needed an amputation, and he didn't have hot oil handy. And so frantically he was looking for something, and he improvised by pulling threads out of his jacket. And after he tied the threads, the bleeding vessels, he applied a gauze dressing. And to his amazement, that patient did much better than the patients that he'd done previously with the hot oil. So he became the father of modern amputations, and he actually wrote his work, published it in what he called the Treatise on Surgery in 1564. Another one of his contemporaries, Andreas Vesalius, published De Humani Corporis Fabrica, or On the Fabric of the Human Body. He was the first person to publish an anatomy textbook that had illustrations in it. Prior to that, all anatomy students had to use just text. And in fact, before that, the human dissections had been illegal, so they hadn't been able to do any human dissections. So this was really a huge deal, this textbook that was published in at that time. But maybe somebody that might be more familiar is Dr. William Halstead, who comes centuries later and is very associated with Johns Hopkins University. It's said that scrub suits and sterile gloves began in his operating rooms. And other principles included gentle handling of tissues, scrupulous hemostasis, tension-free closures, crash-free dissections, and all of these things that we sort of assume, take for granted today. Other work that he did as a pioneer was in the proper surgical treatment of hernias. So people actually crossing North America to come and find him. Breast cancer, gallbladder disease, all of this. But he's actually probably best known for having worked on the first structured residency program at Johns Hopkins that was used as a blueprint for training surgeons elsewhere in North America. So these kinds of innovations and discoveries were not limited to North America or Europe. Actually, this is work that was witnessed in 1879 in Uganda, where they were doing cesarean sections at the time. And by the time we come along, nobody else knows how to do cesarean sections except those of us that have gone through medical schools. So I'd like to highlight a few other people. This is Dr. Charles Drew, who graduated in 1933 from McGill, and he paved the way for blood banks by his work on blood preservation and separation techniques. A lot of the things that we've taken for granted around transfusions actually originated with him. He was a surgeon, but he was also a scientist that was researching blood and how to separate it, preserve it, and so on and so forth. Another one that I'd like to talk about, some of you might have come across this guy who had a 70-plus year-long career. And in 1932, he devised a roller pump, which was essential for the heart-lung machine that permitted open-heart surgery. So if you're in cardiology, cardiothoracic, you're using this man's work. He developed an efficient method for correcting aortic aneurysms by grafting frozen blood vessels. And in 1953, he performed the first successful carotid endarterectomy, laying the ground for surgery for stroke. These were all people that worked with far less than we have today, but they did amazing things. So here is for the ladies. Dr. Myra Logan graduated from New York Medical College in 1933. In 1943, he became the first woman to perform heart surgery, and at that time, it was the 9th such operation. She developed new antibiotics, she worked on early methods of detection for breast cancer and how to treat it. Another lady is Jane Wright. So Dr. Jane Wright, in 1940, she graduated with honors in 1945. In 1949, she was at the Cancer Research Foundation, and she later became director of the cancer chemotherapy research at New York University Medical Center. Again, a brilliant scientist who performed trials and tested new chemicals on human leukemias and cancers of the lymphatic system. Let's go to this guy, Dr. Kunz. He graduated in 58, so much more recently, he was a pioneer in renal transplantation. In 1961, he and a colleague were the first to perform a successful kidney transplant between two people that were not twins. Prior to that, the science had only allowed twins to donate. So he performed some 500 kidney transplants throughout his career, which was believed to be the most of any physician at his time. Now, his research led to significant advancements in preventing and monitoring renal allograft rejection, along with donor tissue typing, preservation of donor kidneys, and so on and so forth. So a lot of the work that is currently taken for granted that is used in renal transplantation was a result of this brilliant surgeon that didn't just stay in the OR, but did a lot of work in the labs to develop all this. Let's come much closer to home. Professor Sebastian Chalwazi, 1920s through 1992. He did a lot of pioneering work on hepatocellular carcinoma, Burkitt's lymphoma, penile cancer, Kaposi sarcoma, and so on. And his role was pivotal in setting up the Ugandan Cancer Institute. So, my 10 minutes are nearly done. So this is a quote from this other guy, Michael DeBarkey, who said that the natural history of science is a study of the unknown. If you fear it, you're not going to study it, and you're not going to make progress. So we think about our role as surgeons. This is where I started. Now, if we limit ourselves to repeating what's been handed down to us, no matter how meticulously we do it, no matter how many patients we treat with these established methods, we do ourselves and our patients a disservice. And the improvement of what's known or the discovery of what's unknown is not the duty of some other people somewhere else. So let's not settle for the technician role, grand as it might be. Let us also become the teacher, the educator, the innovator, the scientist, the researcher, the patient advocate. All these are our roles as surgeons. And if a barber could discover ligatures in the 1500s, I think we can do better. Thank you.
Thank you very much, Dr. Kupsinja. Interesting when speakers actually do respect time and you don't have to hustle telling them 3 or 5 minutes. Thank you very much. Our next speaker, let me take this opportunity to invite Professor Patrick Chamanywa, Professor of Surgery, a mentor, a role model, a champion and leader in healthcare, the current Chancellor of the Uganda Matters University in Kozi. Professor Chamanywa will take us through the future surgeon robotics, omits artificial intelligence, big data, and green surgery. Most welcome, Professor.
I think he's raising expectations. Yeah, good morning to you all. Yes, I've been given this very difficult task to be the one to talk about the future surgeon. And it's interesting that the previous speaker has taken us through the history. So knowing where we are, what does the future hold? And indeed, next slide, please. Or do I have it here? Okay, and indeed, this is where we are. This is the today and the future. I think we are now living in the future. Those of you who watched James Bond 007, and I'm sure my senior, Professor Kijambo, has fond memories. Most of the things we saw in the James Bond films looked very futuristic, very out of this world. Today, the future arrives faster than we expected. And most of these are now reality. So that's where we are today. And of course, we live in an era where there is personalized patient care. And this is why this topic is important. All the advances that we see are moving to how best can I treat Kyamanywa if he presents with the same disease as Galukande? Because the two are not the same, although the disease could appear the same. So that is what brings us to this. And so they are all interconnected, as I will soon be showing you. And indeed, that is where we are going. And of course, outcomes and efficiency of systems is another thing that is driving this. Why should I spend so many cycles of whatever chemotherapy on an individual who will not respond just because another one responded? Those are the things we are looking at. So you waste money, you waste the patient's life, actually, without moving forward. So let us try and digest each of these. And of course, it all begins with big data. And what's big data? It's just looking at the volume of data that is available that can no longer be easily analyzed by a single statistical tool or a simple computer. And that is all about it. But really, there is a data explosion today. The amount of data we generate even from a single operation, look at all the tubes you've connected to this patient, they are all generating data. You know, you want the minute or even second by second oxygen saturation in the blood. You want the minute by minute ventilation. You want the minute by minute fluid flow. All that is data that is supposed to be helping us come up with different things. And of course, this data is covering populations, it's covering individuals, it's covering systems, processes. All that data is being developed, but how do we use it? And that's where the future surgeon will have a role, as we shall see in the subsequent slides. And of course, now a gentleman called Zhao, in a recent publication, has coined that concept of sagomics. Just looking at the interoperativity of that data that we are collecting and how we can then use it to inform further development, like machine learning and so on. There's also an argument that probably the surgeon is working only in theater, but we should start looking at a surgical informatician. Someone who just studies surgical information and helps us integrate it in systems, in algorithms, and so on. Not only the surgeon who has a scalpel in hand. So we need to start looking at that aspect. And the data we collect sometimes is random, but actually should have some characteristics, because data to be useful has to be intentionally collected. That's when you can later run back. But of course, we know that there is a huge volume of it being created. But if we do not have the variety taken into consideration, many of you are now changing your HMIS systems in your private hospitals, clinics, just because you thought only of one element and the person developed it. Now you're asking more questions and you find the system can no longer work for you. That's because of the variety of data that you now realize you have to collect. So every system should therefore be upgradable if we are to get useful data. The data should have value to us, and of course it should be valid, the veracity of it. Can we trust the data? Or are we not able to trust the data? And of course, there should be the velocity, that is the speed of acquisition, but also the speed of access and use. When you want to draw on something, The previous speaker, actually the first speaker, told us they were unable to find some information online. That means that data is not useful to the wider community. It is stuck in a shelf somewhere, maybe at the ministry desk. It's not useful. So it has to be accessible, it has to be quickly accessed. And that's why the big data movement has come up with the concept of fair data. Fair data meaning it must be findable. When I need it, I should be able to find it. It must be accessible. That's why these days we are getting open access and all those things coming through. It's just to make this data accessible to those who want to use it. So everyone is now going into the Creative Commons and so on to make their data accessible. Of course, it must be interoperable, meaning it should be able to serve more than one purpose. If I want to design a robot, can your data help me? If I want to design an algorithm, can it help me? Can the anesthesiologists use it? Can the epidemiologists find it useful? And of course, it should be reusable, which means it remains current. Unfortunately, the systematic review you see there by Knight and others shows us we are not doing enough in LMICs and worse still in Africa. Most of our research is on the short outcomes of surgery. Nearly everyone here has done short outcome of this for their M-Med and so on. But that's not good enough. We need longitudinal studies. We need studies that capture data over a prolonged period. That's when you can work out a pattern and start asking deeper questions. So there is almost no data on the topic of this AGM, access. Access. We are here talking about access and so on. Everyone will sing about it, but we are not actually measuring it. So how can we then have policies relevant to it and others? So we need more data. Of course, with the big data, then we are able to move into artificial intelligence because it relies on data. Algorithms are rising out of data patterns. And the surgeon cannot distance themselves from this anymore. There is a lot of virtual and augmented reality in surgical performance. When you are planning, for example, a transplant, I hope that our president can now first simulate the transplant and then go in. Or do we run in believing we shall find something? So in good practices, you should first simulate. You have the patient characteristics, you simulate because you've captured data. And that is where surgical practice is going, ladies and gentlemen. So in the preoperative, you need it. How do you assess the patient? What population? These days we are using data that is developed in Caucasian race for the African race. Are you sure it translates to the same? Then you say, but no, in India they are using this. Maybe who has said it will work in Africa? So those are the things in the preoperative. Of course, in the intraoperative, there is always a lot in artificial intelligence. Some of the procedures are now automated. Those of you who, again, I will try to come back to the president. Prostatectomy, especially for CA prostate with radiotherapy, the so-called cyberknife treatment, is actually robotics using artificial intelligence. It has been told how to identify and zero in. It twists, when you change, it changes with you, and that is using data and artificial intelligence. And then, of course, in the post-op period, it becomes very important as well. So with data and artificial intelligence, you are then able to develop robots.
3 minutes, Prof.
you are able to develop robots, because that's when you teach them to do certain things. And robotics is here with us. And of course, it offers great advantage. It started off in 1985 with a robot that later was used, and then very quickly we saw the ADAVNCING, which has now become a commonplace in our surgery. And there are many benefits, of course, but the cost is still the outstanding hindrance. Then the omics. Many of you could have asked yourself, what is omics? Omics it's just using the last 5 letters of all the biological issues in there. So phenotype, you move to the genetics, and these are useful in the pre-operative phase, in the prognostication, in the treatment. These days, people are looking at, for example, PSA, you are looking at the HER2, you are looking at, all these are coming out of analysis of different components. And here we see these components. So when you look at the DNA, then you are starting to look at the genomics. You go on to the RNA, you are trying to look at the transcriptomics. We even target treatment to the protein and even to the metabolites. And that's where the surgical practice is going, not just the scalpel. If we are to individualize care, we have to take on these things. And you will believe me when I say that we cannot run away from the climate change. Many of you in the last few weeks were exchanging temperatures, ambient temperatures, wherever you are. That is a reality today. But sad to it is that surgery is a big contributor. Just to step into, well, our setting might not be the best example, but step into a North American theater, scrub up, and then wait for the volume of disposable material that will come after that operation. You will be amazed. It can feel a pickup. Tubes, clothes, and so on. So there is now a discussion on green surgery. How can we make surgery more responsive to the environment without contributing? And statistics is showing that health systems contribute 4.4% of global emissions compared to the aviation industry, which has 2.5%. And a typical operation will give you the worth of carbon dioxide emission of a 450-mile journey in a poorly maintained petrol car, which is common. So we are now having to swing from the reusable, where we were first, to the disposable, which had become fashion, and now we are going back to the reusable. Okay? When you pull off all those disposables, you're actually contributing. So now we need to go back and sterilize. We know now better ways of sterilizing with nanotechnology. We don't use a lot of water. When you are scrubbing and you have 3, 4 cases in a day, the first scrub is all you need for the first patient. The subsequent patients, you should be using alcohol, disinfectant, instead of running 44 liters of water just for a second scrub. Those are the things we should be looking at. When you have the cables, reuse them. So when you look at this, you can see the surgeon's carbon footprint. Unnecessary investigations. Must everyone get a CT scan before you operate? Must everyone go for an MRI? You know? When you go in, how are the linens and disposables? When you look at the carbon dioxide we insufflate in laparoscopy, can we do it Can we do some operations with no insufflation? And so there is a checklist that looks at all these things, which I would invite you to look at, but it considers the anesthesia, the preparation phase for the surgery, the intraoperative phase, and the postoperative. And it has been put forward by the Intercollegiate Green Theatre Checklist in the UK. So, to summarize, what are the implications of this? First is the education. Our curricula, I read recently that Makerere was not to admit surgeons. They need to first review the curricula. I think these are things we should put in our curricula. Does our curriculum in surgery actually ask the resident to understand statistics, to understand data? Do they graduate with competence in laparoscopy, or we still want them to split the abdominal wall with a scalpel in layers and so on? Is that still what we are teaching, or are we transitioning? When you look at ourselves as practitioners, are we ready to get those training opportunities, which I think is important? Then, of course, the research. We might still be researching on things that are for the 20th century and not informing the 21st century practice. So when we are looking at the research we are interested in, it should be in the right direction. The practice should change, but most important, also the policies, the health financing policies, because as we advance, access becomes a tricky issue, and we have to be intentional about it. How many will afford robotic surgery? How many will afford all the advances, the transplants we are talking about, and so on? And therefore, even the infrastructure. Recently, we had a refashioning of Mulago, but I'm not sure it was refashioned for the 21st century. It was just for beauty. And of course, our chairman had his theater redone at some point to be able to suit a transplant. Yet this is what should have been assumed already. So those are the implications of this topic, and I thank you for your attention.
Thank you very much, Professor. Our next speaker would have been Dr. Michael Kecho, though it happened that he had to rush into a case and asked me to go through his presentation, which is in line of what I do practice, basically cardiac surgery in Uganda. I promise I will use less than 8 minutes, and if I go beyond that, Secretary General, please kick me off there. Please applaud me the presentation of cardiac surgery in Uganda. Thank you. This is an IT's time. Thank you very much. Well, as had been introduced, I'm Jose Wakarieba. I'm a pediatric cardiac surgeon at the Uganda Heart Institute. The Uganda Heart Institute is the single only national referral center for cardiac care in Uganda, established in 1988. The heart surgery program resumed in 2007. The bed capacity of the Heart Institute, though
we have grown to take up some more floors. It's slightly bigger than 40 bed. But then in perspective, if you have a capacity of 50 beds for a 45 million population of Uganda, then that already illustrates that something is wrong. The ICU bed capacity has grown to 7 ICU beds with the refurbishment of 1C. We still have 1 operating theater and 1 diagnostic catheterization lab. The history of heart surgery in Uganda started far much earlier than a lot know. In the 1960s, there were attempts to do open heart surgery, of course, with rudimentary ways without using a roller pump. And this also had a makeshift cath lab. It was doing wonders for the times. Now, with the turmoils of the 70s to 80s during Idi Amin's presidency, things changed. The professionals who had started the programs in the 60s had run out of the country. In the 80s, you have a return of professionals, and then you have Professor Maswa championing the rebirth or the reconstitution of the heart programs in Uganda, where he identified a number of key individuals, among them the current director of Heart Institute, Dr. Magino, Dr. Kefas Mijumba, and Dr. Wabi, to go for training, who came back and started doing procedures that later on grew to the establishment of the Heart Institute in 1988. Now, in 1988, you start to have individuals who are identified, who are recruited to come and start building a new program for heart surgery in Uganda. The current challenges are challenges which are faced with all of us in the practice. Insufficient funding from government, lack of skilled manpower. We are still young departments growing with skeleton staff. The tremendous disease burden to be handled by a single center in the country. Limited operational space, as I highlighted, that we still have 1 single theater and 1 cath lab, and then limited ICU beds. Lack of equipment and supplies, as we all endure. Poor remuneration and benefits for health workers, which leads to brain drain. These challenges have been turned into opportunity, where we have sought collaborations with other institutions and partners, well wishers abroad, Rotary clubs. This is a little bit fast IT. Gift of Life, Chain of Hope, Children National Medical Center in Washington. And of all these have come in to help develop the programs financially, skill transfers, and then the training and recruitment of staff. The expansion of services, you have heard of recent, we are trying to expand services to regional centers to see what can be done at the regional centers, in that you start to grow these programs to where the patients are coming from. Then the planned hospital, which will be in Naguru, that will increase the capacity of handling much more cases and also avail opportunity for training. This leads to the local training programs. As colleagues, you know that we have young training programs where in the last 4 years we took on fellows who graduated from general surgery and have already qualified as CTS surgeons. But of course, what we do prepare them is also knowing where all of us have passed, that you can get information and training within the country, which will require you to go to another high volume center so that you can up on the skills. This gives a trend of congenital heart surgery in Uganda. I limit myself to congenital since it's in my area of practice. The current program started in 2007. When you compare 2007 to 2019, you see the growth trend of heart surgeries done at the Heart Institute. You start from 0. You have 2 surgeries which were done whenever you had visiting teams that came for skill transfers. And as you go to the next slide, you see that in 27, you had visiting teams that were doing majority of the works. But in 2019, the local teams are able to do close to above 70 cases of this is open heart surgery in a year. If it hadn't been for the COVID pandemic, we would surely be past that greatly. This is important for policy, among the things which President Asou, you were mentioning yesterday. When you look at this, 2005, before the programs started in 2007, all patients who required heart surgery in the country had to be referred abroad. But as per 2019, majority of the cases, close to 80% of congenital heart defects can be done in the country. Now, this shouldn't be interpreted wrongly. Yes, you can do 85% of the spectrum of congenital heart diseases, but then you are doing it for a population of 45 million Ugandans in one single center. So at the end of the day, that does not translate that you are able to do all that. Yes, you have the capacity to do 85% of what presents to you, but for the patient population, you are not able. That's why you have had colleagues who have referred patients. We have waiting list at the end of the day, which we dub as a dying list, of which you have patients who keep on accumulating. To put it in perspective, each year in Uganda, you have approximately 1.6 million children born. Of 1.6% of them present congenital heart defects. Now, 1% of them is 1,600 patients. Do we have the capacity to do 1,600 open heart surgeries in the country? The answer is no. So you have to see solutions which will come out of advocacy, which Asou and all other sister associations should take on, to see that as we reach in 2025, 2030, you have the regional referral hospitals with the capacity to do some of this work, and that's where you will have an impact. As per now, our impact is less than 1% vis-a-vis the population of Uganda. So these challenges have been made through partnerships, as I said, resumption of the program, and 2016 you have an act of parliament which establishes Heart Institute. The management and gives it a mandate, among other things, directing policy, carrying out research, as Professor Chairman illustrated. If you don't have the information, then also your impact will be minimal. So the current state, we have what we call a well-staffed but skeleton structures. Equipped, more or less we are equipped for the kind of things which we are doing, but there is still a lot that is desired. We have reliable suppliers, but still we endure things which come from NMS that come quarter and are insufficient. Then goodwill. The cost of heart surgery in Uganda is 18.6 million. I basically offer a service which, if I had to pay for that, I can't afford it out of my earnings as a public servant. So for children programs, you have all these collaborations. Dr. Sekavri is aware of that. A number of organizations will come in to chip in support for children programs, which is different for adults. An adult, when we look at a 45-year-old with valve disease or coronary artery, he has lived his years. But for a young baby, there are programs which do support. So these are the collaborations which keep us going. And colleagues who have passed at the institute, you wonder why do they do a lot of pediatric cases compared to adult cases. It's the reverse in developed countries. You actually find that programs start with adult and then you go to pediatric because of the complexity of pediatric cases compared to adult cases. We have ongoing researches which we are trying to use as a voice and a vehicle to put our work out there and cause change. And you make noise, but this noise has got to be backed up by information. And it's through these research programs that are aiding our training programs. And then we hope that it will give us results and leverage later on. As I said, we have one OR, one for all cardiac cases. The departments are split in congenital and adult, which are for acquired. I don't think that's mine. Now, the catheterization laboratory is basically where we do what would be more of the non-invasive procedures. You can implant stents, you can implant, if you have an ascending aortic aneurysm, you can do a TIVA, implant a stent and repair a burst vessel from inside. There are procedures now, defects which we can cross through the cath lab, through a vesicular access to implant a device or an occluder, and you end up not, this gives us what would be in surgery as minimally invasive surgery. The cardiac ICU, we recently got a refurbished and well-equipped ICU of a donation from the Hungarian government, which improved our ICU capacity from 4 beds to 7 beds. It's something, but then for the population of Uganda, thank you very much. The scope of surgeries, as I said, we do acquired and congenital, and a broad spectrum of them, except of the other challenges that we are faced. And this capacity has come through enduring, and our seniors who have taken on challenges and chose to be here and train us and cause advocacy for the growth of the programs. And the future perspectives, the new home, which is coming up in Naguru, improve on training and strategies to increase government funding through advocacy, strategies to improve collaborations, and lobbying government for more cardiac centers at regional referral hospitals with a vision to improve cardiovascular service delivery in the country. I end with our cardiac theater, catheterization lab, and our new intensive care unit. Thank you very much. At this juncture, let me take the opportunity to invite all the speakers in the session we are in. Professor Kyamanywa, Dr. Olive, Dr. Kasaga, please come up and we talk on questions, and shall take on 2 questions per each speaker so that we can respect time and go into the next session. Thank you very much. Dr. Jivan, hope you're still online. There could be some questions for you too.
Yeah, absolutely.
Thank you. Someone with a mic in the...
Thank you very much. I'll be quick with my question. I think it probably will go to Professor Kyamanywa and Olive Kovsinje. This is the Association of Surgeons, and it's supposed to be the August house to decide what moves in surgery. How do we create a think tank so that we are able to move forward? And my second question, I think it will still go to any of you. I will start with an example. Recently, the government gave funds for research, I think at Makerere University. RIF, you're familiar with that? But the research says whatever research is going to be done must take at least 9 months and produce a result. And at the end of the day, results were produced to account for the money. How do we change this narrative? Thank you.
Thank you very much. This was a very powerful session, and it sets us rolling very well from the history, Dr. Kovsinje, to the future, Professor Kyamanywa. how do we embrace AI in training and in practice? Recently, there's an organization which was trying to recruit me to see patients online, and I struggled. They told me they have AI-generated questions. Basically, it amounted to me giving a call to a patient. I don't see them. From their responses, I get AI enhancement, and I'm able to come up with a diagnosis and treat. In my traditional practice, I found that a bit strange, and yet that seems to be where we're going. So how do we embrace AI before it leaves us and gets us out of the job? Thank you.
Good morning, ladies and gentlemen. Our panelists, thank you very much for those presentations. This question, I think, could go to Brian, but maybe everyone else. Your presentation, it relates to a statement that was made some time ago about surgery being a stepchild, surgery being neglected. And the question is, why? What are we not doing right? Sometimes someone said they've never seen a hernia eradication write-up on a car. But there's a lot of malaria, there's HIV. What are we not doing right?
Thank you. I have two questions. One to Dr. Kobusinje. Thank you for the wonderful presentation. I was just wondering, from the data you gave and the references, are there possibilities that others, as a process of selection, they were not included? Because the history of surgery goes beyond that period. Then secondly, would you want to, I like the term changing roles, but are there possibilities that we can look for other additional words like shifting roles or switching roles of surgeons? And then to Professor Chamanywa Patrick, you suggest that we need to have simulation and AI before we can do the transplant. Do we have trained AI machine for our setup? Thank you.
Yes, thank you. My name is Brian Matov from Biomedical Engineering Unit, Makerere University. I think my question would go to Professor Patrick, but also I think the presentation from Dr. Olive Komsinje also was touching the same. Surgeons, our role as engineers is to see how can we bridge the gap between medicine and engineering to improve healthcare delivery. So if we look at robotic surgery and how everything is changing in the environment of surgery, do we need the robotic surgery, maybe the robotic such kind of surgery right now, or what are the challenges that are currently in the surgical environment that engineers could push for? The good thing I have my head of department, Dr. Robert Sechitoleko. We are interested in seeing how can we work with the clinicians, okay, the surgeons, to address the gaps which are there. And then we support local production, local innovations, and we see how best can we push those forward. So I think your views around that would be so helpful. I think also from the presentations which are coming, we are trying to go with carbon dioxide. Okay, how can we have gasless laparoscope as a way of improving access to surgery? So we are really interested in such, and then also the think tank that the first person talked about. I think it would be good if engineers could also be involved in such a think tank and see how we can support innovations. Thank you.
Thank you for the questions. I think Dr. Kopsin, you can go first and answer.
much. I'll leave the difficult ones for Patrick. So, the think tank, Rose, I think that this is something that we need to consider as Asou, but also maybe generally as Ugandan doctors. Because if you think about it, we were trained, we were first taught how to read, how to write, very fundamental things that enabled us to do whatever else we needed to do. And now we need a different kind of skill set in order to become the surgeon that Patrick was talking about. And part of that has to do with how we interact with technology, for instance. So if you look at the training, at the people that are coming into the medical schools, what do they have beyond reading and writing that's going to enable them to become the kind of medical students and eventually the kind of doctors? So I think that needs to change from very early on. And I think somebody else, I think it was Patrick, that what we are being taught in the medical schools, what we are being taught in the surgical program even, is not realistic for where we are currently. So I think we can begin as Asou and begin with the people that are closest to us. But this is a conversation that needs to happen yesterday. And it has to do with the interrogating what's on the curriculum and how that curriculum is taught. We cannot be teaching the same things that we were taught. It's just not on. That's not how we're going to solve Uganda's problems. Because, I mentioned some of the people we look up to have no clue what kind of problems we are confronting today. And they were great for their day, but they are out of their depth for today's problems. And so I think we need to have this conversation with younger colleagues to find out what kind of tools we need in order to tackle today's and tomorrow's problems. There was something about research funding. Yes, I think the idea of those monies that came out and they said you have to have done your research, it was so ill-advised that it was really just throwing away money. And most of it went to students that had a deadline to present their dissertation. And so they came out with something, but it really was just throwing away money. And I think, again, one has to have those conversations in the back to say, if you really are interested in advancing medicine or health, and if you want to fund health research, this is how you do it, or this is not how you do it. Some of my students benefited from that, and the only reason they were able to do anything halfway decent was that they used those funds in addition to the funds they already had for longer-term research. Maybe I'll leave it. Somebody else was thinking about changing. Well, so you can use different kinds of words, whether it's shifting, whether it's switching, but it has to change in some way or form. And again, it's just what I said, that the roles that we had, so when we were taught to be surgeons, we were expected to be in the OR, to do plenty of opening and closing, and now we may not even step in the OR to do what we need to do. So I think it clearly is going to change, and it's not a subtle change. In many cases, it's actually a radical change, and we have to be prepared to deal with this change.
Don't run away yet, Dr. Olive. You might still get a few more hard ones. Yes, thank you very much for the questions. I think the issue of a think tank should not be even further delayed. As Asou, we should resolve, probably it should be one of the resolutions in this AGM, that there should be a council or a committee that looks at surgical training in Uganda. And why is that important? We now have about 4 or 5 medical schools that are teaching M-Med surgery. But who reviews their curriculum before it's accredited by the National Council? We should be the ones to determine what kind of surgeon we want. And therefore, as an association, we should establish ourselves in that sphere so that we become the go-to committee for accreditation of surgical training. In undergraduate, we should be involved. At postgraduate, we must be involved. Why? Because we have to, we are in a difficult situation where we've got to catch up with what has been done elsewhere. But we've also got to catch up with what is demanded of us going forward. So we are bending back to cover the masses that our chair of session was talking about. We cannot satisfy everyone with the current care, so there will be need for some basic care. But we've also got to leapfrog forward and be able to catch up with what's happening elsewhere, because that is the trend. And of course, this also goes to the surgeons. We should be able to create, it is already starting, but probably starting largely on individual initiative. But as an Asou, we've not taken into our responsibility to determine how many cardiothoracic surgeons are we training for Uganda. Who determines that other than personal interest? How many urologists are we training for Uganda? Who determines that? We should be the ones and even look out for partnerships and funding to send these people there and pull in the Ministry of Health to be able to fund some of these efforts. I think that was a very excellent question, Dr. Rose. Thank you. Our president asked about AI. In education, in practice, and so on, AI is new, but we can no longer run away from it. We just have to learn to work with it. We had a meeting recently as Vice Chancellors talking about AI in higher education, because people were worried, how do we handle the chat GPT now that it has come? You have to work with it. And this actually is just going back to the history. Was it Isaac Newton, I beg to be reminded, who said, do not commit to memory that you can find in books. So leave the mind to think of solutions, but know where you can get the data when you need it. What you want is does this person demonstrate that they can work with the data they have got? I think that is, to me, more important than do they actually have it in their head. Because there is a lot, we've seen there is more than 5.6 heptabytes coming out every day. That is data. You can't know it all. That's why journals have stopped publishing hard copies, because the volume of data is too much. You just have to have a soft copy, put it, and next day you are able to produce more. That's where we have to go. So looking at AI in training, I think we need to embrace it. In practice, we must embrace it. I hope you took the job, Mr. President, because one thing that is killing us is tradition. As we advance in technology, as the digital era advances, so should our review of what we call ethical. We used to insist you must see the patient so as to treat them. Is it always possible for you to see the patient so as to treat them? How are we embracing the technology that has come? Can we have an algorithm that helps you get to the near truth in that patient? Because even when they come, you don't always get to the truth anyway. So we have to be engaging in that kind of discussion. What do we call ethical in practice now? I think, to me, I always want to push the frontiers, and I believe that culture is what eats innovation. We are so stuck in culture that we don't embrace and are not innovative enough to grow. Then we look at others and say, oh, we thought this was unethical, but it's being done, so we should do it. And so that brings us into trouble. The biomedical engineer asked about the multidisciplinarity. I think this is one of the things training has to embrace. we have talked about, and the two gentlemen there have been on planes, I don't know how many air miles they were able to accumulate, Professor Galkand and Professor Kijambu, going to learn about problem-based learning and interdisciplinary training in medical. We have not actually moved forward. How many of us have a word round with the biomedical engineering students, biomedical science students, nursing students, and being able to engage each of these students? We talk about it, it sounds nice, but we are not doing it. So this discussion between surgeons, engineers, anesthesiologists, laboratory staff, the pathologists, and so on, should be an everyday thing. It should not be only for the tumor boards. When it comes to tumors, we start realizing the importance of MDTs. Why not for others? Can't a sigmoid volvulus actually be managed differently if you had your laboratory technologist in that room to make the decision, looking at all the parameters? I think it should be beyond the cancers. But we need a committee that can help us drive these things to be able to move forward. And that's probably why we are talking about the NSOP. NSOPs are helping us realize that surgery is beyond the surgeon. It also involves the anesthesiologist, it involves the policymaker, it involves the obstetrician and others. And I think I will leave it there for the interest of time. Thank you very much.
Thank you. Dr. Kasaga, your question?
Yeah, thank you. Thank you, Professor Galukande, my mentor and department chair, for that question. Well, I think why we have surgery as the neglected stepchild of health in Uganda is basically many factors. But the main one is we as surgeons, I think, most of the time we operate on our patients, we do not get time to advocate for our patients. So, and advocacy itself, you need the data, you need the information, you need research. And while our colleagues in the landscape of HIV, TB, they do a lot of research, they make a lot of, I've seen evidence, briefs, policy briefs, rapid response summaries, reports. All that is going to be used by policymakers to put maybe HIV and TB on the agenda. While for surgery, we even don't have data on magnitude of health conditions. So why would you convince maybe a donor in Uganda to put money in, for example, supplying more materials for casualty at Mulago? So we need the research. We need to and actually there is another paper that was done by one of my mentors on this project, Professor Ekwaro Buku. He looked at the academic productivity of M.Med dissertations. So he says that about 10 to 30% of M.Med dissertations are published, and approximately 1.4% of the dissertations are used in the policy making process. So what happens to the other 70 or maybe 80%? So we say that most of the research for us as residents, we are going to do research on outcomes, and most of the times it stops there. So this work is not published, and as such, we don't have any information that we are going to base on to make decisions. So I think we need to improve in the terms of research and advocate for our patients. Then also, maybe because the other factor is the planners, or maybe the people planning for our health in Uganda, they take mostly a siloed approach looking at specific diseases. For example, TB, maybe cholera and other diseases. So instead of looking at the health system as a whole, instead of maybe looking at supporting health infrastructure, because if you support a laboratory to have a refrigerator to store blood, it's the same blood that you're going to use for a child who has severe anemia for malaria. So I think instead of looking at specific diseases, as we saw from the report here, we need to look at the surgical system as a whole and try to reverse the trend. So I think those are the major reasons why surgery is still the neglected child in Uganda. Thank you.
Thank you, Doctor. Thank you, Dr. Brian. Dr. Jevan Francis, I think you're still online. Thank you very much for making time to present from Aberdeen. A round applause for the speakers in this session. Thank you very much.
Thank you. Thank you, Dr. Mohoz, for moderating that session quite well. We're going to dive straight into the session we skipped earlier on in the morning. And the session is being chaired by Dr. Rose Alenyo. Dr. Rose, kindly come up to the podium and we start the session. Thank you.
Thank you very much. We'll move fast. This session will be shared by two sisters. We are actually twins. One came so many years before. So in this session, we have Dr. Laro is not here. We expected Dr. Laro, he's a director of curative services from Ministry of Health. I think he's not able. We have Dr. Sekabira John, Deputy Director, Mulago National Referral and Teaching Hospital. He's a professor and a senior consultant, pediatric surgeon, and he's actually the lead pediatric surgeon for this country. You're welcome, sir. On that panel, we also have President Kosek Samam. You're welcome. They already said she's the first president of a female president for Asou, but she's also a consultant endocrine and general surgeon. I know her best is she's an anthrophile, if somebody knows that. She loves flowers and grows flowers.
Also, part of this panel, we have Dr. Cornelius Sendajire. He's a cardiac anesthesiologist working as a lecturer with Makerere University and the Uganda Heart Institute. Don't kill me. And then next on this panel is Dr. Ronald Bisegera, who's secretary-elect for the Association of Anesthesiologists of Uganda. He's also a senior clinical fellow in pediatric anesthesia. So I think, Professor Galkande is the other speaker on this panel. Professor Galkande is the chief of surgery at Makerere University and also chancellor of Clark University, and has done lots of research and has been part of the spearheading group on the Uganda National Surgical Obstetric and Anesthesia Plan. So before we kick off the questions, we expected Dr. Olaro, and there's some key points we wanted him to speak about, but just as an overview, the National Surgical Obstetric and Anesthesia Plan, I'll just declare right now that I'll just say surgical care, so I don't have to give the entire mouthful each time. So for the Surgical Care Plan of Uganda, it's been led by Dr. Olaro at the Ministry of Health. He chairs the committee that's dealing with this. And then there's several other people that have been working with him over the last few years. Of course, it's still in its infancy. But this is a plan that has been pushed and accepted by many countries because of a need to satisfy the Sustainable Development Goals, which have been projected that should be achievable by 2030. And most of the surgical problems fall in SDG 3. And there's almost like about 8 areas that are target points for us: neonatal mortality, under 5 mortality, maternal mortality, and morbidity, as well as like non-communicable diseases. So like lots of other places where surgery feeds into, and it has several pillars that areas that we'll be teasing through during the discussion today. Please welcome our panel.
So we're going to start with Dr. Sekavira, since we don't have Dr. Olara around.
So what Dr. Sekavira will be talking about is that he'll give us some updates on the Uganda National Pediatric Plan, on the Uganda National Pediatric Plan, but also we'd like to find out if this plan is in keeping with the optimum resources for children's surgery, but also how realistic in our context it might be, because some of these are suggestions, but will it work here, or is it something you've considered? Thank you.
Thank you. Good morning, everyone. Good morning. Hopefully, good morning. Maybe to start with, I think all of you know the global movement about development of NSOPs, which is like it was a resolution of World Health Assembly, which was really setting the role to see that the global disparities of access to surgical care can be addressed. And this created a platform so that it's like imperative for the country to develop NSOPs, which have been talked about. As Dr. Kasaga said, it all came about like nobody knew, for example, what is the burden of surgical and obstetrical anesthesia diseases, what we really need to know, so that we needed to collect data about all these conditions. And as part of pediatric surgery, we started by collecting data. We realized that, okay, it was really pushing the NSOP for the entire country, really was not moving. And the pediatric surgery, we started by collecting data, which really we are sharing with our partners. And we indicated locally, basically in the 2 hospitals in Mulago particularly, and then some data from Mbarara and then Lacho, which informed the world about the burden of pediatric surgical conditions. And this helped us to solicit for support, whereby we started by creating surgical, basically kids OR, with other partners. We created surgical suits starting from Mulago and then in Mbarara. And this, we realized that the output and even treating the children, the output improved, and so is the quality of surgery and the outcomes. And also training of providers in anesthesia also started. And also we started a bit with financing. And this also helped us to even look for more funds so that we can develop other theater suits everywhere. And with our partners that is Kids OR, they started looking for funds so that we can develop theater suits in other 10 regional referral hospitals, so that we can we can address the unmet need of pediatric surgical care in the entire country. And that plan was launched last year at the Ministry of Health. It was supported by the ministry, particularly the permanent secretary. It is we try to look at creating theater suites in 10 regional referral hospitals, as I have mentioned. But also, this is going to be like building a super hub, which is going to be Mulago, and then hubs in 10 regional referral hospitals. And these 10 regional referral hospitals are going to act like a sport, rather they are going to be like the hubs, sub-hubs, and spokes, which is going to address the surgical needs, pediatric surgical needs in the district hospitals. We hope this one will try to address the demand for pediatric surgical condition, to address this pediatric surgical disease. And when you look at the epidemiology of Uganda, you find that all the children who are under maybe 15 years constitute more than 50% of the population. And we can't claim that all these children could come to Mulago for treatment. So we realize that unless we spread out to regional referral hospitals, probably that's when we can try to address some of these conditions. And for example, we could see that children with simple conditions like anorectal malformations coming all the way from Arua to Mulago. Some could come already when they already the physiological derangement could not be treated. Conditions like gastroschisis cannot come all the way from Soroti to Uganda to Kampala. So we think that if we can create those regional centers where these children can be treated before, so that there is no need for them to come to Kampala, probably that would be a big way of solving the problem. So Kids OR has committed to build these surgical centers in those 10 regional referral hospitals. Of course, we know that there are 14 regional referral hospitals, but we think if the 10 regional referral hospitals are probably kitted with these theater suits, then we go for training. Right now, we have started, as you know, we have the fellowship training program, which trains pediatric surgeons in Mulago and in regional referral hospitals. And we think that if the aim is to train 20 pediatric surgeons, anyway, the plan was ambitious. We thought that in the space of 10 years, we can train 20 pediatric surgeons. And some of them are being supported by Kids OR through their training, the pediatric surgical training fellowships. And also the training of anesthesia has started. We have a pediatric anesthesia fellowship training program. And we think also to embark on the training of pediatric nurses, basically in critical care. And this we hope it will try to address some of the challenges in managing pediatric surgical conditions in the entire country. We know it needs a lot of support from government, and because if you realize countries whereby they have developed NSOPs, the biggest challenge they have faced is the implementation. Countries which started, we have people, I think we have friends from Rwanda, they faced the similar condition of implementation. Zambia, even the 5 years have elapsed when they have not managed to implement the NSOPs they created in the first place, because Zambia was the first country in Africa which created the NSOPs. 5 years have elapsed when they have not managed even to implement what they plan to do. So we think we have to draw conclusions from those countries. I don't know how Tanzania has moved, but as we are talking about development of NSOPs, we have to think of implementation. And implementation has to have support from government, basically. Without support from government, nothing can move. And of course, government can of course influence development partners, because as individuals, as surgeons, it's very difficult to go to implement partners like to USAID and to see that we can implement this policy, rather NSOPs. We can have very good policies on paper, but implementation, without funds, is very difficult. And as you know, agencies have been funding malaria programs, TB programs, and HIV/AIDS, but surgical plans have not get support. So what we need to do is to see that this support is got from development partners using government as a vehicle to seek for this support. Maybe that's what I can advise, but for surgical plan, for pediatric surgical plan, that's the plan we have, but we have to seek support from government so that they can influence the development partners so that these plans can be implemented.
Thank you. Thank you very much. Government of the people, for the people, so we are part of government, I guess. We're just now moving, you know, surgery never takes place without anesthesia. Yeah. And when you talk about pediatrics going peripheral, I know their heartbeat is going up. So please then, Dr. Ronald and Dr. Sendagire, we can, please let's keep it brief so that the House can discuss with you. Tell us about the infrastructure, the basic things that we need to drive pediatrics or any other surgery in the lower settings. Thank you.
Thank you very much. Good morning, everyone. So with infrastructure, I think it's one of the pillars of the Lancet Global Commission on NSOPs. I think one of the most important things that we sometimes forget is oxygen. Someone said breathing is one of the most pleasurable activities that human beings do. But since morning, you didn't take note of that. If I was to strangle you right now, you would start to find that breathing is actually quite pleasurable. But oxygen has been an essential medicine on the WHO list. However, up until the COVID-19 pandemic, we had no idea that the world was in dire need of oxygen. So what we know now is, especially with the current capacity of Uganda's oxygen, which we quantified, I think, in 2021, what we found was that regional referral hospitals that probably provide a huge bulk of care, not just surgical care, but also medical care, were producing about 16 cylinders of oxygen per day. That is from 8 to 5. And this is significant because if you have an oxygen plant and you're only producing 16 cylinders a day, which amounts to about times 6.8 liters per cylinder, it's very little because you're going to give out some of the cylinders to district hospitals. Now you're left with a few cylinders that are going to be used not just for medical purposes for children who have pneumonias, but also for children who need surgery and postoperative care, okay? And then not just the children, but even the adults. And the adults we know consume a lot more oxygen than children. So oxygen becomes a very huge issue in that regard, that I'm glad to say that there's been an increase in the oxygen availability, especially to the children and neonates. But these are not the surgical side, mostly to the medical side. So again, if surgery is the neglected child, anesthesia and critical care are the distant cousin of the neglected child. I know most times when you're starting off with your surgeries, you start off with giving oxygen, the patient goes to sleep, but we never really take note that this oxygen is actually life-saving. I'm sure some of the surgeons here have seen blood turning blue while you're on table, and that is dire. At that point, you probably have a cardiac arrest. So oxygen, as much as we have not paid much attention to it, we've given a lot of credence to all the other essential medicines, and we've forgotten the crucial thing of oxygen. So in terms of infrastructure, at least I can gladly say the government is trying to step up on improving the oxygen availability in the country, having liquid oxygen available, having regional referrals have newer PSA plants that generate a lot more oxygen. But what we found is that the human resource at the oxygen plant is actually the fundamental issue. Biomedical teams that are supposed to ensure that the oxygen plant works 24/7 are not there. So if you have one person, they're going to come in at 8 and leave at 5. And during that time, they've produced 16 cylinders. And then if you have an increased need, you're not going to be able to meet that need. So I'm sticking to oxygen because all our surgeries, almost all our surgeries, are going to need oxygen. whether during the operation or even after. The last thing you want is to do a very wonderful procedure, and then the patient goes to the ward or to the post-anesthesia care unit, and they need oxygen, and then you don't have that oxygen. It can be quite catastrophic. We know that in terms of reduction of mortality, 25% mortality in children was reduced just by giving oxygen. It is equivalent to the vaccines that are being used. They reduce the same amount of mortality. So why not give oxygen the same credit, the same credence as we give things like vaccines to prevent mortality? So I will probably stop there and allow Dr. Bisegura to build onto that, but let us remember that as much as we want to operate and do all these things, there are these small things that we may not consider so important. I'm not sure if any surgeon here would be willing to go into an operation without oxygen. I'm almost certainly sure no one would. But make sure that in the setting that you're in, you advocate. The voice of the surgeon is very important. No matter where you are. It's not just the anesthesiologist. If you don't support me in terms of what I need, then we are both going to be in trouble in terms of patient care. So the voice of the surgeon is extremely important to advocate for such essential medicines to be available for us to have success in the surgical procedures we do, not just short term, but also long term. Thank you.
So to talk about the workforce, like we have already alluded to the surgical burden that is present and what is required. Regarding workforce, you need, the recommendation is that we should have about, to start with anesthesia, we need about 5 anesthesiologists for every 100,000. When you compute that to what our current population, assuming 45 million, we have 0.2. So because we have about 100 anesthesiologists, if you add all the other anesthesia providers, including the bachelors, diploma holders, it comes up to about 800 anesthesia providers. If you compute that, we get about 1.2. So it shows a huge burden or need of anesthesia providers. If you aggregate it, to put it together and follow the surgeons, anesthesiologists, obstetricians together, the recommendation is 20. Uganda has 1 for every 100,000. Why is it important to look at workforce? For the bellwether procedures, which are thought to be the procedures that should be happening almost at every level of health care, you need a team for anesthesia. This might include the anesthesia, the diploma holders, we have the bachelors and anesthesiologists. A study done, the Asou study that came out found that in African continent, adults are twice as likely to die following surgery compared to those in the high-income countries. It's worse for children, 11-fold. Children are more likely to die. But what in these studies, when they looked at what the likely causes were, the issue was postoperative complications. It might be a bellwether procedure, and in, say, a patient who has low risk versus those that have a high risk. That's why we need a team. We need like supervision from the anesthesia, the diploma holder, anesthetic officer. You need the bachelors and then the anesthesiologist, so that once there are complications, they can be detected early, and through this, you are able to get support. And a way to beef up this dates back from in the 1989, about 35 years ago, we had only 2 physician anesthesiologists in Uganda. And over time, we've built up to now 100 anesthesiologists. It's been work that has been put in by the Ministry of Health, the different partners like AAGBI, the World Federation of Societies of Anesthesiologists, the individuals that have sacrificed themselves to train the different cadres to get to where we are. So where do we want to go? What can be done? The need is about 1,800. That's what we would need if we are to meet the suggested requirement to make 5 for every 100,000. We need 1,800 anesthesiologists. This is like an unthinkable number. Remember, the population is growing. The system currently produces about 10 per year. If you need, so you need about maybe 170 years. If the population is static, you're not getting out. Some people, you're not, so you can imagine how much more we need to do. But a few things could be done with the current circumstances. We have collegiate training. This is one that has been already alluded to by the previous speakers. Like the training happening in the universities, we only have 2 institutions producing physician anesthesiologists. How about we embraced the College of Anesthesiologists of Eastern Central Africa, colleges which can do trainings even in regional referral hospitals. What it would take would be easy. From a study done about incentives for retaining anesthesiologists in peripheral hospitals, because they will be the ones to train, if in case collegiate training is to happen, the incentive was, among the many, was having at least 2 anesthesiologists at a facility. But you see most adverts are advertising for 1. Even the recent advert that came out, the physician anesthesiologists in this study, their responses were, maybe if we had 2. And this could be done because the positions are there. If we have 2 at least, that means that can become a training center. And with the rotations from the different, imagine all regional referral hospitals being training centers, because you already have 2 anesthesiologists who can support the training. These can be supporting even the entire region. The Association of Anesthesiologists of Uganda had a call center where people could consult. Like I said, we want the procedures to be done, but what are the outcomes that we want from these procedures? Because there are low risk and the high risk. So an anesthesia call center was set up, and people would consult about cases when they are stuck, how could they be helped? So we thought this can be useful if it can be extended to even other specialties. If a medical officer is stuck somewhere, who can he call? If we had them at the regional referral hospitals, it would be easy, even if someone has to go physically. But imagine the child has to move from Kapelebyong, has to come to Mulago for them to get the care that they need. So maybe empowering, starting with employing at regional referral hospitals, if we had at least 2 anesthesiologists for each of them, maybe it would be useful. The adverts have come out, actually people haven't applied. Even those that applied don't even show up because there is 1 post. Maybe if there were 2, maybe it would make a difference, and they would attract more to stay in the system, and then maybe build capacity and have better human resource to take care of the children that have been worked on, or even the adults that have had surgery.
Thank you, Ronald. And from what you and both Cornell have mentioned, there's a few follow-up questions whose answers possibly both you, Professor Galkande, and Dr. Jen can actually respond to. You've mentioned collegiate training, but you see workforce is not just numbers, there's quality as well. There's producing numbers, and then you've produced a bunch of butchers. Is there something that you think collegiate training might have more weight over the university-based controlled training that you think might be better in this situation? And if Uganda is in a unique situation to promote this, what should we be pushing for in this type of thing to improve our workforce?
Thank you. One of the previous speakers said the training that is happening in universities, who is supervising that training? Recently, we had the saga with UMDPC. The reports that were released were below what was expected. Maybe health professional associations need to stand up and own this practice. And imagine if we had an association, the Association of for surgeons, if they were the ones who set the curriculum, give the exams, the bias would be less compared to having maybe 2, 3 institutions who are working independently to do the training. Even if there are exams, the exams are given by the university. They decide what kind of exam they want. But if it was opened up, say, to the professional associations, they are better equipped, I think, to manage if they're given the mandate.
Professor Galkande? you have a comment on that?
You want me to comment on this?
Yes, on the collegiate training, yes. And university-based. We want to keep the blood pumping.
Yeah, there is an invitation we got yesterday from Dr. Kanyesije, those who were there at the landscape. He mentioned that in about 30 days, the Ministry of Education is going to consider some policies that are going to be in place. When they are put in place, they are going to apply for a long time. So he made an invitation that if we have any submissions, we make them within 30 days. And I think, Frank, you are assigned, and I was assigned to correct those suggestions and take them, and we have a conversation. So the little bit of a challenge is the training mandate is with the Ministry of Education at the moment, not the Ministry of Health. And that has its problems. So the general understanding is that you may want the Ministry of Health to participate heavily in the training and determination of it and so on. So this is an opportunity for us to make some declarations, some suggestions. So these are good conversations we're having right now. So that could be one thing. But what I might smuggle in at this moment is, you know, as surgeons, we are doing a very poor job of being advocates. For many reasons, we're busy in the OR and so on. But one other thing that stands out very, very clearly why we have a gap in advocacy is we don't put price tags to our things. Now, the people who sit in those boardrooms and make decisions, there's something they look at before they make a decision. The same thing you do when you go to a shop and you look at a nice shirt or a nice top and you want to buy it. What do you do last before you make a decision? Price tag. If it's $100 and you're thinking 20, what happens? You move. So we make these arguments, but we're not putting price tag. The guy in the boardroom is going to ask, how much does it cost to have an anesthesiologist? And if no one can answer that, that might be relegated.
Okay. Dr. Jen, before we come to your official question, anything on the training, particularly collegiate, if it's something we might be suggesting to the Ministry of Education?
Thank you. You know, the Ministry of Education, in my experience, does not understand collegiate training. I say this because when I was the country representative, I moved to National Council of Higher Education to try and present. I remember in one of them I was with Dr. Jombwe, and I think I called Dr. Mutiaba to accompany me. And even at another point, I called Professor Maswa to accompany me. The first presentation I made in their office in Chambogo, they said, oh, you are doing a lot of work, which we don't understand. And you are so international, but we are only national, so that does not belong to us. That was the word for National Council of Higher Education. You are so international. You are so beyond our borders. We don't understand you. So we had a lot of other meetings with them. Until now, we resorted to Uganda Medical and Dental Practitioners Council, which also took us a bit of time to convince, because I remember calling and inviting the registrar to our Dar es Salaam, I think Mombasa meeting. He didn't come, so he came to Rwanda, and he saw how we were examining the students, how many examiners were there, and how many, you know, how the students, he went literally through all the examination rooms. And by the time he came back, he was a changed person. So, in a nutshell, whether be it collegiate training or university training, the most important thing, how do we supervise these students on a day-to-day basis? A student is presented to me. What is what do I want that student to accomplish by the time he leaves my unit? Okay? If he goes and just roams on the ward or on the unit, by the end, if I give an example, by the end of his rotation on my unit, he cannot do a thyroidectomy. He cannot manage a complication arising from a thyroidectomy. Have I done my best? And take that even on your own and do that. Thank you.
All right. This is just really food for thought, so that when we reach out to you for more information, and for more assistance on suggestions for how to move forward with surgical care, some of these things have already broiled in your head and you can give a suggestion. Now to your question, Professor Galukande, you've spoken about advocacy, Dr. Sekabera has spoken about finding out what's going on before they pushed for these hospitals. That all comes to information. And information doesn't go without data. Big data was mentioned earlier. And what do you envision that we're going to manage information like in our ENSO process? And it's like almost nothing can happen without information. So what are we doing right now? And could it be designed better? And what do you think are the checkpoints we might need as data points to be able to do this? Of like whether it's workforce, infrastructure, but also are we doing what we should do? What's the quality of our care in terms of that? Thanks.
Why are you asking difficult questions? Let me try. I think what we need in the conversations we have, a good starting point would be defining our problems properly. I mean, what is our problem? What are we dealing with? And maybe in asking that, where do we want surgery to go? Where do we want surgery to go? Where do we want to go? Because if we define some endpoints, then it might inform the processes. But definitely, data is one of the tools we're going to need to inform decisions, to advocate, to do all those kinds of things. And there are a number of constraints we have right now. One of the constraints we have is those of you who are familiar with the HMIS sheet. When you look at it for surgery, it's extremely limited. And now some people make these decisions where we may not be represented and we may need to push for that representation. So that these forms that go out to every center in this country collect the data we need. But in the first place, if we haven't defined what we need, then how could those forms have the data we need? So we need that. But if we're to work with the Ministry of Health in this country, that form becomes a critical point for data collection. Otherwise, we shall always be doing parallel data collection because the national system doesn't meet our needs, so we go on the side and collect data. If we inform what should be in this form, it means on a continuous basis, data is being collected. So now we can then interrogate it and so on. So that's one big point. So we need to be in that room where those decisions are being made. If we are not invited, we can invite ourselves maybe, so that we do that. I don't know if I'm done. It sounds like I'm done with just part of your question.
There's just something additional.
Yes.
I mean, part of the people in here from the private sector, what would be their buy-in to contribute information to this, common portal? Because, I mean, at the end of the day, we can't quantify unless all of the information goes to one place.
You raise a very, very important part. Now, many times in these conversations, we talk about Ministry of Health alone. Now, the figures we have is that the Ministry of Health directly supervised institutions about 50%. So the Ministry of Health directly supervised institutions do 50% or look after 50% of the patients in Uganda. The other 50% is from the private sector. And I think the private sector has two parts. The for-profit and non-for-profit. But I understand those terms have been dropped. Exactly. But you know what I mean. So, and for sure we know that there are some procedures or some surgical things that are dealt with in that other 50% that need to be represented in this conversation. So I think moving forward, as I saw for us, I think we need to keep inviting intentionally the other 50% of the sector.
Thank you very much, Professor. Let's get the conversation moving to Ms. Falal again. We're just talking with her and saying, in this country, there are small groups that are trying to do things that are actually focusing on the 7 things that for NSOP. So we're just wondering, how can all these groups try to focus together so that the impact can be measured, so that we understand what is going on in the country?
I think the answer is just straightforward. We need to integrate our work. The more we move as little groups, the less we shall be heard. When a bigger group goes and fronts the Ministry of Health, then your voice is heard. So little groups, yes, it is good. You promote a subspecialty, you promote, but in the end, like for instance, now in Association of Surgeons of Uganda, all the little groups should actually be under the umbrella of the Association of Surgeons of Uganda. Then together, you go and shout. Otherwise, you shout as urology, you shout. He has a voice because he has trained a lot, and Kids OR is on his back. Mm-hmm. Maybe you even tomorrow will have a big voice because Smile Train Research and Operation Smile is on your back. You have a lot of students. But for the rest of specialties that are struggling, the best is to be under one umbrella, and you don't break. Thank you.
Yes, we can get a few questions from the audience to see how we get the conversation going higher. Any comment?
As we wait for microphones to get to the people, I think, Dr. Jane, what you're trying to say is that, we need to know what the left hand is doing, and we need to find a way to coordinate what the different collaborations are doing, because I think Uganda is in that unique position. Many of the countries with plans have not implemented, but we've implemented in several little ways. Why can't we put it all together, and then actually we'll have some things we've already moved forward with, and because some things are duplicatable services. If I'm improving oxygen for ICU, that is oxygen for the whole hospital. Why should it be, for one specific? It meets the entire service. So I think some of those things can be harnessed for the greater good because the services are duplicated. But many of us want our own personal footprint, so of course it's harder to work. But I think, like she says, we need to work together. I think someone has a microphone now.
I'm Dr. Pero Alfred. Probably I would like to comment on something, just information on the issue of data, having a database for surgical conditions, probably. I think it would be something important. Another either we have one, I'm not sure if it's already in existence or we don't have, but I would wish, if it was possible, having a database that we can easily access information, which can help us probably in the planning processes and make of all, like in trying to lobby maybe to the government or other organizations. Secondly, in this conference, we're talking about having access to surgery to the local people. But if you go on to the cost of surgery, you talk in terms of millions of shillings. And most of this cost goes on to the supplies, due to high taxation. Since we have a team from the Ministry of Health representing the government of Uganda, I don't know it's going to be possible probably on issues of using the external taxations on these items, probably to make access to, because now actually we are moving off from the open surgery to this minimal invasive surgery. But if you look onto the cost of surgery on this supplies required for this minimal invasive surgery, they're quite expensive. Thank you.
Thank you very much. That is noted. The speaker is somewhere behind.
Yes, thank you very much, Patrick Chamanywa. I would like to lend myself to the discussion that was sparked off by Professor Sekabira. I think we might need to use the opportunity that was extended to us yesterday by Honorable Ayume of transplanting our tent to the parliamentary grounds. This is where budget discussions are actually made.
Okay, 3 years.
And if we are to try and get a snip into the Abuja Declaration on budget allocation to health, that's the place we can get it hard. However, we need to be able to do that with the figures. Do we have a team, or do we have even a knowledge of what this costs? Because just going to talk and say, you see, this is what we do in Uganda, and they ask you, so if you were to get budgetary support, how much should we allocate? Who has that figure? I think that is the homework we need to do as Asou. Get the figures. Again, it is data. Get the estimates, even if it means borrowing a leaf from Zambia or wherever, and then we determine what are the priorities within all these that would like to be funded, because they will never fund all of it. But once we can identify our priorities, cost them, we can push the parliament with our tent there showing what we do. Thank you very much.
Thank you, Professor, for that comment. Can we get like 3 questions? You want comments only?
Thank you so much. Mine goes to, I think, either Professor Galukande or any other person can answer. One, there has been a caveat on advertising. I think previously, 1 month or 2, I had the registrar from the UMDPC made a comment. She was accusing doctors for advertising. Now, when you're talking about advocacy, what are we trying to imply? Are we talking about that we should go out and advertise? Or what else are we trying to talk about? And then secondly, Professor made it clear that if they are not involving us, we are going to invite ourselves. Now, my question is, are you trying to advise us to go for politics? If so, I think it would be one of the ways to solve this issue. Thank you.
Noted. Prof, I think you need to respond. It's very hot. We don't want it to cool.
Thank you very much. I would say that the surgical practice, we should consider it as a whole spectrum, from public health or population concerns to the middle, which we're used to mostly, which is clinical. You can call it the bedside. And then the other extreme, the other end of the spectrum, which is, some people call it bench or laboratory or molecular. I think for the most part, we focus on the middle part, which is the clinical thing, bedside. to the point if you're writing proposals that are not clinical based, they are thrown out. But then this other side of population health, of politics is so important. Again, we must have a presence in the boardrooms where decisions for allocating money is concerned. So am I encouraging us to go in the politics? Yes. All of us? Maybe not all of us. Some of you would know how to talk very well and convince people that black is white, so you can go for us.
Thank you so much. My question goes to the pediatric and anesthesia team. We have a lot of surgical burden in the rural areas, especially pediatrics. How are we going to be able to retain anesthesiologists in the rural areas? Like, I'm glad that Pete team went to Lacho, they move around, but we also need to retain. Most of the anesthesiologists are in the central region. And if you look around, I don't know if Sorority has one, but in terms of training, yes, we are training, but then the retention and the surgical burden. And also, Dr. Phillips talked about quality. There's an issue of quality vis-a-vis task shifting. In terms of human resource, we have AOs out there. Is there a possibility of identifying some AOs who are interested in pediatric anesthesia and we also take them up, or that will compromise the quality? Thank you.
That's a very, very good question. As you answer to the PID, as you answer that, we also want you to comment. I think it's about 15 years ago, somebody in faculty of, these people of money. One of those did a study, and they are non-clinicians, or they are not doctors, non-medical, and somebody did his master's thesis on finding out what can entice doctors to go outside. And they put incentives so that the salary by government is a little higher. And it was a quantitative study, yes, no, and what. And they got that it was p-value was significant, that the doctors were happy to go if they were paid differently. So as you answer her, please comment on that as well.
So thanks for the good question. Some people have already alluded to it, and it's a burning thing. How can we retain doctors, like you have said, and now specifically anesthesiologists? In 2021, a publication came out, a study done in Uganda, and it was answering exactly your question. So it was looking at incentives for anesthesiologists to be retained in rural areas. So there was a concept called pull and stick factors. Pull is, you advertise. What will motivate someone to get in the application, actually come and actually reach the facility? And then the stick factors, what would actually keep that person in probably that position? A number of factors were looked at. So they did a discrete choice experiment, looking at adjusting so many parameters like your salary increment, to what extent it's increased, maybe plus $1 million shillings, plus 2 million, would you go to a rural facility? With your family, how far from your family? A number of factors. And actually we collected data for the surgeons and obstetricians. That's in the pipeline. We hope we'll have some results that are useful. But for anesthesiologists, a number of factors were raised. But among them, that was a low-hanging fruit was recruiting 2 versus recruiting 1. So many physician anesthesiologists thought if they had a colleague at a regional referral hospital or a rural facility, that was a motivating factor. That might take them there, but what will keep them there is the infrastructure that Dr. Cornell talked about. What does it mean for you to be there and there is no oxygen? The child is desaturating, and the best thing you can do is to look. It's frustrating. So the stick factors, they won't stay there. A number of things were done by government at some point. They took anesthesia machines, advanced anesthesia machines to rural health facilities, especially general hospitals. Guess what? In one of the hospitals I won't mention, I went there and the machine is packed up nicely in the packages that were used to bring it. So, and why was this? Because of the workforce. So they have an anesthetic officer who only used the EMO, some small equipment, very rudimentary, and you're now giving them a touch screen. It is far from what they can think about. So they were kept. So maybe when we improve human resource, this can help even boost the other aspects of the care, the equipment. They will know that we need this equipment, or we can no longer use the EMO. Let's get this other equipment. So while the government, it's easier to fund one-time purchases like equipment, human resource requires sustainability. You need to pay this person a salary. So to answer your question on incentives, for anesthesiologists, there were a number, but among the long-hanging fruit was having 2 colleagues, and maybe Dr. Cornell can add something to it.
In addition to that, collegiate training, if at all we succeed in implementing it, will mean that you're getting trainees out of the city, taking them, let's say, to Mbale, to Fort Portal, to all these regional referral hospitals. There's a high likelihood that you're going to increase the human resource capacity there, but also a high likelihood that you're going to retain some people in those settings. But also, let us look at Molago, last 10 years. Let me go maybe to 2010. The complexity of operations being done in Molago is significantly correlated with the increase in number of trainees in anesthesia. Okay? Just in case you have never noticed that, the complexity is significantly increased in the number of trainees in anesthesia. The quality of care is significantly increased with the number of trainees. It's only 2010 that all of a sudden the number of anesthesiologists in the country just exponentially went up. Okay? Simply because the number of trainees increased, the number of retention within the hospital increased, and so that allowed increase in the quality of care, increase in the complexity, and the same effect can actually be felt if you did the same type of thing in a regional referral hospital. If I increase the number of trainees there, then the likelihood that the quality of care is going to go up significantly shoots up, because there is an educational program. The best hospitals in the world are university affiliated, or they are teaching hospitals. Okay? So introducing some form of training within a hospital increases the capacity of that hospital. So we think, or I truly believe that one way that we can increase the retention is to actually introduce training programs. And one way to introduce training programs is to go with the collegiate training, which currently the AAU is trying to work on in terms of boosting the capacity in the regional referral hospitals. And we've sold the idea to the Ministry of Health, but like the other speakers have mentioned, the Ministry of Health is not really the one responsible for training in this country. It's mostly the Ministry of Education. And I think taking on Dr. Galukande, Professor Galukande's opportunity in the next 30 days is to actually put this as one of the things that we need to have within the structure that is going to be reset. The other thing I think you mentioned was having AOs do pediatric anesthesia. I think it's very important to train anesthetic officers, whether diploma or bachelors, in handling children. And one of the things that the AAU has done is to introduce what we call the Safe PEDS program. The Safe PEDS allows us to interface with anesthetic officers and teach them how to handle children. And what we noticed over time, it was funded by the World Federation of Societies of Anesthesia, and we did a couple of trainings during, at least before COVID, we did a couple of trainings. And what we noted is that most of the anesthetic officers built confidence in terms of handling children, and there was an increase in number of children being worked on in most of the hospitals that this training happened, both in Eastern region, Western region. In terms of doing actual specialty training, that requires a little bit more background in the medical knowledge. People who have actually gone through medicine can handle the children better because they can tell the intricacies between a child and an adult are quite significant. Just like the pediatrician said, child is not a small adult. The intricacies are significant. And what we're advocating for now is not necessarily to train specialty anesthetic officers in pediatrics, but to have anesthesiologists work together with the anesthetic officers as an anesthesia team to be able to provide quality care. The anesthetic officer will learn a lot. I will learn a lot from them in terms of what they've been doing, and we try to amalgamate everything that we know to improve the care. So I think the best way forward for us as a country is to provide educational programs that are short to allow people to build confidence, but also to attach people who have more experience to help them pick up in terms of confidence. Thank you.
Thank you very much. We now have one last question. I know Smile Train has been very keen observing the region on NSOP, so I think East Africa manager is going to ask.
Okay. Thank you very much for the great insights from the panel. So I wanted to speak towards collaborations for NSOPs. Currently, we've been able to collaborate for NSOPs with the Ministries of Health for Nigeria and Zimbabwe and Rwanda, and hopefully we will also be able to collaborate for Uganda. I've had Dr. John speak to the issues of the pediatric ORs that they are building. There's supposed to be 10 of them. I know we've supported one at KOSU and also supported to build capacity for the surgeons, anesthesia providers, biomedical technicians who are working at the hospital. So there are some opportunities that are still there in the sense that we are working with Kids OR and COSEXA to provide 40 scholarships for pediatric surgeons. So these are some of the areas that you would be able to collaborate for this. Also with CANEXA to train 25 pediatric anesthesiologists for the next 5 years, although ending in 2026. So these are some of the areas that we are willing to collaborate. And so because we also need to get information about the NSOPs for Uganda so that we're able to know when and how to come in to support. Thank you very much.
That was a nice way to end it. Our panel, thank you very much. You've given us a job for these 30 minutes. We appreciate you. Thank you. And thank you, Prof. Phyllis, as well.
I would like to invite everyone so that we can have a photo with everyone at this moment. And then we will go for breakfast after that. Thank you. Please, let's come and have the photo fast enough so that we can... All right, breakfast is ready just outside. We have 20 minutes to take the breakfast. Kindly just go straight, pick a cup, have some eats, and in 20 minutes, let's be back and continue with the remaining sessions. Thank you. The next session is about global surgery and surgical innovations. And our chair today is Professor Patrick Chamanywa. Professor, kindly come to the podium and take over the moderation. Thank you.
Yes, welcome back from the break. I'm told in Uganda we normally say break tea, while elsewhere internationally it's known as a tea break or a coffee break. Here we say welcome back from break tea. Yeah, but it's actually welcome back from the tea break. That should be the right way of saying it. So, ladies and gentlemen, we are back today, and we are going to look at session 4. We've gone a bit back and forth, but you will pardon us. It's because we had to manage the availability of the speakers. So, our menu in the next about 1 hour is going to be as follows. The theme for this session is global surgery and surgical innovations. And it's going to be kick-started with a keynote address from one of our guest speakers, Professor Salome Maswime, who is going to talk to us about universal access to surgery. That will be followed by Paula. Paula is stepping in for Miss Rebecca Nansubga to tell us about an accessible laparoscope for surgery in LMICs. After that, we'll hear from the biomedical engineer who you earlier heard introduce himself, Hussein Wabi Kato Omulongo, who is going to tell us about a key loop retractor, looking at laparoscopy surgery again. And this will now go to the educational aspect of all these innovations, which will be addressed by none other than Dr. Bua Manuel Johannes. So to start us off, ladies and gentlemen, is our keynote address, and I would like to take this opportunity to introduce to you the person we are going to listen to. And this is Professor Salome Maswime, who is the head of Global Surgery and Director of Education at the Division of Global Surgery in the Department of Surgery at the University of Cape Town. Professor Maswime, yes, she's a full professor. She's an obstetrician gynecologist and an accomplished clinician, scientist, and academic. A well-known researcher who has researched on obstetric care and stillbirth. She's now also in charge of the University of Cape Town's University of the Future project, where she's spearheading innovative work on how to position UCT, the University of Cape Town, for the future. She's the chairperson of the Health Systems Trust Board, which is a global council, and also a member of the Lifebox, vice president of the Women in Global Health in South Africa, and founder and president of the South African Clinician Scientists Society. Ladies and gentlemen, Professor Salome is also a board member of the Cancer Alliance, Female Academic Leaders Fellowship, and a member of the FIGO Committee on Ethical Aspects of Human Reproduction. Of course, with all that, she's a specialist with a name made and did a PhD in OBS-GYN. She's a Harvard scholar, and she completed the Young Physician Leaders Program in Berlin and has a certificate in program management. Just to sum up a little, because we could go on for the entire hour, Professor Maswime has received numerous awards for her research contribution to maternal health, including the Trailblazer and Young Achiever Award of the President of South Africa in 2017. In 2020, she listed in Mail and Guardian's 50 most powerful women in South Africa. As if that is not enough, in 2021, she was named among the 20 young shapers of the future in health and medicine by Encyclopedia Britannica. And she's won the Tumani Cora Prize for Research Excellence. Ladies and gentlemen, that is our speaker this morning. Welcome, Professor Maswime.
Thank you so much, Prof. Chiamanywa. I'm normally not intimidated by my own bio, but I think it's the way that he speaks. Thank you so much. It's such a great honor to be here. I'm really, really excited. But before I start, let me first acknowledge the president of Asou, the president-elect, our Pan-African president. You know, I think it's unfair to call you just the president of COSEXA, because we see you all as the mother of surgery in Africa, and we greatly appreciate all you do. I want to recognize the chair of the organizing committee, vice chancellor, chancellors, professors, the organizing committee, fellow keynote speakers and guest speakers, leaders, colleagues, and friends. Good morning. I'm going to just start off by just setting the tone. You know, we've said a lot this morning, and in fact, you've covered many things I guess I'm going to touch on. And so I'd like you to see this as an open and honest conversation rather than see it as a speech about the challenges that we face in Africa as surgeons, as obstetricians, as gynecologists, as clinicians, as fellow human beings. I've spent the last few days in Cameroon visiting hospitals. Today I'm here where I come from in Limpopo in South Africa. It's the poorest province. And there were not many differences, despite the advances we've made in healthcare. But there are some of those rural areas where, there are some of those rural hospitals and rural areas where you yourself will not want to have an accident, right? You know, am I the only one who won't want to go to my own hospital if I'm in an accident? And so we need to think about surgical care, not just as what we do for them, our patients. We have to think of ourselves, because any of us can become a surgical patient. And sometimes if you just look at some of the places where we work, you will see why access to surgical care is so important. But let me first thank you for this warm invitation to the Pearl of Africa. As you can see, I've been part of the Ugandan community for many, many years. Some of my best friends come from Uganda. I have aunties. You know, South Africa has a very strong Ugandan community. And so when one of my friends was getting married, the aunties just put their attire on me, said, "Yeah, the daughter, yeah, one of our daughters." So it feels really special to be here after many, many, many years of my life, looking forward to one day coming here. But my talk is on universal health access to surgical care. And I thought, let me just start off by framing it with, before we talk about universal access to surgical care, we need to talk about universal access to health care. And when you look at how it's been defined, it talks about access to all sorts of services, comprehensive services. It doesn't talk about how strong an economy is. It's saying that everyone should be able to get the care that they need when they need it, where they need it, without financial hardship. And this doesn't distinguish between low income, middle income, high income. But that as a human, the dignity that we should have is that if you find yourself sick with an injury, you should be able to have access to care. But they further compartmentalize it to say it's not just health promotion, prevention, it's not just primary healthcare services. I added the word surgery there because often we are lumped as treatment, you know. But if you look at it and what it means, it represents that even someone who needs surgery, wherever they are, should be able to have it, including rehabilitative and palliative care. And so we should start off with this point of saying we agree that everyone should be able to have access to surgical care, that it shouldn't depend on where you come from or where you are in the world or how rich or poor your country is. Everyone should have this. And so as you try to make a case for why surgical care, you need to remember that. So many of these figures, many of you already know, but I thought I'll frame it slightly differently because we know that at least 7 or 6 out of the 8 billion people in the world will have access to primary healthcare services. If you're sick, you will be able to get into a hospital or a clinic where you'll be able to get basic services. But the problem comes when surgical care is required. And so, and if you start comparing what's the difference in high-income countries and low-income countries, access to care, the disparity is too wide, the disparity between access to surgical care. But if you only talk about increasing the number of surgeries, you'll see from the African Surgical Outcome Study, which I was part of, and some of you in this room, that it's not just about offering surgical services, it's about providing safe surgical services. Because when we don't manage these interventions properly, people die in our hands, and then we become the problem as well as surgeons. This was a sub-study that we did also from the African Surgical Outcome Study, where we looked at the women, the population of women that had surgery. And we compared the African women from the African countries with women from the UK and other international high-income countries. The women in Africa were younger. They had less complications at the time. They had less comorbidities. So we would expect that they would have less complications because they were healthier at the time of going to surgery. But instead, what we found was that despite the complication rates being similar, the in-hospital mortality in African women was 47% compared to 18% in the international cohort. So something says that something is going wrong somewhere if young women who are healthy come into our surgical theaters and have got a much higher chance of not surviving. So we need to think about the patient experience. We need to think about the human experience. When we talk about access to care, how many hurdles does a patient need to jump to get surgery? And we all know that because whilst we're on the receiving end, we know that there are long and long stories about patients going to clinics, being sent back. Eventually, they get an appointment with us, they are canceled, all sorts of issues. So we need to think about access to care, not just in terms of making the service accessible, but are the services available? There are hospitals that you will not want to end up with if you have a head injury, right? Because you know that you're not going to get the treatment you need. And even if you have a cardiac condition, we all know that our hospitals are not the same and are not able to provide all the services. But also, some of our services are also not acceptable to our communities, and hence they'll rather go and seek healthcare access. As you mentioned, President, this morning, that sometimes they are not interested in the science, not because science is not important, but because the scientists do not care as much. You come into our hands, you get shouted, beaten, ill-treated, and that wears on patients and their dignity. But I think more importantly for the African context is affordability. Our patients in some countries have to pay before they get operated. In other countries, operations are free because healthcare is free. In other countries, they'll operate on you, but they won't discharge you. So I'm not sure what the situation is here in Uganda. I hope you're not locking up patients just because they haven't paid. But that's a conversation for another day. What I want to say is where we live matters. You know, we all treat our patients, especially if you've gone through the medical system like mine, where this is the appendicitis, this is the ectopic. We treat them according to the disease they have. But in reality, how well they do actually is going to be determined by where they come from. I don't need to tell you a story, but I'm sure you can see, you can already predict what type of outcomes you're going to have for a patient on the first slide who is not going to present with symptoms of breast cancer early and will not get the treatment and is much more likely to die from breast or cervical cancer because they couldn't access healthcare services compared to your patient who can even call the oncologist into their home. So we need to think about these things. So part of global surgery is looking outside of the surgical theater. And why it's important, you know, someone asked earlier that do we need to go become politicians? And I love the answer that yes, some of us will need to do some of the politics because we've always assumed that someone is doing the politics on our behalf. But travel the world, go into world meetings on healthcare, on medicine, and you'll find that no one is advocating for the surgeons because the surgeons are busy in theater cutting, and also because the surgeons have not translated this information enough. I had a choice as a gynecologist because I felt that I could really make a difference one cesarean section at a time, until I realized that at some point you've got no control over what your colleagues are doing, and the same deaths that I need to report on and had nothing to do with me and my skills, had a lot more to do with poor health systems and that no one was really regulating that, or those who were trying to didn't understand it enough. So we have to ask our questions. How is surgical care financed in our country, in our countries? How do patients get access to the hospital? You know, in some places, so in South Africa, where, you know, South Africa has a whole history with apartheid, where there were hospitals that were previously designated for white patients. In those hospitals, they do not have private transport. So taxis, which would be the way that people get to the hospitals, do not come there because that was the way of stopping black patients from getting there. Now, so many years after democracy, those taxis are still not going there, and patients are still not accessing those hospitals, which are now for everyone. So sometimes we have to think beyond what is happening in front of the patient, in front of me, and start to look at what ecosystem do they live in? What is the local burden of disease? If in your place you are treating, you know, same thing over and over again, is there something unique to this area that needs to be looked into? If there are injuries happening all the time, what's the state of the roads? What's the state of the infrastructure? We have to think beyond just what we're seeing and think about where the patients are coming from. So what are the barriers to surgical care in Africa? And these are generic. Whether you come from South Africa, of course, when you fly to South Africa, we'll show you the nicest parts of South Africa. But if you come to my village, you'll get a better experience of what the country looks like. So these are across: lack of services, delays in access to surgical care, shortage of specialists, shortage of equipment, shortage of resources, lack of multidisciplinary care, poor infrastructure. These things have been mentioned. But unfortunately, you become the person looking after the patient, and at the end of the day, most likely the person who's going to sign that death certificate, but you had nothing and no control over the things on the other side of the screen. But I tried to do my own research to understand the barriers to surgical care in Uganda, and this was a paper. I like the title. These same things are mentioned, long distances to hospital, limited transportation, low waiting times, power outages. I don't know, are these things true or not? Sometimes when we read the papers, you don't know, is this an accurate reflection that these are the things that have been described? And it feels very similar to the challenges that we also have in our countries. But the real delays to accessing care are in patients seeking the appropriate medical care, delays in reaching the appropriate facility, and delays in receiving the appropriate care. And that is the one that we have control over in this room. We may not have as much control over when the patient decides to come to us, but we have control over what happens. And I made this example where a patient says, it took me a long time to get to the hospital after having to borrow money. But even when I got there, they did not have enough doctors or medicines to treat me. That's the patient who's not going to get a surgical operation when they need it. And we need to think about the services that we provide. And I always say, where I come from, they've done one heart transplant. I asked a few months ago, because the first heart transplant was done in Cape Town, in the Western Cape province. So I asked our provincial minister, that is our province doing heart transplants now, that, it's been many years. And she said, we've done one. I think it was done for the newspapers and it was celebrated. But the burden of disease and cardiac pathology continues. Whether the service is there or not, the burden of disease is there and it's significant. And so the idea that people are going to cross borders and travel to other countries, in my place it was people who travel to other provinces. It's still happening to access care. But how many people are traveling across borders to access surgeries and care that should actually be available? I was reading in there about the number of patients that travel to India and other countries, and that as we strengthen the surgical system, it will reduce also the medical tourism, that we know the migration happens. We don't want to talk about it, but it happens because people want their lives to be saved. And if they can't find help in our hands, they're going to go and look for it elsewhere. So the drivers of poor surgical outcomes are access, just basic, are the services available? But safety, is our surgery safe or not? And then the quality of care becomes the other important ones. The determinants of health, we talk a lot about the social determinants of health, but there's economic, there's political. What's in the policies? The paper that was presented this morning around surgery doesn't appear. Often, if you look at these political policy documents, surgery doesn't appear. And that means that preventative measures are not prioritized. It means health promotion and other measures are not being governed at political level. And then the geographic and biologic. And as we know, a lot of us in medical school will be taught about the biological. Now we're starting to talk about social. The problem with emphasizing social, it puts the problem in the patient's hands. It's like you're saying, because you are poor, you are unemployed, you cannot get the kind of care that you need. But I like to talk about the political determinants of health, and I'm happy you don't have many politicians today, because I won't get into trouble. That it's important that we talk about this. Now, we've spoken about the drivers to bad outcomes, but what are the drivers of health? Now, we want a healthy population. Before we talk about providing surgery, we need to talk about how do we ensure that our populations are healthy. And this was a very interesting paper which showed that only about 20% of the drivers of good health care are clinical. So, which means you can train as many surgeons as you want to, you can improve equipment and all of that, but that's only 20% of the job. So do we need to be political in how we handle healthcare as surgeons? I think so, because if all the effort is just about training better surgeons and creating better facilities, what about the 80% of the factors that determine our health outcomes? I like this quote by Professor Mahmoud Fatala. He says, women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. And the reason why our communities are not advocating for safe surgical care is because they don't know that they deserve better. You know, they don't know. You know, if they knew that if they support the surgeons, the Association of Surgeons of Uganda, that their lives will be longer, they'll contribute better to the socio-economy of the country, they'll get better jobs, I think then they would start advocating. So we need to think about the stories and how we tell the stories to our society. In my early days, my PhD was on cesarean section hemorrhage. And so you can imagine trying to advocate for cesarean section hemorrhage. No one knows why you're talking about it and why it's important. Then we wrote a paper, very simple, that African women, we could save more lives by doing more cesarean sections in Africa. Suddenly, everyone could understand and could hear that, okay, people are dying, you know, and they didn't even know that there was an issue on the continent. So the real message of global surgery is that there is a gap between surgical services and surgical systems. And global surgery aims to bridge that gap. The work that we have developed at the University of Cape Town, we define global surgery as this interface between surgical services, surgical systems, and surgical leadership. And we put surgical leadership because you can understand health systems and work in public health, but it's ultimately the politicians who will decide what to prioritize, where to invest. The decision makers need to be part of this triangle if we want to make access to care safer. So global surgery is surgical system strengthening. And in surgical system strengthening, what we try to do is increase the number of surgeons, decrease the need for surgery, improve surgical outcomes, increase the number of surgeries, and increase the cost effectiveness of surgery. This is a framework that we have developed for ourselves and hoping we will be publishing it soon, but it is available online on our website if you want to learn more. So before I go into some of the solutions, I'll talk briefly about why I transitioned from a life of surgery to a life of global surgery. And I put in that quote that, you know, I started discovering that there were health systems factors and issues, but no one was teaching me how to treat a sick health system. You are taught how to treat a sick patient. You are taught that there's a health system, but you're not taught that there are ways of treating a sick health system. And so that was my journey outwards. And so some of these stand true as facts and quotes that I stood by, that diseases don't have borders, but health systems do. And so if you want to ask why is the perioperative mortality rate higher in Uganda than in Rwanda, than in Cameroon, than in South Africa, you will understand that what is different, it's not the disease, it's the health system, how it's governed, what investment goes into it. So often, as I say, you'll train more surgeons, but the decisions that govern the surgery that you do are the thing that we often fail to address. And that's where the real problems are. as a cesarean section is the same. Anyway, go across the world, it's the same. What's different is the operating bed, it's the medication, the availability of antibiotics, the recovery, all of those things, and it's the systems around the surgery that we do. As clinicians, we are only as good as our health system. I used to do what we call community obstetrics, visit hospital to hospital, clinic to clinic, do outreach. In some places you get there, you want to operate, they've got a sick patient, they say, no, we don't have an anesthetist, you can't, it's too dangerous. So the surgeon never changed, but the setting changed, and suddenly you couldn't do what you could have done in another place. We now know how to treat diseases, but no one taught us how to treat sick systems. And part of what I've been trying to bring into global surgery with our team is how do you remedy some of these situations. So these are our recommendations for how to treat a sick system. I'm going to go through about 5 or 6 of them. The first part is what we call health system preparedness. COVID helped us in global surgery because before no one understood systems, you know, and that wasn't a popular way of thinking. But then now there's a whole preparedness. Everyone's talking about preparedness, but it's preparedness for pandemics, you know. I say sometimes that what if we just called injuries a pandemic, or we call cancer a pandemic? Because the numbers are obviously much higher, but because we don't call it a pandemic, no one feels that they need to put a lot of care and investment in there. So for health system preparedness, we need to look at infrastructure, health workforce, skills capacity, equipment, medicines. These things, when you train to be a surgeon, no one teaches you all of these things, but these are the things that will ultimately determine how well you can function in your job. Surgical prevention, again, we think there are primary healthcare people out there doing surgical prevention, but many of them are doing prevention of pregnancy, infectious diseases, etc., and not for surgical conditions and not for cancer. So we need to start looking at how can we collaborate or partner or even do it ourselves. This was a men's health talk that we ran through our division. The person giving the talk is a urologist, a very well-known South African urologist who could take his time off to go into a township and educate men and community healthcare workers on cancer. Then we have to look at surgical safety and human behavior interventions, and this is surgical training. How do we capacitate our medical officers, the junior doctors, those who are doing anesthesia, who are not anesthetic trained, etc. How do we make increased capacity, quality improvement interventions? In some of your theaters, I don't know, maybe let me say in some of our theaters, surgery will only start at 9:30 or 11 or 12, you know, because the nurses will not let you start before that, and the anesthetist will not, you know. And a simple quality improvement intervention to reduce or to make theater start early could mean that you've got more and more effective surgical theater, a more productive one. Risk scoring systems, checklists, etc. We start looking at what are the practical things that we can do to make our service safer. Communication, how we speak to our patients. We often say acceptability. We talk about acceptability, and it's usually a communication thing, how we speak to them. You know, sometimes you can have a poor outcome, but have a patient who feels that you did the best that you could do for me. And that patient is, you know, the patient who's going to sue you might even be the one you did everything for. You know, 4th laparotomy, relook laparotomy, but not because you didn't do everything, but just because of how they engaged in the system. It's toxic, it's hostile, And so we have to look at how we communicate. Capacity to rescue, which is a surgical concept, because I try to, let's keep some of these things also clinical. You know, sometimes people think global surgery is just outside of the hospital. A lot can be done inside of the hospital by surgeons. But failure to rescue is the idea that not every complication is preventable. And so the health system should be able to identify, to treat. You know, when our patients are dying from surgical complications, it's failure to rescue. And so we need to think of what systems do we need in place so that patients that shouldn't die are not dying in our hands. Then I want to talk about systems thinking. When you move out of, medicine is very linear thinking. A patient is bleeding, stop the bleeding, and then do the next thing, look for the next patient. But working with systems requires a different approach, because you mess with one system, it topples all the other systems. And so I've also seen some of the work with NSOAPs, for example. Countries have been very resistant, because if you put a surgical plan, what about mental health? What about pediatrics? What about all the other people? And so when we don't approach it with a systems thinking approach, we are less likely to succeed. And if your health system is bleeding, it takes many, many years, and so that's another thing. As surgeons, we want NSOAPs, let's solve this problem now, but we don't think about all the complexities of working in a different type of system with different ecosystems as well. So stakeholder mapping, from my days where it was me and the patient, all I had to worry about is the nurse, the porter, the physio, the OT, and suddenly you have to worry about the politician, the public, the church, the traditional healers, the investors. But that's what global surgery is about. It's about looking beyond what can I do right here to who are all the stakeholders and engaging in them, with them, the managers, so people that you would not necessarily have had to plan with. But when you bring them in, you accomplish a lot more. So I'm going to start closing up, because what I want to bring is, I've showed you the problems that the world has, the problems that we have in Africa with regards to surgery. And I've shown you different systems interventions that you can look into. But I also want to say that you need context-specific interventions. It's not one size fits all. And if we're sorting out the issue of roads in Uganda, we must go do the same thing in another country, We need to identify what are our unique problems and what are our unique interventions. And so this is the obstetric transition model, and I use it as an example because I like how they split interventions according to maternal mortality rate. That in a place where your maternal mortality rate is unacceptable, it's high beyond high, where you just have to think about how long does it take for a patient with an eclamptic fit in a community to drive around the mountain to get to the healthcare facility. Your interventions, they will be different from a country where maternal mortality has almost been eradicated. So it requires that we really understand our systems so that we come up with solutions that are context-specific. And if we are all doing this as countries, as regions, as districts, then eventually we'll start seeing a difference. But for me, I think the biggest investment that we can make is investing in surgical leadership. I will say, I'm bold enough to say that I don't think we have a surgical problem. We have a leadership problem. And at the end of the day, you have to think about the care you want to give to your patients. You have to think about the electricity, the water, the air cons, all of those things. the medications, how do you decide what's important? And you're competing with your colleagues from medicine who have perfected the art of negotiating and the mental health and pediatric health. We need to invest in surgical leadership so that in whatever capacity you're doing it, whether as a surgeon, as an anesthetist, as a public health specialist, as a policy maker, we are equipped to make the right surgical decisions that are going to improve healthcare for our setting. So at the University of Cape Town, we launched our global surgery division 5 years ago with a vision to improve the quality of surgical care in Africa through research, capacity building, implementation, and advocacy. My personal dream and vision has been to lead an academic program to build surgical leadership in Africa and internationally. We run various programs, an MSc in global surgery, a PhD in global surgery. We've got an executive leadership course in global surgery, which Prof. Chiamanwa is a proud graduate of. I'm adding that because you can only imagine when we received his CV, we thought, is this the right, is this the right degree? It's not every day, but it is a leadership course, and of course, the caliber of people you want are those who are going to make changes and influence change. But because of this, our heart is closely tied to Uganda, and we would love to support in whatever way we can the surgical system strengthening. So I will conclude by saying global surgery is about access to safe and timely surgery in Africa, and it's about bridging the gap between surgical services and systems. And I hope I've convinced some of you not necessarily to quit being surgeons, but to also think about surgical systems. Thank you very much.
I think that is a very timid applause. Yes, thank you. Thank you, Professor Salome, for opening this session with such a very powerful presentation. Personally, I've captured 4 key things, and that is systems thinking is important, context is important, leadership, and advocacy. So those are the 4 things I managed to glean from that presentation. Thank you very much. Now, I would like to take you through a creative moment, just so that you can digest. There are notebooks in front of you and pens. Can you draw a cartoon or any image of a biomedical engineer? Just scribble. It doesn't have to be as good as Spires, but just draw a biomedical engineer. Okay, are we done? It should be just a sketch. Okay. I'm looking at the last person. Yes, okay. He has already torn the paper out, so that means it's done. So, what is the gender of your engineer? How many have females? How many have males? Okay. So you are in for a great surprise. So our next speaker, ladies and gentlemen, is Paula. Paula is a biomedical engineering graduate, Paula, and she is especially interested in the fields of biodesign, research and innovation. She is passionate about applying frugal science, frugal, mark the word frugal science in the development of global health technologies, which possess the key features of affordability and accessibility. She currently works as a junior research fellow at the design tube under the Makerere Biomedical Engineering Unit. So we have female biomedical engineers, ladies and gentlemen. You're welcome.
Thank you very much, Prof. Good afternoon, ladies and gentlemen. Yes. As earlier introduced, my name is Kwere Kwapola, and I work at the Biomedical Engineering Unit, which is under the School of Biomedical Sciences, Makerere University. And we are headed by Dr. Robert Sechitoleko, who is just there in the audience. And today, I will be talking about an accessible laparoscope for surgery in low and middle-income countries. Particularly, I'll be talking about how we are navigating systems to ensure that this key scope is brought to the Ugandan market. Yes, Professor Salome has done a very good job of introducing us to the need for improving access to global surgery. And as biomedical engineers, we just try to bridge this gap by applying technological solutions to ensure that we become better as the low and middle income countries. So as she had mentioned, about 5 billion people globally lack access to surgery, where more than 4 million people will die within 30 days after surgery. And this need is especially pronounced for laparoscopic surgery, where laparoscopic surgery is the standard of care for the developing countries, where about 90% of the procedures would be done laparoscopically, basically because of the well-documented outcomes. It will take a shorter recovery time, there will be less post-surgical complications, and so on. So this fits into the key scope, which we have developed. So the key scope is, I'll first move to the next slide. So it's on the left. It is a single rigid laparoscope, just one unit. So unlike the standard of care laparoscope, which has, there's something, I'm going to put a disclaimer, I will use some engineering terms, but I hope you'll be able to keep up. So in surgery, in the hospitals, they are very delicate fiber optic cables. That's why they break down consistently, or they are supposed to be handled with care. So we try to move away from that by using a CMOS detector. So at the tip, there will be a small camera and small light emitting diodes that will produce light. And then in the handle, we have a printed circuit board that controls the whole system. And as you can see with the picture on the right, this system is, it's just a plug and play, where the device will be plugged into a laptop, and we are hoping that this will improve access to surgery. So just to be clear, this is a suite. So we call it the key suite. It has the laparoscope, and then a mechanical retractor, which has its stand, and my colleague will later talk about this mechanical retractor. So we are, it's in twofold. We are trying to develop a low-cost system and also try to move away from using carbon dioxide for insufflation. So we are using mechanical retraction. I believe previous speakers have talked about that, so my colleague will talk about that a little bit more. Yes, so we are using a human-centered design approach. So we identified this problem by interviewing a number of surgeons, and they told us the problems they face. The machines break down often. There's intermittent electricity, and then the high cost of the carbon dioxide that's used for insufflation. So that was a background that informed our design. So this design was initially created at Duke University and the University of Maryland, And slowly by slowly, we are transitioning into ensuring that we can manufacture this key-scope locally. And this is because it is believed that technologies which are developed from the exact context they will be used are the ones that are most successful. So you cannot develop a technology from the US and expect it to be exactly relevant in the Ugandan context. There's variations in power, variations in humidity, variations in the technical capabilities of the health workers. So that's why we want to do something locally, and hopefully it shall be easier integrated into our healthcare system. So we developed a bill of materials, scoped the Ugandan market, tried to find these different materials, tried to find the facilities that could help us manufacture. So we have identified facilities that, like the Uganda Industrial Research Institute, where the government has put state-of-the-art machinery to help us with manufacturing. So we are just trying to leverage these existing resources and make sure that our technology can get to the market. So that's just a comparison between the device that has been made at Makerere and the one at the University of Maryland. And on the left is all the individual components broken down. So we apply something known as frugal engineering. And to the common understanding for frugal is cheap, but we choose to believe that frugal means doing more with less. So our design tries to use the least available materials, but we do not compromise the functionality in turn. So as you can see, our laparoscope is able to produce an image which is comparable to the standard of care. And one other thing, this laparoscope works hand in hand with a software, so which will be an interface. So you could connect to a laptop, be able to view whatever is going on as shown in the image there. Yes, so that's a comparison between, so this was during a pig study that was done at Duke University. Up is the standard of care laparoscope, the image captured, and then below is the image captured with Archiscope. So the building of this technology has been, so we've tried to simplify it to as low as possible, because we recognize that part of the problems is limited technical expertise. So we anticipate that in case this breaks down, how quickly can it be fixed? So trying to make it one unit, there's nothing very complicated. And this was engineering students at Makerere trying to build the prototypes. Still in the construction. And yes, for every technology that is developed, you have to evaluate it. So there are optical parameters and functionality tests that we carry out. Is color reproducibility okay? Is the resolution okay? Is the depth of view okay? Etc., etc. So we've developed a testing chamber, and we can be able to develop, to test all these parameters. And those are part of the results we've got, where the resolution is comparable to the standard of care. Yes, what are our next steps? So we've been in the research and development phase, and we are now moving towards manufacturing. We've partnered with a local company called Shishi International, and we are hoping that we shall transition this technology from our laboratories, and hopefully it shall reach the Ugandan market. So our goal is to have Our goal is to have a device with a label made in Uganda. So we've made animal studies. We shall conduct a first-in-human study at the Uganda Cancer Institute, as shown in the schematic. I shall try to move on fast. We've tried to adhere to international standards such as quality management standard, that is ISO 13485. We are trying to obtain a good manufacturing practice certificate from the National Drug Authority. We've also heavily engaged with the Uganda National Council for Science and Technology. And as Professor Salome had said, COVID has awakened all these systems. So all the key players in Uganda are trying to support local manufacture because the need was heavily recognized during COVID. So the National Drug Authority has put up some guidelines for development of surgical tools and instruments, and that's what we are currently focusing on. So today, we are here to invite the surgeons to come and play a part as eye users. We hope that you shall join us so that we can leverage your skills, your knowledge, your expertise, since you are the end users. Tell us what is not good about the device. Tell us what is working perfectly. Tell us what you would envision. Tell us what other functionalities you would require. For example, we've previously engaged with a few of the surgeons, and they told us we would want a system that stores the images and then apply tools such as AI, and then we can be able to do, the AI can help us in the diagnosis process. So that is part of what we have so far. So we are having a workshop coming up on 12th of April. We hope that you can be a part and, as I've said, try to help us build a device and transition it to the market, because I'm very sure if you saw a device with the label made in Uganda, you would brag and say, I was a part of that team. So please come and join us. Those are the references. And that is the team, the local PI, Dr. Robert Sekteleko, Dr. Tamara Fitzgerald. She's a pediatric surgeon in the US, and Dr. Jenna Muller, who is a biomedical engineer, and the rest of the technicians. This work was funded by the National Institute of Health for the development part, and for the translation process, we are being funded by the Wellcome Lip Save. Thank you very much.
Thank you very much, Paula. That's great inspiration for us. And I think we are moving in the right direction as surgeons to have conversations with biomedical engineers, because most of what we do involves your work as well. We now have our next speaker, not far from where she is, also a biomedical engineer. And this is Kato Hussein Wabi. He's a biomedical engineer also working at Makerere University. He describes himself as an innovator and a researcher. So we are in for a great submission. Currently, he's employed under the Wellcome Leap Keysuit project as a technical lead and quality officer. So quality is one of his things. As a quality officer, he's leading the acquiring of regulatory certifications for medical devices development for the project. He has led a number of innovative products and projects that are still delivering even more products. For example, a thermal bed, a cooling device to mitigate brain damage due to neonatal asphyxia. I think even for head injuries, we might call you to help us. So he's also looking at low-cost compression cuffs to prevent DVT. So I think you are in the right sphere. You're welcome, Omulongo Kato.
Yes, thank you so much, Prof. As earlier introduced, I'm Kato Hussein Wabi, and I'm the technical lead of the project. It's going to be a continuation of what Paula has presented, and it's the key loop together with the key stand. So So the project, as Paula said, it's under Welcome Leap Save. It's the KISUIT project. A KISUIT meaning it's comprising of a lot of different parts. So Paula has presented the key scope and the key view, and then we So before presenting the key scope, the key stand and the key loop, I just want to look at why laparoscopic surgery is not being well utilized in sub-Saharan Africa. So this is in addition with what the previous presenters have been talking about. We see that laparoscopic surgery is very expensive. Buying the unit itself, it costs around $200,000 US. And then in addition, Paula did mention that the standard of care laparoscopes, they rely on optical fibers, and these require high maintenance, and also the use of consumables, that's carbon dioxide for insufflation. It makes the surgery of laparoscope more expensive, and also it requires less continuous consumption of electricity. And this makes it inaccessible for low and middle income settings. So our project is looking at bridging those challenges and solving them in introducing our device. So in that, I would introduce the Kiro retractor. This is a mechanical abdominal retractor that eliminates the need for carbon dioxide and continuous pressure regulation in the abdomen, as it is for the standard of care laparoscopy. So the design of the key loop, as we see it, the image A, it's the key loop. It's a semicircular, and it's made out of one material that is biocompatible medical grade stainless steel, and it comes in various diameters depending on the patient height and weight. So in conjunction to the key loop, it works with a key stand, and I'm going to be talking more about the key stand, which is in the image number 2. So, yeah, the key stand the key stand is used to hold the key loop retractor so that we can be able to maintain that intra-abdominal position. And it's also made out of a single post, low-cost bedside retractor. And the materials, this is being sourced locally available as we are doing local manufacturing. So to use the key loop and the key stand, it's really a simple procedure. After making the incision, we need to choose the appropriate side for the key loop. This will depend on the patient's weight and height. And then we have different dimensions ranging from 49 to 86 millimeters. And the diameters for the key loop also are different for the minors and the adults. So for the adults, it's 5 millimeters, and for the minors, it's 3 millimeters. And after choosing the appropriate size, we have to insert in the key loop. We use that smooth-end semicircular end, which is inserted into the abdomen, and then you rotate it to insert it, and then after you secure to the key stand. So after retracting, you hook it and clamp it on the stand to have that intra-abdominal exposure. So the images we have are just, we are on a workshop, and it was more of illustrating the usage of the key stand and the key loop. So this is the entire assembly. This is just showing it was inserted in a shirt, not the abdomen, and the setup is the other side. Yeah, so we have done a number of tests on the key loop retractor, and right now I just want to talk about the evaluation of safety and feasibility that has been done in a porcine model. This was done by our team in the US, and the paper has been published. And looking at just the background as earlier communicated, the key loop is eliminating the need for continuous use of carbon dioxide and reliable electricity. So we are also, so for the methodology for our evaluation of safety and feasibility, the study involved 5 surgeons And of the surgeons, we had 1 female and 4 male. Of them, we had 3 gastrointestinal laparoscopic surgeons and 1 oncologist surgeon and 1 pediatric surgeon. So they did 60 tasks in 15 pigs. So this were the participants and what they did. And the procedure required each surgeon to complete a number of tasks using the porcine model. We are relying on our kilo retractor and versus the standard of care. And if I say standard of care, that means use of gas, carbon dioxide in laparoscopy. So the tasks that we are done, we have evaluating the laparoscopic exposure. This involved, for the kilo, it involved making a 10 millimeter incision in the center of the abdomen. Then they inserting their fingers to make sure that we don't have any adhesives between the small bowel and the abdominal wall. Then for the standard of care, it involved making the 10 millimeter laparoscopic port in the center. Then you inflate with 15 millimeters of mercury of carbon dioxide. And then we have all the other tasks with a small bowel resection, intercorporeal suturing with knot tying, and cholecystectomy. Those were the tasks that were done. And the evaluations it involved looking at the vital signs, task completion time, the time that they took to complete these tasks, the blood loss, among others. These were compared with the standard of care and the K-loop. So in addition to that, we had a survey that was done on the surgeons to evaluate and get feedback on their perceptions of the K-loop. So the results, I have the graphs here, but let me just summarize it here. The task completion, looking at that task, there were no significant differences in task completion between the K-loop and our standard of care. This testing, the standard of care, remember this was done in the US, and these surgeons were already experienced with the standard of care. So we wanted to evaluate the K-loop versus the standard of care. So there are no significant differences, as we are going to see on the curve, on the graphs. And then the learning curve was also not having a bigger difference between the surgeons familiarizing themselves with the K-loop and versus the standard of care. Then regarding the safety, we didn't get any significant blood losses.
2
and
minutes.
Yes. Sorry, the feedback regarding the survey, we got feedback from 11 surgeons from the US and Singapore who endorsed the K-loop for continuous use. And then the conclusion that the K-loop and the standard of care gas laparoscopy, they showed similar performance regarding the safety and evaluation of feasibility. And the data supports it as we see the graphs. This is a graph for operation times. It is representing, the boxes are representing the interquartile range, and the dash in between is showing the median. And bars at the top and the bottom are also showing the high and lowest time taken. So we see for the laparoscopic exposure, it was quite a bit high because they were already familiar with the standard of care laparoscopy. That's why it took them a lot of time to familiarize with the K-loop. And then the small bowel resection is really nearly the same, and the same with the other tasks that were done. And looking at the vitals that were measured, still it wasn't that significant difference. So the roadmap for the K-loop, K-suit project, remember the K-suit involves the K-loop, K-stand, K-view, and the K-stand, the K-loop, K-scope, K-view, and the K-stand. So we are looking at local manufacturing. We need to manufacture these devices locally, as Paula said. If technology is going to be used in Uganda, we need to have it manufactured in Uganda. So we are looking at the translation, and this involves navigating the regulatory landscape, and it requires getting a GMP, good manufacturing certificate, that is from NDA, and I'm the one leading that work. And also to do the clinical trials, we have to have the GMP. We have our devices to be manufactured in a GMP certified environment. And in addition, we are looking at getting the international accreditations. That is the ISO 13485 and a CE mark for our device. So also, we are looking at contractual manufacturing. And the roadmap is not straight, meaning we get a lot of hurdles and challenges in the journey. Thank you. So these are our references, and that's our team.
Yes, thank you very much, Isaac Hussein, for that very good research and trying to take it to the next level. I think you are challenging us not to leave our research in the department, but take it to the next level. Our next speaker is going to tell us about how the technology and innovation is working in ophthalmology. Now, this is an interruption that is necessary because Dr. Angela Merik Birungi, an ophthalmologist, has traveled from Mbarara to be here. She is a specialist she's a specialist ophthalmologist and trained in Mbarara. She's now a postgraduate student, again in Mbarara, and a member of the Ophthalmology Society of Uganda, where she holds an executive position. And she's passionate about research, especially especially the eye public health. I think we are not doing enough of public health. As Professor Salome told us, we tend to be clinicians more than advocates and public health people. So she's in the politics of ophthalmology as well as in the clinical practice of ophthalmology. Please welcome our speaker to give us her experience. Angela, you're welcome.
Thank you very much. Yesterday, a surgeon colleague cracked a joke and said, they usually forget that ophthalmologists are surgeons. So I'm here to remind you that ophthalmologists are actually surgeons. Yes, we operate. Yes. So I'm going to talk about the status of corneal transplantation in Uganda. And yesterday we had quite interesting discussions about organ and tissue transplantation. And no disclosures. So when we talk about corneal blindness, corneal blindness is low vision that is resulting from diseases of the cornea, but many times a patient already has a corneal opacity or a corneal scar. And the only treatment for this corneal blindness is actually corneal transplantation. When we think about vision, we never appreciate how important it is. Not until you close your eyes for 1 hour and imagine how much your life would change if you lost vision. So it not only impacts the general well-being of an individual, but also as a community at large, and also the country at large. Because at the end of the day, we are going to lose productive hours. Children are going to stay at home looking after someone who is blind. So the burden of corneal blindness in East Africa, it's actually still a very big challenge. And in Uganda, we have 30.1% of all causes of blindness being attributed to corneal blindness. These are things that come from trauma, keratoconus, as we shall see. And the story is quite similar with our neighboring countries. So this is a cross-sectional survey that we decided to carry out, and not only in Uganda, but also in other neighboring countries that form part of that are members of the College of East, Central, and Southern Africa. And this is data that I'm going to present that only concerns Uganda. And the respondents were ophthalmologists from the different eye hospitals in Kampala, and rather in Uganda, and hospital administrators. And the duration of study, this was January to December 2022, and we got approval. So we decided to carry out this survey to determine the capacity of other different countries in carrying out corneal transplantation. But in this case, I'll present information that is specific to Uganda. So we had 5 hospitals that participated in this survey, and these are eye hospitals. We had both private and government hospitals participating in this survey. And out of the 5 hospitals that participated, only 2 reported to have carried out corneal transplantation in 2022. And remember, that is a year that was just immediately after COVID. So only 2 hospitals reported, and only 15 corneal transplants were done. Only 15. And of all these, this was penetrating keratoplasty, that is using the entire corneal tissue to give it to only 1 patient. Usually it's possible to use 1 cornea and use it for about 4 people. Just 1 cornea can benefit 4 people. You can split it into different layers, different parts to benefit different people. But if you're doing penetrating keratoplasty, that means 1 cornea will most likely be for 1 person. And 100% of the tissues that were used were imported. There was no local retrieval that was reported. And in 2022, there was a backlog of 277 eyes that needed corneal transplantation surgery. So these are people who are living with corneal blindness. Unfortunately, a number of these might have bilateral corneal disease. Some of them are school-going children, as we shall see in some of the indications of corneal transplantation. So they literally have to maneuver through life living with this challenge. So some of the indications that were reported for corneal transplantation, the highest was microbial keratitis, that is infection of the cornea. And then second was trauma. Yesterday, Honorable Charles Ayume hinted on the issue of trauma. Mulago receives about 60 cases of trauma per day. So there are times you're going to get a very injured cornea, and the only immediate emergency management is corneal transplantation. If it's not done, well, someone will just have to live with their blindness. And then keratoconus. Now that is a disease of adolescents. That is the time that it mostly presents. So if a child is not able to access this surgery, they might even drop out of school. So what are the barriers that were reported? The biggest challenge was cost. Currently, you need about an average of 8 million to have a corneal transplantation done. And on top of paying the 8 million, you have to wait because the tissue has to be imported. And it's imported outside Africa. The laws in our neighboring countries do not permit export of tissue from their countries to ours. So you can only get tissue from outside Africa, Sri Lanka, America, India. So there is a long waiting time. It can never be done as an emergency. Yet sometimes corneal transplantation should actually be an emergency. And then the other issues were the surgeons. Do we have the capability to actually carry out this surgery? And then definitely the religious issues, cultural barriers that were already hinted on yesterday. So yes, we currently have the law in place, but as we discussed yesterday, the law is not currently permitting cadaveric organ retrieval, because for a cornea, someone should have died, and then we are able to retrieve the cornea. So yes, we have the law, but still we are not able to retrieve the corneas locally. So we have to rely on importing tissue. And then when you talk about the human resource for eye health, who is going to be able to do this surgery? Currently, there are 56 active ophthalmologists, only 56, of which 30 of those are in Kampala, about 10 are in Bara, and the rest are somewhere distributed. So the ratio of ophthalmologists to the population it's too poor. Like, we are supposed to be having 4 ophthalmologists per a million, but we only have roughly 1.3. So if you round off, you can't have 1.3 surgeons. So that is 1 surgeon, ideally per a million population. And then specifically for the anterior segment surgeons, those who have the capability to do the surgery, in the country so far we have 3. And in this survey that we have done, because we also sent out the survey to other countries, and this is very important for us to learn from what they have done. Ethiopia so far does the highest number of corneal transplantations in Africa. And sharing their experience, they have been able to achieve this one because, yes, they have the law, they have the local eye banks in place, but also the publicity, the advocacy, talking to people to be able to accept to donate their corneas. It's not something that is easy. And some of these have been able to incorporate donation, tissue and organ donation into the other services of blood banks, such that as the blood bank goes out to collect blood, convince people to donate, they can also talk to them and spread this gospel of donation. So this is one of the ways that they have been able to get people to donate. And then the other country is Kenya, that is currently able to do retrieval and transplantation. So in conclusion, corneal transplantation capacity in Uganda is still lacking. And we are not able to meet the population needs. If we had 277 eyes in 2022, I wonder how many more we have this year by now. And infectious keratitis and trauma are still the leading causes. And the biggest barriers are lack of tissue and the very high cost of surgery. Many people are not able to afford this. Therefore, setting up local eye banks and building our own capacity as ophthalmologists is going to be one of the ways that we are going to be able to fight corneal blindness. And we appreciate all the eye hospitals who shared their data. Thank you very much.
Thank you very much for sharing that ophthalmology aspect. Now we are aware that you are also surgeons. Yes, so we welcome you back at the next occasion again. Our next speaker is going to be a distinguished general surgeon in the names of Emmanuel Boer. Emmanuel Boer is a fellow of the College of Surgeons of East Central and Southern Africa, and a honorary lecturer at Busitema University Medical School. He also holds a master's in public health, and now he's a global health scholar at the University of California, San Francisco, and the University of London. So he's bringing us some international experiences. His special interest is in advancing global health equity among medical students. He's a committee member of the Association of Academic Global Surgery. No wonder he's advocating for the students' role in global surgery. And that is what he's going to tell us about today. Emmanuel, you're welcome.
Thank you so much, Professor, and thank you for the 10 minutes. I think there will be enough. I just want to right away go to the presentation, but before we go, I just want to recognize the presence of some of my disciples in Incision, Uganda, which is an international students network that advances surgery. I think it's good to have disciples because we are all discipled in one way or another. I need some help here. The 10 minutes are running so fast. Okay, thank you so much. Like you've heard in the morning, a lot has been said about how much surgery is a neglected component of global health. And there is no doubt about that. The good thing is that this problem has been addressed, it's beginning to get addressed. And a number of stakeholders are coming on board, which is good news. The only thing is, and it's a question I ask myself always, where are the students in all these things here? So we set out to promote interest in surgical education, research, and advocacy among medical students. And this, of course, we are doing through the establishment and supporting of student-led surgical societies in all the universities, both public and private, under the guidance of principles of education, research, advocacy, networking, and so forth. So having realized that quite a number of medical schools are coming up with surgical societies, of course, with the support that we give, we thought it's important to have an umbrella body that helps to coordinate the activities of these surgical societies. And that is where Incision Uganda came in. And I'm glad we have the leadership of Incision Uganda here that helps to support the upcoming surgical societies, student surgical societies. The aim is to have a sustainable network that brings ideas together that can mutually benefit all these surgical societies. What we do at Incision Uganda is, of course, we pay visits, and this was one of the visits that we paid to the UCU School of Medicine. I'm glad that they have a surgical society that is up and running. Makerere University has one that is up and running. It's been around for a while. And then, of course, the Busitema University Surgical Society that was launched last year. I remember the president of Asou, Dr. Frank Asim, was saying, let this be a prototype for the establishment of the rest of surgical societies in the rest of the universities. And of course, a lot of preparations were made, a lot of paperwork, several meetings being held late into the night. And then finally, of course, this surgical society was launched on the 5th of May, 2023. It was quite a colorful ceremony. I remember the treasurer and the general secretary of Asou attending and giving talks. And there were, of course, a number of other guests, both locally and internationally, who gave talks on the launch. And of course, for the students, there was no better way to express their happiness about the launch, as you can see. They always say we are getting there. And I think I want to agree with them that soon they will be where they want to be. Some of the activities that are going on right now in those surgical societies is mentor-mentee matching. I have reached out to some of us here, and I'm just praying or making a formal appeal to every one of us here that tomorrow, if I reach out to you to mentor a student, be gracious enough to say yes. And of course, these are some of the other activities that are going on. They include, of course, like I said, training and mentorship. They include talks. People get inspired when they hear talks from different people. And of course, we've had a couple of talks from some of the mentors. And we are reaching out to different to different organizations to become corporate members of Incision and the different surgical societies. Now, these students identified in one of the activities, they identified crowding as being a big problem. And for us, ours is to encourage them to innovate something that addresses some of the problems they have. So crowding during rounds and operating room was quite a big problem. And this is the innovation they came up with. Of course, as you can see, someone just surrendered his television, a very small screen, but it's good enough for the beginning. And that is the kind of spirit we are encouraging medical students to have, that spirit of, ingenuity and innovation. We are having basic surgical skills courses that are already up and running. The idea is to have these things run in every medical school. And of course, there's a plan to have, a joint skills course for all the medical students. And that will come. And then, of course, the community outreach programs. We believe you cannot be a good advocate for something that you don't understand. So by sending them down to the community, we are simply saying, go and reach out to your people, understand the social determinants of disease in your community. And hopefully, you'll be able to manage your people better from an informed point of view. This is something that was borrowed from somewhere, and it works so well for even the students. The collaborative online video didactics. And this is an opportunity where people of different calibers come and give talks. The idea here is that they are online, so all the medical students from the different surgical societies could log in and have these didactics at the same time. And that's good because it encourages uniformity. Whatever is happening in Kavale will happen in Mbarara, it will happen in Gulu or Lira, and so forth. In future, this is something, again, that was raised by the students. I just want to say that all these ideas come from students. They want to have a joint international students conference on violence and injury. This is not possible now because some of the universities don't have surgical societies, but hopefully maybe by the end of next year, they will be everywhere. And so the work can begin here. Of course, as we do this, we are collecting information, we are making a few mistakes here and there, and we are learning our lessons. And very soon we shall be able to tell our story in a more scientific manner. So finally, I just want to say this whole idea, the model of surgical societies is a good one. It aims to improve access to care in LMICs especially, because students, in addition to what they learn in medical school, they are given skills that are not really taught in their medical schools, especially skills of advocacy and leadership. So they get to become aware of the complexities of the surgical care in their communities, and they're given the opportunity to engage in advocacy at the earliest point. This is my personal wish list, which will be my last slide. I wish that we hear a louder voice of students in global health equity, and more involvement of nurses. I'm not a nurse, but as surgeons, where would we be without these nurses? So I think we need to involve them very, very seriously in whatever we are doing. And then finally, I've always suspected diagnostics as being a big barrier to surgical care. We talk a lot about barriers to surgical care. I don't know how much we have thought about patients waiting to have spine surgery because they can't access an MRI and it's several miles away from where they are. So I think that is something I wish that we gave serious attention and address it even as we address other barriers to surgical care. Thank you so much, and I hope I worked within the time I've given.
Thank you. You've done that in 9 minutes, which was very good. Please don't go far away. We would like to ask at least one question, and I would like to invite the other speakers. Of course, our honorable keynote speaker cannot be questioned. So her submission is for our digestion and reflection. It can't be questioned. But the other speakers, please join me. The biomedical engineers, the ophthalmologists, and we'll allow just one question to each because lunch is cooling, I'm reliably informed, unless we are still in the Lenten season. I know that even Ramadan is on, so we might be comfortable waiting longer. Yes, let us start with His Excellency Dr. Epodoy, who is moving with the mic. Prince, can you help us with the mic, please? No. There has to be technological enhancement. Okay.
Thank you very much. My name has been mentioned, Epodoy Joseph, Senior Consultant Surgeon and Urologist. Yesterday, the Minister said there were a lot of presidents in Asou. I'm also the President-elect of the Urology Association of Uganda. To the biomedical team, thank you very much for that innovative research. Actually, to be relevant, you have to provide solutions for common challenges. And we all know that there is a concept of build Uganda, buy Uganda. So it will actually be in line with that. However, there are a few issues here. One, intrinsic challenges. I'm looking at the issue of quality. You talked about it briefly. Then the other issue is about cost. We have seen that local manufactured products have been outcompeted, especially in that aspect of cost. The cost of production of local products is actually higher than those imported. So look in that area. The other issues are extrinsic. People don't trust what we actually make locally. We all know this. One would rather buy a shoe from the UK, and that's what I've done for myself, than a shoe made locally here. Then the issue of certification, you talked about ably. Then the last one is, I remember in physics when we taught about gas laws, especially Boyle's law, which was described in 1662. If you are doing retraction and the peritoneal cavity remains airtight, then most likely, if you are increasing the volume, then you are going to decrease the pressure as well. And that would cause a lot of bleeding, unnecessary leakages and all that. Thank you very much.
Thank you very much. That is applied physics. Yes, Mr. President, again. Mr. President, first, you know, you must respect hierarchy.
Thank you very much. Again, Paula, first of all, please have your photo. Secondly, thank you very much, the organizers, for bringing Biomed on board. We must move together going forward without any doubt. My only concern is that the testing, the trials were done not in Uganda, unless I got it wrong. If it's going to be a boo-boo product, let's have some trials on Ugandans. Otherwise, I'm glad about your involvement and our association. Thank you.
Okay, yes, please.
Thank you so much, Chair, for the opportunity. I'm Dr. Kanika Andrew Marvin. I'm a Medical Officer and Research Associate at Mengo Hospital. Thank you so much, the biomedical team. I'm really inspired as a young person, seeing what you do. And I have about 3 questions.
Keep it to one, please.
Yeah, one, okay. What are the limitations you anticipate using this key loop versus the carbon dioxide insufflation that you want to replace? Because I didn't see that coming. And lastly, please, Chair, the involvement of surgeons. I would think that you would have a surgeon on your team rather than intermittent involvement of them. What do you think about that? Thank you.
Okay, can we have 2 more? I see a lady at the back after Dr. Rose.
Okay, thank you. Mine is also a small comment following what my president said about those studies. If you're doing the pivotal study and it's not in Uganda, then how will we credit it here in Uganda? So I think, as they have said, we should have been right from the feasibility study to the pivotal study of the equipment. Otherwise, it's exciting to see. Then for the surgeon of the eye, for us as plastic surgeons, we are also aching and itching for the cadaveric skin. So I think this is a time that we need to make ourselves, because we are going to start engaging that discussion. We needed skin long ago, so I think we need to join together. Thank you.
Okay, thank you. I think transplant is taking center stage, so the act must be widened. Yes, madam?
Thank you. I'm also interested with Paula, just asking about the real cost of your key scope, as well as the size. Is it 4 millimeters? Is it 2.7? Because we need to know for the other users that are not talked about, like ENTs. And then for BUA, the question that I have is, does the incision also invite other super specialists? Because we also have things that we want to talk about with the students. Thank you.
Okay, now that the bus is rolling, people want to get onto it, so that's very good. Lastly, ED Lubaga Hospital, one of our laparoscopists.
Thank you very much, Chair. The question again goes to Paula. I also have your photo here, so I'll hand it over when you're back. Just a little more details regarding the key scope. The angulation, is it 0 degree? Is it 30? The controls, we wanted to know a little more as we come to contribute. The focus, the light and all that, we need to know a little more. Sterilization, the method of sterilization, and all that. Otherwise, a very exciting innovation. Thank you.
Okay, thank you very much. I think you're already getting audience for your meeting in April. So, panelists, please fire on. You can start responding. Okay, you want to go last because you are hammered the most? Okay. Who wants to have a go?
Okay. I think I'll go first.
Thank you.
I'm responding to a question from Dr. Kavagenyi, and she's wondering if we invite super specialists to give talks. They have something they want to contribute. And of course, the answer is yes. There's a very, very big gap for mentorship. Many times people specialize, they tend to specialize in things they have been exposed to or where they have been mentored. So the more we get different specialties coming on board and speaking to students, the better. I made an observation that many times when medical students are joining, I don't know if anyone has observed this, when they're joining medical school, I think over 90% want to become surgeons, especially neurosurgeons and cardiothoracic surgeons. They read the work of Ben Carson and they get inspired. And by the time they are completing their medical school, it's just a handful, maybe less than 5% who want to become surgeons. Something happens in between. And most of them, of course, blame it on exposure and mentorship. So I want to say, and I want to encourage everyone to find time and actually speak. I want to thank the president. Recently had a mentorship talk with the students. And like Professor Galukande said in the morning, sometimes if you're not yet invited, you can actually choose to invite yourself. And let us know. We shall arrange for that. Thank you.
Okay, next. Hussein, do you want to go next?
Yeah, I think I'll go next. So I want to first address the question on by Dr. Joseph that was on cost of production. Looking at the fact that products that are manufactured here in Uganda, at times they tend to be more expensive than products which are imported, which is actually true. And in working in this project, we are looking at navigating this supply chain to see where do we find challenges and what are the causes of this increase in the costs. So if we have a detailed study why the costs are being high when you manufacture from here, and it also depends on the volumes of production. Say, for example, for the key suit, we anticipate by the end of this year, to Binga, we have made 18 key suits. locally. But you find this compared on the economies of scale, comparing it to a country, a company that produces, say, 100 keysuits, laparoscopes in a year, it will really be expensive for us. But in navigating the supply chain, we are trying to see the availability of the local materials and see a way of breaking down these costs. And if it's the raw materials that are on market that are also expensive, we are also looking at the feasibility or are comparing if we are getting raw materials from importing them. So those are some of the works we are doing, and we want to also address that. So the other question is, people don't trust what we make locally, which is also true. In Uganda, you find out we really rely on, giving an example of shoes, we buy Italy, Japan, and we leave Ugandan-made shoes. And this I can respond it in when it comes to medical devices. What we really need to have is the QMS systems in place. And these are the accreditations and certifications that we have been talking about. If a device is being accredited, say for example, it has a CE mark, that means that device, having a CE mark, that means you can sell in the European market. So even if a device is made from Uganda and someone is convinced that this device can be sold in the European market, then it can be sold in Uganda. As well as also getting the ISO 13485 certification. It's for medical devices, and it shows that you've been following the stringent standards in developing this device. So if we have all those accreditations and the local good manufacturing practices, we believe we can buy this trust from the local market. And then the other thing was surgeons being on the team. Yes, I would want to acknowledge that. We have surgeons on the team and we are working with them. That is Dr. Tamara and Dr. Jenna. They're both surgeons, and we are working close with them. And as well as in the development of a key suit, we are getting more feedback from surgeons, and we are planning for more stakeholder engagements, like the one that Paula has invited the team to be there on 12th of April. Thank you.
I think that would make an obvious turn for you, Paula, before the ophthalmologist.
I just want to start by saying the number of questions indicates that we are moving in the right direction. Oh, sorry. Okay, thank you. The first was on quality, and Kato has made a good job of explaining how the medical device industry might be quite different from other industries, because whether it's made in Uganda, whether it's made in China, whether it's made in Germany, we are all following the same standard. So the International Organization for Standardization has set out different standards. There's a standard on endoscopes, there's a standard on risk management and analysis, there's a standard for packaging and labeling, there's a standard for anything you can think of. So those are the same standards we are following. And there are particular notified bodies across the world that will perform audits of your processes, of your products, and these audits are performed yearly. So just because you have a system in place doesn't mean you shall follow it after 6 months. So the audits are routine. So rest assured we are working according to international standards, and that gives us more work, but it ensures quality. But yes, the other thing I wanted to mention is we have confidence because we are working with the users and we are hoping that you shall embrace us because we believe we've brought you on board early enough so that you understand the device, understand the processes we've been through, and hopefully have us at heart when you are in the hospital. The other question on the volume and pressure, I hope we can have a discussion during the lunch break. Yes, because that's something we had actually never thought of. With the set of tests we've conducted, so just for clarification, we had the device developed in the US, we developed it here in Uganda. We conducted benchtop tests. Those are like standard laboratory tests here in Uganda. When we reached the stage of conducting animal tests, it's shocking to note that in Uganda, the laws regulating animal studies are more difficult than even the ones on human studies. So it was quite difficult to navigate that. And now we are moving towards the inhuman study. Yes, but we recognize that animal studies should have been conducted, but it was quite difficult. The next is on the cost. So comfortably, we can state that the cost of production is $2,000 compared to the standard of care laparoscope, which is about $250,000. So that's quite a gap, but post-production processes are actually much more expensive than the production processes. So while we are talking about these ISO standards, they have to be procured. You have to pay whoever is coming to certify your processes. You have to pay for the CE mark, and these are tens of thousands of dollars. So right now, I don't think we can comfortably tell you the cost of our device because we've not yet calculated the post-production costs. We can only tell you that production cost is $2,000. Yeah, but we anticipate that in the end of all this, it will rise. And we can never compete with China. As he said, economies of scale, they produce millions. We can never compete with them. Yes, the working of our device. The current scope is at a 0-degree angle, but we hope that in future iterations we can go with, we can make a 30-degree scope, one that can be able to see at the angles, so it is in process. Sterilization, currently for the case scope, we are looking at sterilization using Sidex, but Sidex OPA, but we are open to suggestions. And then the mechanical retractor is metallic. We think that if a facility has an autoclave big enough to accommodate it, they can autoclave, but based on the normal autoclaves we have, the distance, the length is quite big, so it wouldn't be able to fit, so still could opt for Sidex. Then the controls. So control is done through the software that was displayed, the KeyView software. So you could be able to, our scope has a 30-millimeter working distance. I think I should also say that. And it is 5 millimeters in diameter. So our current scope, those are the dimensions. So control is through that software. You can be able to tilt the angle. You can be able to change parameters such as the contrast till you get an image that you would desire. And then you can take a screenshot and save the image for later. What are the functionalities? Yeah, basically, yes, that's the functionality right now. Yes, thank you.
Okay, thank you very much. I think, ladies and gentlemen, you can see that the biomedical engineers understand the economics of their trade. I think as surgeons, that is something we need to look at. But as a word of encouragement, every journey begins with a single step, so don't stop on the second. We know it's still a long way to go. Dr. Virungi, please.
Thank you very much. And to my colleagues, the biomedical engineers, I think we should also venture in ophthalmology equipment. There is actually one biomedical engineer who does servicing and repair of all ophthalmological equipment in Uganda. So we shall look for her in Barra, she's in Kampala, she goes to Tororo. So I think that is also a good market.
And I think the head of department has heard that. the market is there. When we first had a discussion of biomedical engineering, it was in its nascent stages. At that time, I think I was still in Rwanda. Now I see you are producing things, so I am encouraged to keep it up.
Yes, and then about the cadaveric donors, yes, I think we are actually supposed to start the advocacy and talking to the public as soon as yesterday. And this is going to only be successful when we all work as a team. Otherwise, if I come and I convince someone to donate a cornea, and that is all they are going to donate, I mean we shall lose a lot of other very useful materials. So I agree it has to be teamwork. Let's all do the advocacy and health education to the public as a team. Someone who is willing to donate a cornea most likely is willing to donate skin, is willing to donate the liver. So yes, I agree. Thank you.
Thank you very much. Probably the last question, which comes from the moderator, is to the biomedical engineering team. How are you addressing the intellectual property aspects of your innovative ideas? Are you sure we are safe, or are they going to be sold in Guangchung or whatever?
Yes, please. So we have a patent in process. So patents consider the filing date. So we have already filed for a patent. That's why we are confident to display our device. Yes, thank you. That's
Thank you.
one
Yes,
thing
that is
innovators usually forget.
That is always the forgotten thing. Because of the excitement of invention, we forget to protect the invention. Ladies and gentlemen, can we put our hands together for the panelists? Thank you very much. Lunch is now duly earned, and I would like to ask the Prince to lead us in that chapter.
Thank you. Professor, a picture with your panel, please. Thank you, and thanks everyone. It is very interesting to learn that Ugandans are anti-vivisectionists. I think we like our animal meat so much. We have none to spare for experiments. It's time for lunch. I'm going to ask us that we have our lunch for 35 minutes so that we can be back here at 3:30 for the remaining program. The people who are fasting, kindly register your names so that we can spare your ftali. You can have it later. All right, the meals are served in the restaurant downstairs. Kindly get a coupon from Immaculate so that you can be able to get yourself served. You will pray for each and every single plate of your meals. Please. Thank you.
Imagine needing to give birth. with no way to get to a hospital. Imagine needing surgery and having to wait 20 years. Imagine having no one to turn to when you need help the most. Then imagine you meet Bulamu Healthcare. Since 2016, Bulamu Healthcare and our partner health facilities have provided life-changing care in Uganda. This includes performing more than 10,000 surgeries at no cost to the patients. The value these procedures bring to each patient's life is priceless. But Bulamu Healthcare is able to perform them for about $200 per patient by working with local health leaders
we have
and
very
teams.
limited time, so
Bulamu
let's go to the
Healthcare is
restaurant
also
for the
leading the
meals.
fight against infant
Our
mortality,
time is really,
the number
really
one
limited.
cause of death in Uganda.
Kindly,
Every year,
let's slope to the
Bulamu
restaurant
Healthcare
and
helps
have
thousands of mothers
our
safely
meals
deliver
served.
their babies. Bulamu Healthcare also
should be here
provides
in 30
helping
minutes.
babies breathe training to more than 70 maternity facilities that deliver more than 50,000 newborns per year. This training reduces newborn mortality by 47%. Currently, Bulamu Healthcare partners with more than 350 health facilities to serve more than 4 million patient visits per year. And while our impact has been significant, with your help, we can do more. And we need to do more. Help a baby take her first breaths. End the wait for a surgery patient in need. Bulamu means life. Become a lifeline. Donate or partner with us to continue the life-saving work of Bulamu. Imagine needing to give birth with no way to get to a hospital. Imagine needing surgery and having to wait 20 years. Imagine having no one to turn to when you need help the most. Then imagine you meet Bulamu Healthcare. Since 2016, Bulamu Healthcare and our partner health facilities have provided life-changing care in Uganda. This includes performing more than 10,000 surgeries at no cost to the patients. The value these procedures bring to each patient's life is priceless. But Bulamu Healthcare is able to perform them for about $200 per patient by working with local health leaders and teams. Bulamu Healthcare is also leading the fight against infant mortality, the number one cause of death in Uganda. Every year, Bulamu Healthcare helps thousands of mothers safely deliver their babies. Bulamu Healthcare also provides helping babies breathe training to more than 70 maternity facilities that deliver more than 50,000 newborns per year. This training reduces newborn mortality by 47%. Currently, Bulamu Healthcare partners with more than 350 health facilities to serve more than 4 million patient visits per year. And while our impact has been significant, with your help, we can do more. And we need to do more. Help a baby take her first breaths. End the wait for a surgery patient in need. Bulamu means life. Become a lifeline. Donate or partner with us to continue the life-saving work of Bulamu. Imagine needing to give birth with no way to get to a hospital. Imagine needing surgery and having to wait 20 years. Imagine having no one to turn to when you need help the most. Then imagine you meet Bulamu Healthcare. Since 2016, Bulamu Healthcare and our partner health facilities have provided life-changing care in Uganda. This includes performing more than 10,000 surgeries at no cost to the patients. The value these procedures bring to each patient's life is priceless. But Bulamu Healthcare is able to perform them for about $200 per patient by working with local health leaders and teams. Bulamu Healthcare is also leading the fight against infant mortality, the #1 cause of death in Uganda. Every year, Bulamu Healthcare helps thousands of mothers safely deliver their babies. Bulamu Healthcare also provides Helping Babies Breathe training to more than 70 maternity facilities that deliver more than 50,000 newborns per year. This training reduces newborn mortality by 47%. Currently, Bulamu Healthcare partners with more than 350 health facilities to serve more than 4 million patient visits per year. And while our impact has been significant, with your help, we can do more, and we need to do more. Help a baby take her first breaths. End the wait for a surgery patient in need. Bulamu means life. Become a lifeline. Donate or partner with us to continue the life-saving work of Bulamu. Imagine needing to give birth with no way to get to a hospital. Imagine needing surgery and having to wait 20 years. Imagine having no one to turn to when you need help the most. Then imagine you meet Bulamu Healthcare. Since 2016, Bulamu Healthcare and our partner health facilities have provided life-changing care in Uganda. This includes performing more than 10,000 surgeries at no cost to the patients. The value these procedures bring to each patient's life is priceless. But Bulamu Healthcare is able to perform them for about $200 per patient by working with local health leaders and teams. Bulamu Healthcare is also leading the fight against infant mortality, the #1 cause of death in Uganda. Every year, Bulamu Healthcare helps thousands of mothers safely deliver their babies. Bulamu Healthcare also provides Helping Babies Breathe training to more than 70 maternity facilities that deliver more than 50,000 newborns per year. This training reduces newborn mortality by 47%. Currently, Bulamu Healthcare partners with more than 350 health facilities to serve more than 4 million patient visits per year. And while our impact has been significant, with your help, we can do more, and we need to do more. Help a baby take her first breaths. End the wait for a surgery patient in need. Bulamu means life. Become a lifeline. Donate or partner with us to continue the life-saving work of Bulamu. Imagine needing to give birth with no way to get to a hospital. Imagine needing surgery and having to wait 20 years. Imagine having no one to turn to when you need help the most. Then imagine you meet Bulamu Healthcare. Since 2016, Bulamu Healthcare and our partner health facilities have provided life-changing care in Uganda. This includes performing more than 10,000 surgeries at no cost to the patients. The value these procedures bring to each patient's life is priceless. But Bulamu Healthcare is able to perform them for about $200 per patient by working with local health leaders and teams. Bulamu Healthcare is also leading the fight against infant mortality, the #1 cause of death in Uganda. Every year, Bulamu Healthcare helps thousands of mothers safely deliver their babies. Bulamu Healthcare also provides Helping Babies Breathe training to more than 70 maternity facilities that deliver more than 50,000 newborns per year. This training reduces newborn mortality by 47%. Currently, Bulamu Healthcare partners with more than 350 health facilities to serve more than 4 million patient visits per year. And while our impact has been significant, with your help, we can do more. And we need to do more. Help a baby take her first breaths. End the wait for a surgery patient in need. Bulamu means life. Become a lifeline. Donate or partner with us to continue the life-saving work of Bulamu. Imagine needing to give birth with no...
Since 2016, Bulamu Healthcare has worked with Uganda's local and national governments to make quality healthcare available to patients throughout the country by organizing teams of licensed Ugandan doctors, surgeons, nurses, and midwives. Together, we have done more than we ever expected to achieve. 325,000 plus Ugandan patients treated all time, including 10,000 plus surgery patients. Thanks to Bulamu and our partners, all of these patients were treated free of charge. In 2018, leaders at the Ministry of Health of Uganda shared key challenges of the health system with Bulamu's team. This set Bulamu on a mission of developing health systems that can improve patient care through Ministry of Health facilities and the existing doctors, nurses, and midwives.
Nto wange nga amaze okufa yaleka akasajja kano nga kato. Mama wako n'agenda nako nga tumaze okumuziika. Naye nagenda nga neŋŋendayo. Buli lwaki olunaku olumu ngenda okgendayo ng'omwana yafuna akananka wano eno ng'ensolosozi gwe yalumye. Mukyala wange oyo yaŋŋamba nti omwana alina akananka wano eno. Namutwalako ko Luweero Kasana. Ente ze baŋŋamba e Kasana nga sizirina baŋŋamba akakadde kamu $2,000. Konze akanzireyo eggayaza nja kuyiyiza eyo n'ensitula omwana n'enzija naye.
Nti omwami bwe yavaayo ekiruddu eggulo limu tuli wano abantu bajja otulabako ekintu bwe bakyewuunya bwe bakitya. Sente tuzijjeewa jjukira nange ndi muzito. Kati nno nayimba wange akolera gayaza yabajja n'aŋŋamba balanze nti Kasanga tibagenda kujjayo abaki abasawo abayinza okubayamba naye omwana mumukole eki mumutwaleko eyo tulabe. Deni ndowooza enkeera waalwo kwe kumusala ekintu ekyo. Bamuwa bulungi obujjanjabi nga bamulongoosezza.
Working together with districts, health centers, and national leaders, Bulamu developed the Health Center Excellence Program to strengthen health systems for the entire country.
As a district, we are grappling with huge numbers of cases that, one, were coming in late, untimely referrals, and two, were having very many traditional birth attendants in business. And as a district, we are not finding out solutions how we should stop this. Mothers who are seeking maternity or delivery services from untrained hands, traditional birth attendants. And a lot of things were happening there. I was getting a lot of ruptured uterus within the facility. And these were coming out because unskilled birth attendants were monitoring these deliveries. I addressed the issue to the district and the RDC promised to take it on, and indeed they did, but to avert that it was extremely hard. And as a result, we're having a lot of, one, unnotified maternal deaths that were not later on reviewed because they were in places that were not convenient. Two, we're having a lot of home births by these mothers. And when the ET program, emergency transport, started, that was about January to February of last year, 2022. This is what it did. the program came in handy, and they were saying, look, we want in referrals to improve, and then also timely out referrals. And I remember convening a meeting with my in-charges, and we said, no, we can take on this. When we started the emergency transport program, mothers who are being referred from Health Center 3s, a standby ambulance that was fueled by Bulamu Healthcare was going within these Center 3s and picking these mothers. Previously, the picture was, write a referral for this mother who has come at Health Center 3 to go to Nsinze Health Center 4. Big distances, about 22 kilometers, about 25 kilometers, 30 kilometers, 16 kilometers away from the facility. And these mothers, because of lack of funds, they were opting for traditional birth attendants. When we told these mothers that we are going to always pick you and come in and operate on you and work on you from a higher facility, now Health Center 4, we started seeing our cases of seizures increase from the 12 we were doing every month to now 30 that we are doing this month. And we didn't know about this. We thought maybe these were the mothers who needed obstetric intervention within a month, but we were wrong. Emergency transport helped us realize that we could even actually operate up to a tune of 40 mothers in a particular month. You know, and averagely we've moved from 11 seizures per month to 30 seizures per month. This month in particular, we had about 32 operations, emergency operations done on our mothers, leaving alone other procedures. And because of that, we are seeing reduced numbers of mothers who are seeking care traditional birth attendants, from traditional birth attendants, and we are seeing less maternal deaths within the district.
Most of our mothers in the villages, they become pregnant. They know that at the end of the 9th month, they must give birth. But they end up not saving anything to take them to the hospital. And at the same time, when they go to the nearest health facilities, they go at a late stage. So the emergency transport has helped us in a way that when this mother, when is diagnosed and cannot be kept at that health facility, they ring Health Center 4, our ambulance quickly goes to that health facility, picks this mother, brings the mother to Nsinze Health Center 4, where she's taken care of. And in case she cannot be taken care of in Nsinze, she's easily transported to Iganga to get other facilities that are not in Nsinze.
Today, the Health Center Excellence Program supports 346 Ministry of Health facilities that treat more than 3 million patients per year in 12 districts of Uganda, districts that contain 17% of the population. 346 Ministry of Health facilities, 3+ million patients visits per year, 12 partner districts, 17% of Uganda's population.
When we were piloting some of these programs in some of our partner districts, we came across problems that needed easy solutions. For instance, there were mothers who could not reach the next referral point because of maybe lack of essential surgical supplies at the referring center, and we thought we can avert this situation by assuring that there is some small fund that can support these mothers to be escalated to the next point of care. Alongside that, we thought of why not reduce on the referrals. So we have introduced a program called Essential Surgical Supplies, which we give to health center 4s, so that some of the doable surgical conditions targeting the mothers can be done at those health facilities without necessarily referring. This one cuts down the cost of the mother and also the risks of losing both the mother and the baby. And we are doing this in quite a number of facilities and districts, and has proven a good model that could be scaled up nationally.
I was largely attracted by Bulamu's vision and mission that aims at improving access to care at low cost to the patient or the client, so to say. And this has been very exciting so far for me in the last 4 years, because we've been able to look at the entire health system, generally aiming at treating the sick, improving access, so we reach out to where they are in the different districts. And then we also are developing the documentation, because one of the difficulties in planning for healthcare is lack of data.
Previously, our patients would struggle to even buy a book of 200 shillings. 200, a patient comes to seek care from the facility. As a health worker, I have nowhere to write. I ask a patient, please go and buy for me a book. But because the patient walked over 6 kilometers to reach the facility, without even a single facilitation, they don't even know what to eat. How are they going to afford a book? Resultantly, most of the patients would walk back home, you can imagine. And us, the health workers, were adamant to understand the situation. When Health Center Excellency Program came in and they brought majority of these patient forms at OPD, at inpatient, in maternity, in the theater for consent forms and anesthetic reports, and then also surgical notes, it was like a magical bullet. It changed very many things. Actually, it improved people even who are seeking care at our outpatients department.
Most of the districts we've been to have been able to improve their ranking in the Ministry of Health annual reviews. And this is giving us hope that the model we have put in place is delivering a difference. We are attending to the very needs that the Ministry of Health wants to be attended to, so we become a relevant partner. And we are also helping the health care delivery systems at the districts to feel empowered and work more efficiently. We've noticed that we are able to enhance the cost of care at less than 5% of what could have been. It is a low-budget organization, but with high impact. And I think the Ministry of Health is looking for how it can improve its efficiencies in healthcare delivery and healthcare promotion. So these models, if we are to engage better with the ministry, may inform the ministry's approach, because these are really tested approaches. We've tested them on ground over the last many years, and we've seen that the impact is already being felt. And like I said, the districts are being able to record improvement, which means we're actually addressing what the ministry would like to address by the mere fact that the districts we are in have demonstrated improvement. So that gives me hope that the ministry will see in us a very strategic partner.
I recommend that the services that Bulamu is giving in Namutumba district to be extended to other districts, such that they also benefit what we are benefiting from.
So far where we are in these districts here, at least the number of referrals, the number of maternal deaths have reduced, which you feel if it also happen in other districts, I think we would realize significant reduction in mortalities.
Today is a good day for the Association of Surgeons of Uganda. It's a good day for the Ministry of Health, and it's a good day for our country. But the whole idea is for us to showcase what we do in our theaters, what we do in our hospitals, in our intensive care units in Uganda, and we put it to the public so they can see for themselves. Uganda can now proudly boast of performing transplant surgery, separation of conjoined twins, complex open heart procedures, laparoscopic abdominal surgeries.
I would really want to juxtapose this same tent, the way it is, to the grounds of Parliament sometime this year or next financial year, so that our fellow colleagues are able to walk through and see what Ugandan doctors are able to do and what they are doing currently.
The small beginnings that we are seeing, the advancements that have started, the opportunities that have opened will continue to grow. We shall nurture those beginnings with you. Government must find money to train specialists if we want to see these services being performed.
If we had our surgeons populate the peripheral hospitals, especially the senior ones, that would be more cost effective than having 90% of them in Mulago.
We must have good teachers, dedicated and mentors. As the seniors go away and we see our exit door, we become mentors and supervisors to the young ones.
We need to go beyond the perspective of only focusing on clinical care and open up to other components. It will enable, reorient the surgeons in terms of the way they see things, the way they look at health in a more broader perspective.
Let the people know what you are doing. Let's make documentaries. When will those people in Kisenyi know that you can do those surgeries? Even amongst ourselves here in the various hospitals, people don't know what you do. Because most of the specialties are concentrated in Kampala. The regions don't know. I know it is expensive, but we are here to support you, to spread the good news.
This landscape exhibition is one of the ways of raising public awareness about the availability of surgical services in the country. It will help to reduce forex loss of dollars to other countries. Government will continue to provide a conducive environment for training and retaining specialists.
Imagine needing to give birth with no way to get to a hospital. Imagine needing surgery and having to wait 20 years. Imagine having no one to turn to when you need help the most. Then imagine you meet Bulamu Healthcare. Since 2016, Bulamu Healthcare and our partner health facilities have provided life-changing care in Uganda. This includes performing more than 10,000 surgeries at no cost to the patients. The value these procedures bring to each patient's life is priceless. But Bulamu Healthcare is able to perform them for about $200 per patient by working with local health leaders and teams. Bulamu Healthcare is also leading the fight against infant mortality, the #1 cause of death in Uganda. Every year, Bulamu Healthcare helps thousands of mothers safely deliver their babies. Bulamu Healthcare also provides Helping Babies Breathe training to more than 70 maternity facilities that deliver more than 50,000 newborns per year. This training reduces newborn mortality by 47%. Currently, Bulamu Healthcare partners with more than 350 health facilities to serve more than 4 million patient visits per year. And while our impact has been significant, with your help, we can do more. And we need to do more. Help a baby take her first breaths. End the wait for a surgery patient in need. Bulamu means life. Become a lifeline. Donate or partner with us to continue the life-saving work of Bulamu.
Since 2016, Bulamu Healthcare has worked with Uganda's local and national governments to make quality healthcare available to patients throughout the country by organizing teams of licensed Ugandan doctors, surgeons, nurses, and midwives. Together, we have done more than we ever expected to achieve. 325,000 plus Ugandan patients treated all time, including 10,000 plus surgery patients. Thanks to Bulamu and our partners, all of these patients were treated free of charge. In 2018, leaders at the Ministry of Health of Uganda shared key challenges of the health system with Bulamu's team. This set Bulamu on a mission of developing health systems that can improve patient care through Ministry of Health facilities and the existing doctors, nurses, and midwives.
Ndo wange nga amaze okufa yaleka akasajja kano nga kato. Mama wako n'agenda nako nga tumaze okumuziika. Naye nagenda nga neŋŋendayo. Buli lwaki olunaku olumu ngenda okgendayo ng'omwana yafuna akananka wano eno ng'ensolosozi gwe yalumye. Mukyala wange oyo yaŋŋamba nti omwana alina akananka wano eno. Namutwalako ko Luweero Kasana. Ente ze baŋŋamba e Kasana nga sizirina baŋŋamba akakadde kamu $20,000. Konze akanzireyo eggayaza nja kuyiyiza eyo n'ensitula omwana n'enzija naye.
Nti omwami bwe yavaayo ekiruddo eggulo limu tuli wano abantu bajja otulabako ekintu bwe bakyewuunya bwe bakitya. Sente tuzijjeewa jjukira nange ndi muzito. Kati no neiba wange akolera ggayaza yabajja n'aŋŋamba balanze nti Kasanga tibagenda kujjayo abaki abasawo abayinza okubayamba naye omwana mumukole eki mumutwalekeyo tulabe. Deni ndowooza enkeera waalwo kwe kumusala ekintu ekyo. Bamuwa bulungi obujjanjabi nga bamulongoosezza.
Working together with districts, health centers, and national leaders, Bulamu developed the Health Center Excellence Program to strengthen health systems for the entire country.
As a district, we were grappling with huge numbers of cases that, one, were coming in late, untimely referrals, and two, were having very many traditional birth attendants in business. And as a district, we are not finding out solutions how we should stop this. Mothers who are seeking maternity or delivery services from untrained hands, traditional birth attendants. And a lot of things were happening there. I was getting a lot of ruptured uterus within the facility. And these were coming out because unskilled birth attendants were monitoring these deliveries. I addressed the issue to the district and the RDC promised to take it on, and indeed they did, but to avert that it was extremely hard. And as a result, we're having a lot of, one, unnotified maternal deaths that were not later on reviewed because they were in places that were not convenient. Two, we're having a lot of home births by these mothers. And when the ET program, emergency transport, started, that was about January to February of last year, 2022. This is what it did. The program came in handy and they were saying, look, we want in referrals to improve and then also timely out referrals. And I remember convening a meeting with my in-charges and we said, no, we can take on this. When we started the emergency transport program, mothers who are being referred from health center 3s A standby ambulance that was fueled by Bulamu Healthcare was going within these center threes and picking these mothers. Previously, the picture was write a referral for this mother who has come at Health Center 3 to go to Nsinze Health Center 4. Big distances, about 22 kilometers, about 25 kilometers, 30 kilometers, 16 kilometers away from the facility. And these mothers, because of lack of funds, they were opting for traditional birth attendants. When we told these mothers that we are going to always pick you and come in and operate on you and work on you from a higher facility, now Health Center 4, we started seeing our cases of seizures increase from the 12 we were doing every month to now 30 that we are doing this month. And we didn't know about this. We thought maybe these were the mothers who needed obstetric intervention within a month, but we were wrong. Emergency transport helped us realize that we could even actually operate up to a tune of 40 mothers in a particular month. You know, and averagely we've moved from 11 seizures per month to 30 seizures per month. This month in particular, we had about 32 operations, emergency operations done on our mothers, leaving alone other procedures. And because of that, we are seeing reduced numbers of mothers who are seeking care from traditional birth attendants, and we are seeing less maternal deaths within the district.
Most of our mothers in the villages, they become pregnant. They know that at the end of the 9th month, they must give birth. But they end up not saving anything to take them to the hospital. And at the same time, when they go to the nearest health facilities, they go at a late stage. So the emergency transport has helped us in a way that when this mother, when is diagnosed and cannot be kept at that health facility, they ring Health Center 4, our ambulance quickly goes to that health facility, picks this mother, brings the mother to Nsinze Health Center 4, where she's taken care of. And in case she cannot be taken care of in Nsinze, she's easily transported to Iganga to get other facilities that are not in Nsinze.
Today, the Health Center Excellence Program supports 346 Ministry of Health facilities that treat more than 3 million patients per year in 12 districts of Uganda, districts that contain 17% of the population. 346 Ministry of Health facilities, 3+ million patients visits per year, 12 partner districts, 17% of Uganda's population.
When we were piloting some of these programs in some of our partner districts, we came across problems that needed easy solutions. For instance, there were mothers who could not reach the next referral point because of maybe lack of essential surgical supplies at the referring center, and we thought we can avert this situation by assuring that there is some small fund that can support these mothers to be escalated to the next point of care. Alongside that, we thought of why not reduce on the referrals. So we have introduced a program called Essential Surgical Supplies, which we give to health center force, so that some of the doable surgical conditions targeting the mothers can be done at those health facilities without necessarily referring. This one cuts down the cost of the mother and also the risks of losing both the mother and the baby. And we are doing this in quite a number of facilities and districts, and has proven a good model that could be scaled up nationally.
I was largely attracted by Bulamu's vision and mission that aims at improving access to care at low cost to the patient or the client, so to say. And this has been very exciting so far for me in the last 4 years, because we've been able to look at the entire health system generally aiming at treating the sick, improving access, so we reach out to where they are in the different districts. And then we also are developing the documentation, because one of the difficulties in planning for healthcare is lack of data.
Previously, our patients would struggle to even buy a book of 200 shillings. 200. A patient comes to seek care from the facility. As a health worker, I have nowhere to write. I ask a patient, please go and buy for me a book. But because the patient walked over 6 kilometers to reach the facility, without even a single facilitation, they don't even know what to eat. How are they going to afford a book? Resultantly, most of the patients would walk back home, you can imagine. And us, the health workers, were adamant to understand the situation. When Health Center Excellency Program came in and they brought majority of these patient forms at OPD, at inpatient, in maternity, in the theater for consent forms and anesthetic reports, and then also surgical notes, it was like a magical bullet. It changed very many things. Actually, it improved people even who are seeking care at our outpatients department.
Most of the districts we've been to have been able to improve their ranking in the Ministry of Health annual reviews. And this is giving us hope that the model we have put in place is delivering a difference. We are attending to the very needs that the Ministry of Health wants to be attended to, so we become a relevant partner. And we are also helping the health care delivery systems at the districts to feel empowered and work more efficiently. We've noticed that we are able to enhance the cost of care at less than 5% of what could have been. It is a low budget organization, but with high impact. And I think the Ministry of Health is looking for how it can improve its efficiencies in healthcare delivery and healthcare promotion. So these models, if we are to engage better with the ministry, may inform the ministry's approach, because these are really tested approaches. We've tested them on ground over the last many years, and we've seen that the impact is already being felt. And like I said, the districts are being able to record improvement, which means we're actually addressing what the ministry would like to address by the mere fact that the districts we are
Those
in
of us who are still outside, kindly enter. And please take your seats. We want to get ready for the next session. The next session is going to have 2 chairs. The first chair is Dr. Flavia Luede. The second chair is Professor Sebufo Robinson. To the podium and take over your session. Thank you.
Gentlemen, oh, sorry. Good afternoon, ladies and gentlemen. Dr. Oluwede Aliba Flavia. I'm a lecturer at Soroti University. I'm the chair for this session. We are going to continue to build on what we discussed before lunch, global surgery and innovations. In this session, we had 4 speakers, though the other 2 have not been able to turn up due to unavoidable circumstances. So we are going to have Ms. Rebecca Kaya Nansubuga talking about local silo bags. And again, after that, we shall have Dr. Banturaki David, who will talk about the unmet needs of global surgery. And just a brief about Ms. Nansubuga. So, Ms. Rebecca Kaya Nansubuga is a graduate in biomedical engineering from Makerere University. She's interested in medical device research, design, and innovation, and she's currently working as a research fellow with the Makerere University Biomedical Engineering Unit. She's going to present a title called Using Locally Made Local Silo Bags to Improve Gastroschisis Management in Uganda. Ms. Rebecca Kaya Nansubuga, you're welcome to give us your presentation. Okay. What about Banturaki? Oh, I thought she had come. She's outside. I thought she had returned. Okay, Nansubuga is coming. I hope David is back from lunch. David Banturaki. Okay, sorry, I think the presenters for this session are not yet in. We thought they had returned. So maybe Prof. Robinson, if yours are here, you can. We thought they were back.
Sorry about that. Good afternoon, members, colleagues. Yes, I'm Sevuf Robinson, an associate professor of surgery and the director in charge of education, training, and research at Mengo Hospital. This afternoon, we have a number of presentations. We shall start with our guest speaker, Dr. Reichert Jennifer. Dr. Reichert Jennifer is an associate professor of surgery at the University of Minnesota. And clinically, Dr. Jennifer works in trauma, critical care, and acute care of surgery. I had an opportunity to work with Jennifer in Rwanda, where she was for more than 10 years with the Rwanda Human Resource for Health. She was involved in teaching and also training postgraduate students and other medical students. Her research interests in global health, surgical infections, and the antimicrobial resistance. I had an opportunity to work with Professor Jennifer. We conducted research together, especially on surgical training in Rwanda. Professor Jennifer, you're welcome.
Thank you so much. It is a pleasure and an honor to be here today. Maybe I could get a different presentation. I don't actually know about saving babies at birth. Is there a way to fix the slides so they look a little bit... My screen looks good. Oh.
Can someone go past fix this?
Oh, no problem.
That time is not counted.
All right. So today I want to talk about research mentorship. And to begin with, just talking about mentorship in general. Mentor actually comes from the time of Odysseus. And so during the Odyssey, when Odysseus went to the Trojan War, he actually left his son Telemachus in the care of Mentor. And this is who cared for him and taught him. And that's where the word mentor comes from, meaning to kind of provide somebody who provides wisdom from their experience. But you can't talk about mentorship without talking about coaching and sponsoring, all right? Because these are all actually very interrelated practices. So a mentor is somebody who helps you navigate and kind of gives you career advice and helps you advance in your career. And it's usually based on their own experience. A coach provides similar advice, but it's usually guidance and feedback specifically on your development. This is somebody that might provide you with something like constructive criticism. And a sponsor is somebody who's going to use and leverage their expertise, their connections, to help you get opportunities, jobs, promotions. And so I think we oftentimes use the word mentor, but sometimes we might actually mean coach. Sometimes what you might need is a sponsor. And so I'm going to talk today not just being a mentor, but also being a mentee, because all of us at some point in our life have been a mentee. All of us at some point have been or will be a mentor. And just to kind of, I think the easiest way to think about the difference between a mentor, a coach, and a sponsor is a mentor is somebody who talks with you, a coach is somebody who talks to you, and as a sponsor is somebody who talks for you. And I tend to use the words interchangeably and use the word mentor for everything, but I think we need to keep in mind that we're probably also playing the role of coach and sponsor sometimes as well. So there's a lot of different types of mentors that you will have in your life, and oftentimes you need more than one mentor. So don't expect that one mentor is going to do everything for you and fill that role. So get a lot of advice from a lot of different people, a lot of different mentors. Oftentimes you will have a mentor for your clinical work, sometimes for research, maybe different aspects of your research, maybe a mentor who helps give you guidance on work-life balance, a lot of different areas that you can get mentorship in. And as a mentor, there's a lot of different things that you can do to help make sure that you're the best mentor that you can be. Obviously, getting a lot of experience that you can share with others is certainly one of the first steps. Make sure that you know more than what your mentee knows. Kind of stay on top of things so that you have that accumulated wisdom to share. I think the other things that are really important is that to do mentorship well, you actually need to be able to commit the time to it. And I think this is something that we often underestimate is the value of time. And so to really be a good mentor, make sure that you're generous with your time and your expertise. And then finally, don't solve all of your mentees' problems yourselves. Your goal is to really help them work through things so that they learn how to solve problems themselves. So you're really helping them work through the challenges, not solving all of their problems for them. If you want to talk about the different characteristics of what makes somebody a good mentor or a good mentee, a mentor, like we talked about, needs to have the knowledge and wisdom that they can share with somebody else. They need to have the different connections that can help somebody network and explore the world that they need to. And then, as we talked about before, being generous with your time and your knowledge. From a mentee perspective, the best way to get good mentors is to make sure that you're a good mentee. So you need to be open and flexible and be respectful of your mentor and their time. Hopefully they'll be respectful of your time as well, and have a pretty clear idea of what it is that you actually expect to get from a mentor-mentee relationship. A lot of times I think people mistakenly reach out to somebody and say, I want you to be a mentor for me, and then they're not really clear and explicit about what they want out of the relationship. And it becomes very hard as a mentor to help guide somebody if you don't know specifically what they're looking for. And I think this is something that we don't talk enough about, but what is the value of mentoring? As a mentee, hopefully you have a pretty good idea of what you're getting out of it. You're getting the advice and support that you need as a mentee, but there's actually a lot of value as a mentor that you can get out of this relationship. I think talking with other people, you get valuable different perspectives on how a mentee might look at the world, and I think that's valuable. But I think it also helps you identify talent and build up a network around you, because those mentees of today are going to be your resources, your connection of the future. This is what's driving change in the world, and they're going to be your legacy. Think about how many times you've heard about somebody who was a great surgeon, and they're very rarely just a great surgeon by themselves, but they're a great surgeon because they've trained up so many people behind them as well. When it comes to research mentorship, I have many people come and ask me for help with research. They're looking for mentorship, but it really depends, right? A lot of people are looking for research mentorship for different reasons, and you need to be able to understand those reasons and expectations for needing a research mentor. Some people, particularly early in their career, are merely looking for somebody to help guide them through the research skills. They want to learn how to do the research. Some people are needing to do research because it's a specific requirement for their graduation. Other reasons that people are doing research is because they want to build their resume, build their CV, career advancement. And I like to understand people's reasons for doing the research because it helps target what it is that I'm specifically mentoring. Somebody who wants to learn skills, I'm going to focus more on that. Whereas somebody who needs this research for their graduation, I'm going to be much more particular about making sure that we're hitting timelines so that they finish their project in time for graduation. Who needs a research mentor? Pretty much most everybody. Medical students often, if you have to do a memoir or a thesis for graduation. Otherwise, if they're just wanting to get exposure to research, they'll be reaching out for a mentor. Residents, many of us have those doing their MMed thesis, and they almost all need research mentorship. But then junior faculty as well. So as you're starting out your career as faculty, you'll want a mentor to help get you started in your research trajectory. So you'll need a research mentor pretty much at all levels. And you'll find that there are times when you are not only a mentor, but a mentee as well. When I have medical students reach out to me, oftentimes they're just looking to get skills and exposure in research. So they might not necessarily have a specific timeline that they're working around. And that's important to understand because it helps you know how much time and leverage to give them working on a project. I ask them a lot of questions about why they want to do that research. Are they just looking for experience, or are they looking for publications to put on their CV to help them get into a residency program? And unfortunately, many times I find that I probably am not the best person to actually fill their mentorship needs, either because of time constraints or not having a project that's ready for them to work on. And if that's the case, I'll often make sure that I refer them to somebody who I think could do a better job. Maybe it's somebody who already has a research project in motion or has the time to spend with them. Because I feel like if I'm not capable of giving them the support that they need, it's better for them to move on and find somebody better. This is probably where we see and do the most mentorship in terms of research, is residents working on their theses. I learned early on it's important for me to know the rules and expectations of the thesis because I want to make sure that I'm guiding them in the right direction. They have specific rules and requirements for graduation, and I don't want to be the reason that somebody doesn't graduate from their residency program. You need to make sure that because it's a time-dependent exercise, I like to make sure that there is clear expectations on regular feedback and regular follow-up so that they don't fall behind their schedule. And regardless of what the expectations are for graduation, I like to make sure that everybody at least gets pushed and motivated to follow through their research to completion, which to me means getting it published. Of course, I can't force everybody to do it, but certainly I try to provide the most support to get that through. And then finally, junior faculty research mentorship is kind of the next level. And I don't know how much that happens here in Uganda. I know it's been a challenge in Rwanda that there's not a lot of people to mentor when you get to the junior faculty level. But there's a lot of reason and opportunity for that. There's a lot of career development awards. I think if people get a little bit of mentorship to help them start up a research career, that'll help carry them through their academic life. And as a mentor, you can help them develop the connections, network at conferences, and help support them as they start off on a research career. So in conclusion, I think mentorship is very important. It's valuable for both parties in the arrangement. You need to make sure that you take the time and effort to do it well and understand the goals and needs of your mentee. Thank you very much. Thank you.
So thank you, Jennifer. Now I'd like to call upon the next presenter, who is Dr. Phyllis Kisa. Oh. Is she around? Dr. Phyllis? I'm here, but they can't find my... Oh, okay. So in the meantime, let's call the next presenter, Dr. Francis Basimbe. Yes, Dr. Francis Basimbe is going to talk about postgraduate surgical skills training in Uganda with a standardized hernia skills transfer program. You are welcome, Dr. Basimbe.
Thank you, Professor Robinson. Thank you, members. Waiting for the presentation to load. Notwithstanding the challenges of giving a postprandial presentation, especially understanding the physiology that happens after a good meal, but I will do my best in that process. I think they posted the abstract. There is a different... There's a presentation in the same folder. The work I'm going to present is something that we've been doing as the Department of Surgery, Uganda Matters University, Mother Kevin Postgraduate Medical School. We started this work about 8 years ago. It was disrupted during COVID, and so we ended up missing those 2 years, but it resumed immediately after COVID was done. And that's the kind of work I'm going to present. Just a few technological glitches. So as a way of introduction, as technology is still being worked on, the title of my presentation is Postgraduate Surgical Skills Training in Uganda with a Standardized Hernia Skills Transfer Program. And like I said, this is something that we have been doing for the last 8 years. And we picked a procedure that we know is very, very common in our setting, and even globally, and that is inguinal hernia surgeries. And we feel that that operation serves well as a standard for good surgical skills transfer for our residents. And so as an introduction, inguinal hernias are very common surgical pathology, as we know, globally. And in this country, we run regular surgical camps, I think once every year, and inguinal hernias form the majority of the operations done in those camps. In our setting, the majority of inguinal hernia repairs are still tissue repairs, but we are increasingly starting to do a lot of mesh repairs as well, and that has been as a result of the materials. So the aim of our study was to evaluate the pre- and post-training hernia knowledge and skills of our residents who underwent a mesh hernioplasty training in our center using this standardized skills transfer program. So in 2016, there was a collaboration that was started between the medical university that I work with and the College of Surgeons of East, Central, and Southern Africa. And this program was to train in partnership with another UK-based charity called Operation Hernia. And the aim of this was to equip our residents with surgical skills in safe hernia surgery. And so a structured hernia surgical training program for our postgraduate students and trainees was developed and implemented as a result. And the course consisted of 2 parts. It has the lectures, which is the theoretical part, but also it has the practicum, which goes on in theaters where we go. And so the lectures mainly emphasize 2 aspects: surgical anatomy of the inguinal canal and the hernia surgical anatomy, and also the second part of those lectures is the surgical techniques, what exactly you do in theater as you're operating on these patients. Before we usually start these trainings, we start with a formal pre-course evaluation of the knowledge of the group that we have. We usually source out these students from, these residents from about 4 universities locally, and it's at expression of interest. We usually prefer to take second years because in most of our programs here, second year is usually the year where they are practically doing most of the theater work. So we feel that that is the group that benefits more from this training. So we do a pre-evaluation of our training and we assess each individual trainee of their personal surgical skills. And we have developed tools that do that. And after we have assessed that, we score them, and based on the score they receive, we allocate them to particular trainers. And so the trainer then gets to engage a group where they are aware of the capabilities and the level of knowledge that they have. Can we move far ahead? Okay. I'm about right there. So a structure, that one I've already presented. So what we usually do is, this is a schematic of what our training, how our training is conducted. We start with a live demonstration of the procedures that are going to be done. And in this, the trainer is able to go through the skills and the steps of this operation of an inguinal hernia surgery step by step. And as they are doing this, they are actually giving a running commentary of every single procedure and identifying all the anatomical structures within the inguinal canal. And after that, the second step is where the trainee assists the trainer, and then they go through each of those steps as the way the trainer has demonstrated earlier. The trainer then assists the trainee, and then after you've assessed the level of progress, because there is feedback and evaluation at each and every step of that model, we then, if the trainer feels confident, they then proceed to have the resident perform these procedures semi-independently. Semi-independently, we have deconstructed the hernia operation, so there could be aspects, like for example, identification of a sac, or maybe dissection and identification of the nerves, certain aspects that probably the trainer may be struggling with, and that is where the trainee can be helped. So it's semi-independent, and at a point when the trainer feels they need to step in and probably offer guidance, that's what they do. And if they've met the criteria to proceed, we then allow them to go to step 6, which is an independent operation that is being observed by the trainer. And then the rest of the steps are until when we feel that the resident has gained the competencies that they need. And like I said, these lectures that initially are held emphasize the anatomy, and this is demonstrated practically during the presentation. How do we evaluate, or how have we been evaluating these residents? We use the Intercollegiate Surgical Curriculum Program, which is a tool of assessment that has been adopted from the UK Royal College of Surgeons and has been adopted by many training programs. So we are able to tell how each and everyone is progressing. At the end of the training of each procedure, we're able to categorize our residents into those 5 levels. One is one where you're unable to perform the procedure, and that's the level of competence we will assess that particular procedure for. The second is able to perform some aspects. So they were able to go from skin to the subcutaneous tissue and probably to open the canal, but probably at that point, so you're able to specifically mention those aspects that they were able to perform. And then there are those that are able to perform the entire procedure, but with supervision. And then level 4 is those able to perform with minimal or occasional, very occasional help. And then the highest is the level where they are able to perform independently. What I didn't include in this slide is that the highest level of competency that we assess during our training is being able to train the other resident, because sometimes that's, for those that are performing well, that are outliers, you find that they are able to do this very well, and then what we do during the training is we allow them to work with another resident, and then we evaluate them as they are teaching someone else to do these procedures. So the key principles in our training is continuous competence assessment by the trainers.
3 minutes.
And individual feedback is emphasized. Evidence is provided to demonstrate improvement in surgical skills as well as knowledge of anatomy. Needs to be demonstrated during the procedures where they're identifying structures, and therefore we are sure that they have gained the necessary skills. Now in this training, with self-assessment, we noticed that many of our residents, beg your pardon, scored a median of about 4.4 on the Likert scale, and that was before training. That was a summary of their knowledge and anatomy, and also or the anatomy of the inguinal canal and hernias. But this improved to 8.4 after the training. And the specific knowledge improved in the same assessment from 4.8 to 8.8. So specific knowledge improved in, so we're able to actually demonstrate that unintense training using a standardized program can help pass on a very vital skill within a specific period of time using a very commonly occurring procedure. And so this is our evaluation after the training. Over the last 6 years, we've trained a total of 68 residents, and 58 of those were able to carry out both tissue and mesh repairs of simple inguinal hernias completely and independently, which we felt was quite good. And then noting as well that a few of the participants, 6 of them, required only minimal supervision, and only 4 required supervision even after completion of the course. And what we usually do in this scenario is we link up with the mentors from the universities where these students come from, and we give this feedback to make sure that they continuously improve in their training. Many of the participants of this training have since graduated and are mentoring many others using the skills that we have given them in inguinal hernia surgery. So in conclusion, we demonstrated that intense close supervision can deliver, especially when you're using a standardized tool to actually improve surgical competence of our residents and help them improve surgical skills. Thank you very much.
All right, thank you so much, Dr. Wasimbe. Please keep the comments and questions, they'll come at the end. So now I call upon Dr. Phyllis Kisa. Dr. Phyllis is going to talk about pediatric emergency surgery course in Uganda, long-term follow-up and insights from further dissemination. So, Dr. Kisa, I hope they have your presentation this time.
Good afternoon, everyone. I'm sorry, they have a glitch and they don't have my talk, so I hope I'm able to communicate what I need to communicate. So I'm here to speak about the Pediatric Emergency Surgical course, which is a course that we've run since 2018. It is the course was born out of the type of referrals that we receive, but also the confidence level of our peripheral providers in managing pediatric surgical conditions of the emergency type. So we developed this course based out of that, and also out of the knowledge that we have very few pediatric surgeons in the country, and we have to depend on other providers to do that. Someone was earlier asking about task shifting and things like that. That is a totally different concept, but also the way we train our trainees here is that there are some things that should be within their mandate so that we can get better care, especially of the emergency type, to the patients that we have. So just to go back to some of the information we had, this is a very young country, one of the youngest in the world. And we have over 50% of our population under the age of 14 years old. And currently, our current population is 47, so you can imagine this is a country of children. Unfortunately, also, the children are having children. So it's kind of an exponential growth that I'm not sure how we can catch up with it. So if you thought about it that We currently have 10 pediatric surgeons, and we're producing one every year since 2015. If we're producing one every year, but the population is growing by at least 2 to 3 million every year since that time. So, I mean, at that time we had a 37 population, now we have a 47. So in 10 years, it has, the population is exponential, but we are producing one surgeon for each 2 or 3 million. We will not catch up with what we expect to achieve. It means that we need other providers to do this for us. So currently, like was mentioned earlier, we have 2 specialized centers in Barra on Kampala offering with pediatric surgical units, but that doesn't mean that there are no other centers that are offering pediatric surgical services. But the biggest challenge here is that even with that, there's still a huge burden of pediatric surgical need. So one of the things we've been doing with the most urgent thing really is to deal with emergencies. And all reconstructive stuff can wait. We can always talk about what this looks like if you're alive. If you're dead, who cares what you look like? So the point here is that any reconstructive problem can always wait, but what is life-saving that you can do for the patient? And so the focus of this course is to make sure we save lives, and it focuses on decision-making for children. What do you do when you're faced with a child? How do you manage them? How do you resuscitate them? How do you transfer them? And how do you transport them so that they do not get sicker when they get to wherever they have to go? But also, what can you do within your repertoire of your resources safely with expertise and infrastructure? So we've run a lot of these courses around. The first ones were in the central, then in the southwest, in the Midwest. We've had 2 now in the north. We've had one in the northeast as well. But one of the things that we've done is we had a follow-up study from this to look at the impact of this study. And one of the things that came out of this course is that actually after running the course, following them up initially 6 months and then 2 years after the course, we found that one, we're having more referrals for neonates. So sometimes, yes, we're having more babies, but also more are getting to us. Before, there's much more limited information, but also how do they channel them to specialized care? So we're getting fewer because they didn't know how to channel them to us. The other thing that's also improved is like also infant referrals, particularly for specialized services, has also increased, particularly from the regions that we've had this course happening. The other thing we found is increased practices in some specific areas. And this has been good because we've had increase in the number of pyloric stenosis done in the periphery, intussusceptions and hernias combined. So again, these are things that many times we're faced with patients who, if when you refer them, they either have very little time to get to you or they might refuse referral. And so if the surgeons in those regions or surgical providers can do that, it's a good thing when this happens. Of course, we still have a journey to walk, and it's not perfect. So one of the things we're looking at is what are the next steps. Almost at each time we've had this course, we've received feedback for it. And part of it is like, can you make it more practical? So the last 2 courses we've had, it's become more practical. The problem with this is that we need the patient population to be able to do this. This is not uniform across the board, and it's not always possible to get the kind of patients you want to teach people on. So we're currently working on a bunch of simulations. Unfortunately, I can't show. Can you play? That's a video. The next one is a video. Can you? And if you can play that, I'll just talk over it. So this is one of our fellows working on, so we're using silicone to make the anterior abdominal wall. We use it with mesh. It has very good fidelity. It does feel like skin and muscle of a child. So we've been able to work through this, and we've got that. We're still working on what the bowels should look like and feel. So this is someone trying to construct a divided ostomy, and we think that with something like this, we'll be able to teach construction of ostomies instead of having patients with intra-abdominal compartment syndrome sent to us over here when they could do this over there. There's a bunch of other procedures we're looking at: peritoneal drain placement, placing of a silo bag, and we're still working on some infant hernia models, which is not very easy to work on. So this is one of the things that we're looking forward to work on, so that we can actually do more practical things, like I said, because relying on patients is not always very easy. and it's not always consistent. So we've been able to do that in the sites where I've gone, and it's highly appreciated, but they're always asking for more and more hands-on, and so we're working on this area to be able to do that. I'll just wait for that. So with this, I mean, he's able to mature, and the silicone, the abdominal wall out of the silicone is able to hold the suture very well. Of course, the glove is not the best to represent bowel because you can't do all the layers well, but it still is able to demonstrate what we need to do. And we don't have complete calculations of how much it will cost, but so far it's very low cost, and we can make multiple sheets of abdomen that we can put over boxes, and then we're able to do the procedure with that. And this, we can actually look at how people construct this. It's really the technique that matters, and then we can always look in the future to see how they can identify the bowel and things like that when we use other models. We wanted to use a model that doesn't have any animal products because we have problems with temperature here. Ambient temperature is extremely high, and if you're using animal products, these things go bad, but also there's also rules and regulations in using animal products and parts, or even animals, and it's becoming more and more stringent using these things. But if you want someone to practice, they can have this in their backpack. It doesn't smell at all, and so they'll be able to practice at any time how to do whatever procedures. The last slide, please. So the last slide. So this is just really a framework of how we hope to work in the future. At the end of the day is we are hoping to create a theory of change, to create a community of practice to improve pediatric emergency services in the country. Thank you.
So thank you so much, Dr. Kisa. Now let's have Dr. Alan Zambeli. I don't know whether he's around. Dr. Alan, can you put up your hand? The Alan is presenting with Treasure. She's doing the presentation on behalf of Dr. Alan. Okay. Sorry for the mix-up, but that's what is written here. Yeah.
Good afternoon, ladies and gentlemen. Let me wait for the presentation to load up. Namo Gamasa Monica, and I'm going to be giving you a presentation not so cool compared to what the others have presented. Okay, so I'm going to be presenting a cross-sectional survey of Ugandan faculty perceptions of a potential locally run trauma fellowship program. I have no disclosures. So we know that trauma is one of the leading causes of death worldwide, and global estimates indicate that improvements in trauma care would prevent 38% of injury-related deaths. Certified in-hospital trauma and critical care training may improve trauma mortality in low and middle-income countries. However, there is still no subspecialty training for traumatologists in Uganda, nor in any of the COSEXA member countries. So the potential impact of these courses or this fellowship in low and middle income countries is less clear, but we do know that without faculty support, such training will not be possible. So the aim of this survey was to assess faculty perspectives on a potential trauma fellowship program in Uganda. So after doing pilot testing of cognitive interviews with experts, we created a cross-sectional survey that had 19 multiple choice questions and 1 free response prompt. And the subjects were the Ugandan emergency and perioperative specialists involved in trauma care, For the data analysis, for the multiple choice questions, we used descriptive statistics like frequency and percentages, while for the free text, we did reflexive thematic analysis. So these were the different specialties of the people. We had 39 specialists coming from 14 different subspecialties. So 67% of the faculty were dissatisfied with the state of trauma care in Uganda. And so we went ahead to ask them what they thought the reasons for this were. And 89% of them felt there was insufficient or inadequate material resources. Other reasons that were given included delay or late presentation to hospital, insufficient human resource, and not trained specialists in trauma, among other reasons. The little free text you see down are some of the responses from the thematic analysis. So 89% of the faculty state that they strongly agree that there is a role for a trauma specialist or surgeon in Uganda. So we were still interested in knowing if there is so much interest, why don't we have any trauma surgeons in the region? So people felt that lack of proper trauma systems in Uganda was the biggest reason for this, and a lack of a training program in Uganda was the other next big reason for not having any trauma surgeons around. So we went ahead to ask the specialists what they felt the barriers and motivating factors for starting a trauma fellowship or its existence in Uganda were. And again, most of them felt that lack of trauma infrastructure, such as supplies, staff, theater space, was the biggest reason. And lack of a trauma fellowship was another reason that really featured. On the part of motivating factors, we have a high burden of injured patients, so the surgeons would not lack patients to work on. And there are already established accreditation pathways in other specialties like urology and pediatric surgery, so we can easily borrow from them while creating this fellowship. So this table here shows us the different specialties that participated in the survey and the 3 commonest procedures that they feel a trauma surgeon should be proficient in. I'll give you half a minute to just look at it. So the specialists went ahead to give some curricular recommendations, which we are going to factor in while working on this trauma fellowship program. So, well, they felt that it should be a hybrid sort of fellowship with some local and international settings, because the international settings already have well-established trauma fellowships and trauma systems. Yeah, in conclusion, this was the first survey of our Ugandan faculty perceptions of a potential trauma fellowship in the country. And despite the multifactorial challenges to trauma care in Uganda, faculty overwhelmingly support the creation of a Uganda Trauma Fellowship program. Faculty also provided some actionable recommendations which we plan to implement in designing the curriculum. I'd like to acknowledge those people who contributed to the presentation or research. Those are some of the thematic responses. Hopefully, I've managed to convince you. So I'm calling upon anyone who would like to collaborate in working on a curriculum for a trauma fellowship, and anyone like COSEXA who would like to take it up. Yeah, welcome. Thank you, and that's the end of my presentation.
All right, thank you so much. Now, for this last session, which I'm chairing, we are going to have Dr. Isaac Guma. Dr. Guma? Dr. Guma is going to talk about acute trauma care training in Uganda, Ugandan medical schools, a cross-sectional survey of final-year medical students.
Yes, thank you very much. I'll start by apologizing. I'm actually not Dr. Isaac Guma. My name is Mwaka Francis Matthew. I am here on behalf of Dr. Guma Isaac, who could not make it. I'm a junior house officer currently working in Jinja Regional Referral Hospital. We work together on this paper. The title, as it is on the screen, Acute Trauma Care Training in Ugandan Medical Schools, was done over the course of July 2022 to January 2023. The background, I think it was appropriate that my presentation came after the former. Trauma is on the rise. If you've worked in any Ugandan hospital, you don't need any introduction. I would love to give some of my experiences as a junior house officer, but I signed a confidentiality contract, so I have to stop there. The first person I would love to see in each of those situations is any specialist with emergency care training. I think the same goes to everyone else. But as we all know, there are very few and also not as well distributed as we might like. Global surgery has been one of the themes of the day. The solution, according to WHO, was task shifting, right? Where appropriate, take these tasks to less qualified but appropriate staff who end up being the nurses, clinical officers, and then people like me, junior house officers. But the thing is, do we know how well that the training for acute trauma care is being done? Besides the assurances that come from NCHE and UMDPC that the universities are training appropriately, we do not really know what's going on. We just say that we do the training and someone needs to put that under a microscope. That's what me and my team tried to get into. We wanted to assess the knowledge levels and the confidence of final year medical students who have just finished the final structured teaching for their level in managing acute trauma care. And our results will be presented. Our methodology, we got our final year students. We did not want people who have retakes, people who have had any further education, say, for example, internship, which might add extra knowledge. And using a random sampling where we took the lists for every single final year student at that time, which was 8 universities at the time, we submitted, we administered a questionnaire in 2 parts. One that looks at knowledge with 25 questions, and another section that looks at confidence in various skills and assessments to see how the final year students felt about their management. And we did this using the Kobo toolbox and did our analysis with Python as it is there. Yeah, that's the data. Of the 700 participants, we got about 35% of them. 88 of those returned results, and then we analyzed after cleaning our data, and the results are as follows. Those are some of our descriptors: age means, gender. The 8 universities at the time that this study was done, UCU and Sorority did not have any final year students, so they were not included. And yeah, one of the first things that we should take note of is to the far right of the screen. 60% of our final year students do not have any dedicated acute trauma training, aside from what is assumed to be administered during their course. And 59.3% have no exposure to trauma specialists at all. The following slides are graphical representations of our data. One is going to represent the knowledge section of our paper. The other one is going to represent the confidence. The mean knowledge score for the MCQs was 58.9%, which might be encouraging or discouraging. It's above pass mark, I guess. But when someone has just been through a trauma event, I think we would want a higher number, right? Median score of 60. And the one that I would like to turn our attention to about standardization is the variation ratio. Higher variation ratio meaning that there was more diversity in the answers rather than every single student picking a single one. If we look at how the graph is going, we have a bunch of questions where majority of students had the same answer. But there are others which go all the way to the right towards a variation ratio of 1. And I mean, if there's only one correct answer and that one correct answer is the one that saves the patient's life, do we really want to see such a large variation? I don't know, it's up to you. And this is in the section concerning confidence. The letters might be a bit small, I apologize. I didn't know what size of screen I'd be working with. But we try to get the confidence levels. Thankfully, majority of the students, when subjected to the Likert scale, they had scores above 3. Scores above 3 is saying, I am pretty confident in it, but I probably need more training, which is a good thing. We didn't have anyone in the lower sides, 2 and below, which is saying, I have no idea what this is. But as far as the sections go, it might be a bit small to read. The first part of this line graph is saying trauma assessment, being able to diagnose what's going on with the patient. Those scored highly, as well as radiological interpretations. However, the bit about managing special sections of trauma patients, say for example, pediatrics, pregnant mothers, burns patients, or performing life-saving procedures, the likes of the cricothyroidotomies and all those scored quite lower, with a total average at around 3.8. I would want to think that these are things that we can take a lot closer to 5. 5, according to our Likert scale, saying, I can do this without supervision. I think that's what we should be working towards. The strengths of the study, we did go to every single university at the time, and using aggregated results means that students were more willing to participate because they knew they would not be singled out for having low knowledge or low competence. Perhaps a limitation I can mention is we were not able to do a hands-on skills assessment. We had some restrictions. And also, there was a disproportionate representation of universities, where we have some universities bringing as much as 40% of our participants. So that might have skewed the results. I'll leave it up to you to decide how relevant the findings of this study were. But in conclusion, I would like to say that the variability in knowledge and confidence is very evident, as the study shows. It is significant and it is suboptimal, especially because we are having task shifting, and the people who are affected by this study are the ones who are going to be taking care of your mother, father, wife, husband, and all. Our recommendations as the team is we need to give a more standardized training. We need to make more standardized training programs that are addressing undergraduate doctors. That's what I had. Thank you.
Thank you so much, Dr. Mwaka. Professor Reikard, I think we are somewhere in research mentorship. Yes, junior house officer. So I call upon my co-chair to take over. We are co-chairing these sessions for the next 2 presentations. Thank you.
Thank you very much. Thank you, Prof. Robinson. Ladies and gentlemen, allow me to take you back a little bit to the Global Surgery and Innovation section. We have Ms. Rebecca Kaya Nansubuga. She's going to talk about using locally made local silo bags to improve gastroschisis management in Uganda. Ms. Rebecca Kaya Nansubuga, please come forward. She is a graduate in biomedical engineering from Makerere University. She's interested in medical device research, design, and innovation. She's currently working as a research fellow with Makerere University Biomedical Engineering Unit. Please.
Okay. Thank you very much, Dr. Lloyd, for the introduction. As mentioned, my name is Rebecca Kaya Nansubuga, and my topic has been mentioned, but it's mainly concentrating on saving babies at birth. Yes. So my topic is centered around the gastroschisis defect, which is a condition where a baby is born with the intestines out. That is through a small opening on their belly, usually close to the umbilical cord. And this is, of course, not good for the baby because the baby is losing heat to the surrounding, but then they're also losing some of the moisture through the intestines, which could lead to dehydration and hypothermia. And there's also a risk of infections to the baby because, well, the air around could cause pathogens to land onto the intestines. So how the condition is managed, even in the high-income countries, is they use what they call a silo bag, which is the image on the left. So this is just like a silicone bag with a rubber O-ring in which the intestines are inserted. Then the ring is flexed to fit into the hole where the intestines came from. Then gradually they have to push the intestines back into the abdomen. Because this cannot be done all at once, that will create sudden pressure, causing further complications to the baby. So when the intestines have been inserted into the silo bag, they hang it vertically and do the pushing in. But despite having these bags as the remedy to the problem, if we look at the statistics for the condition, they're actually alarming because while in high-income countries, more than 96% of the babies with the condition survive, in low and middle-income countries, the survival rate is less than 10%. And the reason for this is because these bags are actually inaccessible. Well, they are made from abroad. So by the time the condition is there, you get to order the bag. By the time it reaches, maybe 2 weeks of shipping, the baby is already dying. But then the bag also costs about $200, and we know that many cannot afford that in Uganda and other low-resource settings. So what we did to solve this was create an alternative, a low-cost alternative, where we repurposed catheter bags, which we know have already been tested and proven to be body-friendly. So we repurposed those and we initially were using female condom O-rings, which have also been tested to be body-friendly, but we got available O-rings on market to make a simple bag that you can see on the image on the right, which can be used to save babies with this condition. And we carried out tests on the bags that we made. Some of the tests are those that we tested for the deformability of the O-ring. That is, if you compress the O-ring to insert it into the abdomen, will it open back such that the intestines can pass through as you push them in? We tested the durability of the sealing method that we were using. We also tested if we can make the bags reusable. And we tested for water tightness because we had to make this bag fluid proof. We don't want to have a bag that has openings where pathogens could enter and affect the baby. So those are the results. I will not go into much detail, but from the results we analyzed and realized that the performance of our bag was actually very much comparable with the standard of care silo bags. Maybe just to add on to that, we did those tests both with our collaborators at Duke University, but also here in Uganda at Mulago Hospital. So this is a graphical representation of the results. And we also went on to do porcine model tests on our bag. And like my colleague Paula, who presented on the Q-scope, mentioned, we did these tests at Duke University. We couldn't get to do them here in Uganda because of the stringent rules on animal tests that we have. And still with these tests, we realized that it's comparable in performance. So after doing our benchtop test, our animal model tests, what we are currently looking at is doing a first-in-human clinical study for those bags, after which we shall move on to the other processes of getting regulatory approval and making the bags available locally such that we're able to save these babies. And maybe I would say that I'm happy to hear Dr. Phyllis mentioned that they hope on making a training model for how to solve these problems, so that would also work well with the device we're making. So I'd like to recognize the team that has been instrumental in making this work come to be. Dr. Robert Sechitoleko, who's in attendance today, he's the local lead. We have Kato Hussein, he presented to you. We have a team from Duke University, and we've been also working with some surgeons locally, including Dr. Anwe Songa and Dr. Rovin Naluyumbazi. Thank you very much.
Thank you, Rebecca. Our next presenter is a doctor in the making. He's called Banturaki Davis. He's a fifth-year medical student at Makerere University. He's the outgoing president of the Federation of African Medical Student Associations. And currently, he serves as the chair of Incision Uganda. Dr. Bua told us a lot about what Incision Uganda does. And his topic is about unmet needs of global surgery, fueling surgical innovations. It is a scoping review. Dr. Banturaki Davis, you're welcome.
Good evening, everyone. It's a pleasure to present to you. My name is Banturaki Davis, as mentioned, and I'll be presenting on unmet needs driving innovation in global surgery. Next. Oh. So, once again, I'll be presenting on unmet needs driving innovation in global surgery. And this is my outline. And going regarding the background, we all know from the last Senate Commission on Global Surgery indicated that 94% of low and middle income countries lack timely and affordable access to surgical care compared to those in higher income countries. And this last Senate Commission also indicated that 16.9 million lives were lost in 2010 from conditions that needed surgical care. This is not different from our context in Uganda, where we have annual surgical volume of 144.5 for every 100,000 people per year. And we also have 0.2 operating rooms for every 100,000 people, and also having less than 25% of the population having access to having 2-hour access to a surgical facility. The burden is huge, as you can see from the research carried out in Uganda, where the nationwide household survey indicated that less than about 27.8% of the people above 50 years do not have access to surgical needs or facility in their area. And this therefore means that we need us ourselves to come up with innovative solutions to bridge this gap of disparities access to surgical care. We carried out this scoping review to map the unmet needs in surgery and anesthesia over the last decade that can help drive innovative solutions. We did the scoping review of the papers from the last decade, and these were on unmet needs, barriers, and solutions in surgical care in low, middle income countries, according to the World Bank classification. Databases including Cochrane, Medline, Scopus, Biolin, Google Scholar, and Globus Index Medicus were searched. And papers were included if they presented on unmet needs or proposed a solution to these unmet needs. Over 69.9% of our papers found were original research studies, and 15.5 and 8.5 were review and reports, respectively. This is a geographical location of where the papers were produced, and it's fair enough that we represented. The papers were representing the low and middle income countries, although the publications on these unmet needs seems to be decreasing with time. We did a descriptive analysis using Microsoft Excel, and the findings were presented in heat maps, tables, and charts. And the results were categorized under 6 items, including workforce, training, infrastructure, information systems, finance, and service delivery. These are the major categories. We shall subdivide them. And from these major themes, we find that workforce training had the biggest gap of unmet needs, followed by shortage of workforce, lack of equipment, and high cost of treatment. So regarding unmet needs related to workforce, we find, as per the Pareto chart here, we see that shortage of specialists, it alone accounts for over 80% of the of the reasons leading to unmet needs in surgery, in workforce. And the other factors included those, for example, shortage in other factors included, for example, shortage in paraclinical staff, or maybe shortage in administrative staff, or maybe mixed. This is the same case in Uganda. I think there's been numerous studies conducted. I think some of the authors are part of our conference today. There is a significant gap when it comes to surgical workforce and specialist training, as per results. As per our scoping review indicates 64% of unmet related needs in global surgery. The other one, we can look at training. We had other factors, including lack of advanced training, lack of basic training, and lack of advanced training and lack of basic training together account for over 80% of the factors leading to unmet needs in global surgery. So unmet needs related to training in global surgery. So we also see that factors or unmet needs related to finance. We have high cost of treatment as a single most major factor leading to unmet needs related to finance, and accounts for over 51.27, and other factors including limited case-specific funding, high cost of transport, other factors that contribute to unmet needs related to finance.
2 minutes.
Other factors included information, how are we accessing information, and there are very numerous factors, including limited records to conclude on a case, for example, underreporting, lack of digital recording, and lack of access to data. All these together accommodate or account for over 80% of the factors related to factors accounting for unmet needs related to information, and the single most important factor being limited records to conclude. Other factors, we had service delivery. We had inaccessibility leading, which it's alone, although there are many other factors, accounted for over 80% of unmet needs related to service delivery. So this is a summary of all our results, showing the four most important being shortage of specialists, inaccessibility, high cost of treatment, and lack of advanced training. So in conclusion, we see that there is a need for innovation in global surgery, and us understanding the factors that are bringing up these unmet needs is important, as we did the scoping review, showing workforce training, infrastructure, service delivery, and this can help inform the innovators. We have many different fungal innovations coming up that can help us address these needs in the context-specific, with context-specific solutions to achieve global surgery needs. Thank you so much. Acknowledgement to the innovation in global surgery team. Thank you.
It's now time for our discussions. I'd like to call upon the presenters, Dr. Phyllis, Dr. Basimbe, Dr. Namuga. Please come forward for a discussion. Dr. Mwaka and Miss Rebecca Kaya, Nansubuga. So welcome questions, comments from the audience. Microphone. Someone help? Okay. Okay. Prof. Galkandi had something to say.
Thank you very much, presenters, panelists. We like your confidence, especially the younger ones. 11 out of 10 is my score for that. Francis Mwaka's presentation about, it speaks to curriculum development, and two things there. One hopes that the structuring of internship contributes to the foundation that someone picks in the first 5 years. But maybe the question would be then, how is internship structured also? And of course, we know in our circumstances, by the time you qualify, you've done your internship, you're almost an independent practitioner. But ordinarily, you should find you should find protection where you work, that the people are a bit more experienced and knew that the skills would develop. But those points for looking back at the curriculum, I think are important. The silo bags, very comforting and pleasing to see that the biomedical people are doing a lot of work. I think in the future we should have a structured conversation of needs of surgeons and challenges and talk and generate a whole catalog of potential work that can be done. Yeah, and for Dr. Basimbe. So what are the implications of that model in training? If you watch one and assist one, that's the impression I got, and take the lead in one, are you proficient enough to take on things? But also after that kind of training, was there a follow-up? And the question with that is that, do skills decay? If I watched one, assisted one, did one, but I take 6 months without doing the next one, am I at a proficient level or back to where I started? Yeah, I think I'll end there. I have others, but I think I'll end there.
Okay, thank you, Prof. Galkande. There's a question at the back. Oh, sorry. Please go ahead.
I can. So I want to recognize all of you today for struggling with some of the technology, and especially Dr. Basimbe and Dr. Kisa for giving their talks without their slides. Nicely done. I think I would have struggled much more. Dr. Basimbe, similar to what Dr. Galakande was asking, how many cases does it take for one of your residents, trainees, to really get to the point most of the time of being able to fix a hernia without significant assistance? Another related question that I know comes up every time we talk about hernias, which are very common all over the world, and the need for hernia repairs, which is very common all over the world. Are surgeons the right people to be doing those repairs, or do you train a surgical technologist of some sort to do those repairs? Just to trigger your discussion a little bit. Thank you again for the chance to comment.
Can I go ahead? Thank you very much. Great presentations. I wanted to combine Mwaka's presentation with Martha's and to comment about the training in trauma care. I think this is like the third surgeons conference at which this comes up, and we make comments, we say something should be done. But I also have to say that most of what skills we gain was through apprenticeship. And I am aware that in many instances, even when students have had training, have had lectures or whatever else goes on during their 5 years, I think we're struggling to have enough senior doctors in the accident and emergency department to supervise, to teach, to handhold if that's what is needed, but to really demonstrate acute trauma care. And so a lot of it happens almost by, it's a haphazard way of somebody might come across this skill or might never. And we've been limping through this, from year to year. I think it was like 2 years ago, maybe a bit longer, when we said Asou and COSEXA need to come up with a position on this, on how to manage and what kind of training is needed for trauma care. And I don't know if that's what sparked the survey that Martha talked about. But I think even without that, we are all aware that if, God forbid, you should end up with serious injury in any of our facilities, you're going to struggle, even when there are senior doctors, surgeons in that hospital. Somebody not too long ago told me that one of the reasons is because it's not easily transferable into a private, yes, people don't really earn. If your specialty is trauma care, then how are you going to, you can't quite charge the patients in the accident and emergency. Mm-hmm. And so, maybe it's neither here nor there, but that's a reality, is that you're working in an area where it's difficult to have a thriving private practice, and so it discourages, I think, residents when they're making their decisions where they want to end up. But it's one that I think, again, Asou, maybe COSEXA need to have to to focus on this and come up with a position on how we would like to see this area grown, this area developed, and how we can then make it appealing to those that want to join the field and to make it their career. And those that may not want to necessarily making their career, but how to make accident and emergency departments safe places for patients to be. Because right now, a lot of them are death traps, I'm afraid. And I think it's terrifying for junior doctors, Mwaka and the like, to be in a place where you could end up with patients that you really don't know what to do with, and you have no seniors that are available to help you manage these patients.
Okay. Thank you, Dr. Olive. I think let's take 2 more questions, and then we have the panelists respond. Prof.
Thank you.
Kiria,
Thank you. I already have the microphone.
Oh, sorry.
And since I have the microphone, I think I've been allowed to talk.
Yes.
Mine is to Dr. Basimbe. Thank you very much for that paper you presented. I would do... they want me to stand. I think I'm extremely short. I oblige. That paper you presented, before I ask the question, were these the people we commonly refer to as postgraduates? It's in the affirmative. And they are doing what we refer to as a Master's of Medicine in Surgery. Then I invite members of this association to worry, because if that is the quality of postgraduates we have, who actually have to be trained to operate a hernia, and some have difficulty learning, then I think we have a big problem in our choice of raw materials for people to join surgical training or surgical residency. That course that you offered during my time was actually offered to intern doctors. So, in other words, we are saying we are developing in the surgical field, we are going laparoscopy, we are leaving open surgery, and we cannot do the basics. And it is for this reason that I indeed invite Asou to worry. I think we need to retrace our footsteps. Where did we lose it? No wonder people come out with masters in medicine in surgery and you wonder where they trained. I'm sorry if I'm worrying alone, but if you are worrying with me, then we need to do something. Thank you.
I think with that, maybe we should have Dr. Basimbe
I had my
respond.
hand up. We can give Dr. Basimbe a breather to prepare his answer as I make my submission. Yes, thank you very much. Very good submissions. Trauma does cause trauma in the heads, even in the heads of the listeners. And so the choice of submissions was good. Just to follow on Dr. Mark's submission, definitely there is a problem. That problem arises from various issues, one being numbers, but also another being the one which has been brought out by Dr. Namuga, there being no trainers. Because if there is no training in trauma, that means there are no trauma specialists, and therefore in the undergraduate program there are likely to be no trainers. One of the solutions is to have simulation, but also at Asou we've been trying to see if we can have a simulation lab, have course curriculum with course content which targets undergraduates, but also targets pre-interns. With these mushrooming numbers of graduating doctors, there is now an established period of months, 8 months, 1 year, where people have finished their MBCHB and they are waiting to be admitted into the internship program. We are thinking that period can be utilized to fill in gaps in training which may not have been done during the undergraduate training. Should that not happen, that the internship program should also have time where this training can be done, so that by the time one qualifies or is signed off from internship, they have had these extra trainings. So we target the pre-internship period or the actual internship period, and then we've got a certification that this person has also had training in ATLS and, trauma care. Thank you.
Okay. Thank you, Mr. President. Dr. Basimbe, you seem to have most of the questions. The rest were comments, so you can respond.
Thank you so much for the comments and the questions and the interest in what I presented. I'll start with Professor Galukande's questions about the implication of the model of training that I presented. And to give a bit of a background or some information about how we conduct these trainings, we usually put out an advert and we usually take on a maximum of 9 residents, and those are within 3 trainers. The numbers, some years have varied to 12, and that is when we have 4 trainers. So that means every trainer has 3 residents that they will train. The community hospital where we are going to do the practicum from usually we run it, we put the advert out there, and we usually have about between 100 and 120 hernia patients usually waiting for us. And so what that means is that for every group, which is 1 trainer, 3 trainees, has about 40 to 50 hernia procedures waiting for them to do over the period of the training. So the model that I presented, where there is a demonstration, there is the next stage where there is the student doing the operation being observed, and all that, all the way to proficiency, is done over a number of up to 50 operations during the training. So what we have demonstrated is that over that period, we end up having trainees that are really proficient and understand really the anatomy and the surgical skills in doing these operations. The second, and that is also to add on to what Professor here asked as well, the issue of decay. We all know knowledge decays, but what has happened over the years as we have conducted this training is that many of the trainers usually keep in touch with the trainees. And I'm glad to say in this room there are many people that have participated in that training and have continued to grow their skill. We also run a train of trainers program that is attached to these trainings, where those that participated continuously grow their skill and are continuously being mentored by their trainers in doing more complicated cases. We have also been using social media and media in general over the past 6 years, where those trainees and a particular trainer, when they go out and start doing these operations, they actually relay this information back to their trainer. So we actually have WhatsApp groups for every cohort of trainers that have gone through this training and trainees. So when they go out there and do complex hernias and do these operations, they actually send the images, and actually we share the difficulties and how to solve them. So this is a continuous training process. The issue Professor raised about surgeons versus training other cadres, we have been strict on training surgeons, and still to add it on to Professor Chiria's question. Before we started this, we identified a gap. If you've noticed, there are many universities now that are training surgical residents. The numbers have gone up, and in some scenarios, the patients for some of these procedures, given the location where the universities are, have been a challenge. And so we identified that this is definitely a problem, and many of these residents who were training needed from across board, and this is not to any specific university. We've actually seen this across all our universities, and so we felt that if we conduct this training and we go to centers and have these many patients, we can actually be able to pass on this very vital skill. So it is worrying, but I feel what we are doing is answering probably to try and solve that particular challenge with skills transfer in a situation where you have a growing number of surgical residents. Thank you.
Okay, thank you. Any comments from the panelists? Any last words? Okay, so I guess this marks the end of our session, which was combined mentorship and training as well as global surgery. Thank you very much.
Thank you so much. I beg for your indulgence a bit. I want to borrow 30 minutes of your time right now to have a lecture. It's the Laura case lecture, which is going to be delivered by Dr. Doruk. Dr. Doruk is an associate professor of surgery at the University of California in San Francisco. He's the director of the UCSF Center for Global Surgery and Health Equity. Dr. Doruk became involved in surgical collaborations in Uganda in 2003, and since then has been a part of multiple collaborations to strengthen surgery and anesthesia care in the region. Mostly building capacity, and he's the founder of the Global Partners in Anesthesia and Surgery. This was focused on Uganda, and the founder of the Global Initiative for Children's Surgery. He's also on the advisory board of Kids OR, which has been talked about earlier today. He's also associated with the HEAL Initiative for training and global health equity. So, and he has had a long-standing relationship with Uganda since 2003. And who best to introduce perhaps him more than one of his fellows? Dr. Namuga, you can kindly come and probably give some guidance. Kindly, I request that if you can do it in 30 minutes, so we can go into another program.
Hello, Doruk. Hello.
Hi.
Hi, Doruk. Hi, how are you, Jackie?
I'm fine, thanks. How are you? I've known Daruk for so many years. Unfortunately, he decided to go into ped surgery. I thought he was going to become a trauma surgeon, but he decided to run away from us and went into pediatric surgery. Jackie Mabujano, senior consultant surgeon. I'm working in Mulago National Referral Hospital in the casualty department, and I've been there for, I think, too long. I think it's time I left. So that's where I met Daruk. He came, I think, as a young resident. That's when he started coming over. And now he's also now a senior consultant. And he has all these administrative posts. He has so many titles, I don't know what to do with him. And that's how we also ended up with Martha. And together, we developed a course, which is called the Kampala Advanced Trauma Course. So it's an amalgamation of the basic life support, life support and advanced trauma life support systems. Because we found out that we couldn't actually give all those as they are. How many of you have seen that ATLS book? It is as thick as this. And we found out that we just couldn't give it. We couldn't do it. So we tried to bring up our own. We formulated it, and that is the Kampala Advanced Trauma Course. Now, the Laura Case Foundation, or what is it? Trust Fund. They help to support this course. And unfortunately, it is named after Laura Case, who was a young lady, I think she was a medical student, who had come to visit Uganda. And unfortunately, she passed away following a road traffic crash here in Uganda. And the family has put up this fund. So they raised the funds, and they have been funding the courses and many other projects. So we are very grateful to them. And Daruk continued to pass on our gratitude to them, although it is very bad circumstances, but unfortunately, but we are very grateful to what they do, and we pray that they continue to continue with that support. So Martha, allow me to call her Martha, she's my daughter, so I can call her Martha. She has been really in the background, trying to collect a lot of the data and bring this trauma forward. But this is my appeal to the young surgeons. We need trauma surgeons. Please, please, please. Olive went into the academia. She went to public health. She's no longer active in hands-on. In casualty, in the A&E, I'm alone. The head now, the other head, who was an orthopedic surgeon after he was promoted, I think you all know him. After he was promoted to senior consultant, he ran off straight to orthopedic surgery. The other one, who is now with me, is more interested in gastrointestinal surgery. So I'm more or less alone. And I'm growing old, people. Don't you see me limping? I'm growing old. We need the young surgeons. Please, please, please do some training in trauma. Trauma is taking its toll on Ugandans. Sorry, Mr. Chairman. I'm so passionate about it because my brother was involved in an accident, and I saw the repercussions of the treatment he got, which was really not so good, and it's had the permanent effects, the disability. You've seen the borders, you've seen, trauma is taking its toll on us. How many of you have been to casualty of late? At times we have more patients on the floor than we have on beds. In my day, people are talking about hernias. I think I did more hernias. We used to see hernias, would see sigmoid volvulus, would do laparotomies, isn't it? When we were postgraduate students. Sister, am I lying? But now, you see one hernia in a week. Everything is trauma. Neurosurgery, orthopedics. So let's try and see how we can get our young people interested and see how we can save the lives of Ugandans. Over to you, Martha and Daruk. Thank you.
Thank you, Dr. Jackie. I'm requesting that you load up the presentation. The presentation has a lot of pictures, so I can't tell you about it until maybe they load it up. I'll just give them a few. So good afternoon once again. So Dr. Treasure and I are going to tell you in a few minutes about just the work that the Lowercase Trust has supported in Uganda in just the last year. So in the last year, we've done about 6 trainings in Mulago. They are intern trainings, and we give them the Kampala Advanced Trauma Care course, which is very similar to the ATLS, but just context-specific. For us, we drop what we don't need, things like frostbite since we don't have winter. And then the mannequins that we use, we could improvise with like a box and goat ribs and some sponge and strapping to simulate a chest, for example. We've also done some regional trauma trainings, and we are in the process of developing a trauma fellowship. We have a draft of a curriculum, and like I earlier mentioned, we are calling upon more stakeholders, more people who are interested to work together and develop this. And then there's some prospects of future work. So those are pictures from some of our trainings. So in Mulago in particular, we managed to work with the surgical directorate and made this training mandatory. So if the interns don't go through this training, they can't sign out of the surgical rotation until they do. And the aim is to reach all the other training centers in the country. So in the last year, we've trained about 170 interns. But since its inception, we've trained over 2,000 doctors in the Kampala Advanced Trauma Care course. Some of you, maybe we visited your hospital in the past. You can recognize me from then. Surgery and anesthesia specialists. As you notice, there's Dr. Stella here from ped surgery, someone from neurosurgery, anesthesia, and all the others. So we make sure to call the experts in those different units to give the talks. So we use a lot of simulation during these trainings, and these pictures are some of the simulation sessions. That's Dr. Treasure doing his thing, and here we're doing a simulation of venous cut down. These people here are doing a simulation on bar hole. We have like synthetic skulls, and then we get goat heads or sheep heads, and then we have like a bar hole drill, so the students can get a feel of what it's like. And then this simulation is a chest wall. We have like a box. Then we get goat ribs, like a whole section of goat ribs, some sponge, some strapping. And we put like a glove with air inside, and so we simulate how to put a chest tube, and the different students can actually get a feel of what it would feel like to actually put a chest tube in the live chest. This is a video, we can skip it. So, so far, these are the hospitals which are on our menu. We completed pre-evaluations in Kawolo and Kabale, and we finished doing the trainings there this year. We have Moroto, Masaka, and Kirandongo. We did the pre-training evaluations. Their trainings are yet to come up. Hopefully by the end of the year, we should have done trainings here. And yeah. Those pictures there are from a training in, was it Masaka, Kawolo? Kabale, Kawolo, and a pre-hospital visit in Masaka. So why these hospitals? We use Dr. Kobusinje's trauma and injury report to see which hospitals actually have the highest burden of trauma, and all these hospitals had to be along highways. With the exception of Moroto, it's in a hard to reach, poorly served area. Sorry if I don't use the right political terms. So that's how we chose these hospitals, where the trainings are going to happen first. Hopefully with enough funding, we can, spread out to other areas. In some of these hospitals, we've done trainer of trainer. I know Dr. Boa did such a training, and recently they were able to replicate a training in Mbale without any of the original trainers available, just them in their center. So usually when we go, we give the KTC training, and then we go to the accidents and emergency unit. Usually we find a bit of disorganization. You find ectopic pregnancy, abortion, there's burns here, there's hypertension, everything is mixed up. So we usually work with the hospital administrators to get a trauma corner where we can get off 1 or 2 beds which are just dedicated to trauma, and then we give them a trauma trolley. I think you saw us handing over a trolley earlier, that one over there. So that trolley, we hand it over to them, and it's usually well equipped with anything they can need during trauma resuscitations. And then while there, we do the KTC trainings. We make sure to mix up the way the entire team that stabilizes a trauma case would be. We have some nurses on board, some doctors, some interns, and so on and so forth. So if time allows and resources allow, we hope to also involve Igang and Hoima. So like I said, I've been working on a draft for a trauma fellowship, borrowing from West Africa, South Africa, the ACS from America, to try and create something that can work for us. The question is, who is going to take it up? Who is willing to be the pioneer? There's some people who have expressed interest of being the first students. So again, calling upon whoever can work with us to develop. These are just a few things from our survey with the faculty, which I told you about. And the survey had 2 parts. One was for the residents. I didn't tell you about that. But the residents also had overwhelming interest in pursuing a career in trauma if it was offered. So over to you, Treasure, to give us the second part of the presentation before we invite Doruk.
Good afternoon to you all. My name is Treasure Ibengera. As you have all heard from previous speakers, trauma is a big deal in our country. And we've faced a lot of challenges in management of trauma and trying to set up trauma in our health system and make it stick. So I think you have pretty much heard a lot about the Laura Case Trust Fund, what they have done. This training that Dr. Martha has just told you about has been around for a very long time. It's been given to interns as a Kampala Advanced Trauma course. And they've been funding it fully, making sure that we have everything we need to give this training. So it's come towards its conclusion, and it has led us to something else. So I, working with Dr. Martha, Professor Doruk, and others, we decided to try and see a way forward from this training. We've trained people for the past 15 years. Then, okay, so after 15 years, then what's next? You've done all this training. These people have all this knowledge, so what is the point? What's the goal? How do we try and do better than just training? So we thought about this. This is something that we proposed, but it's now in play. And when you look at different aspects of trauma, you have the pre-hospital system, you have the emergency care, you have the surgical care, you have the inpatient, in-hospital care, and the rehabilitation part. So for the pre-hospital and the emergency care, these have been a little bit, they've been getting a lot of attention from the EMS side. Those are the physicians, the emergency medical people, even from Ministry of Health. So they've set up all this stuff, but then there's still a little bit lacking, and that's to do with the surgical care, the in-hospital care, and partly the rehabilitation. So this kind of brought us to what we wanted to do. We thought about doing a little bit more, advocate for trauma in terms of policy, in terms of system, do a little bit more of the training, and do a little bit more of research. So just to quickly go through, like I was telling you, the other organizations have come into place. Like you have seen, there's an injury and prevention awareness team in Ministry of Public Health. There's MOH training that is basically EMS stuff. And there's a team that actually came up with a trauma registry in Soroti. All this has been very good work, but it still leaves a lot of gaps in terms of trauma. So the central problem here was that there is no coordination of all these trauma programs, and there's lack of attention to the trauma system in general. So it brought us to think about creating something that we call the Trauma Surgical Foundation of Uganda. So I'm going to tell you just a little bit so that I can summarize. This is a foundation that has been funded and is being funded by Laura Kess, and it's going to try and set up all these things that we are talking about and improve trauma care in our country. So what is the aim of this foundation? So the aim is to bring everyone together under one umbrella, everyone that is interested in doing training, in advocating for trauma, in policies, all these different aspects of trauma. We want to bring everyone together under this foundation and have one goal, try and affect the health care system in a similar manner. Then the second thing that we are trying to do is grow our education mission, try and do a little bit more training, but not just to, let's say, medical doctors or interns, but branch out to nursing, maybe to orthopedic practitioners, and all these other few areas. Because when you go on ground, you find that in the whole country, very few people get attended to fast by a medical officer. Usually you find maybe it's a clinic officer, maybe it's a nurse, and okay, so so then the other thing was we wanted to create a transparent system for management of trauma grants, trauma research, and also for future funding. So the rationale is, of course, we have several challenges that's stemming from our ministry to the people that we work with down, and then infrastructure. If you go to casualty, if you look around Uganda, there isn't a proper trauma center. So all of this stuff, these are things that we're thinking about. So first and foremost, the activities that we've planned, we are creating a board. It's ongoing. And then we'll have a stakeholders meeting. Then we'll try and create collaborations between the existing organizations. That's the Uganda Medical Association, Asou, the Association of Anesthesiologists, Medical Council, and the universities, the different universities. Then we want to try and do trauma awareness campaigns for the public, for everyone out there, to know what trauma does to us, the effects that it has on people. And then we want to try and fundraise for more support and collaboration. So these are the activities that I've summarized here. The fellowship has kicked off. We want to continue doing the advanced trauma course. So we want to kind of make it a bigger thing, not like you've seen, go to Kawolo, go to Kabale, etc. We want to initiate and resume the operative trauma course. This is something that maybe we'll have a discussion about. Then we want to continue doing our research. We want to develop the simulation area. The simulations, we've actually written something into that, and we're going to create a simulation lab because as you've seen, most of our trainings, we use a lot of things that we think of, but we want to come up with real simulations and create, for example, a real chest using 3D printers, etc. So we shall actually acquire a 3D printer through this funding and do all this stuff. Then lastly, things about media awareness. Like, we do all this work, but most of you didn't even know that we do this stuff. So we want to put it out there. We want to make people aware of what we're doing and increase do a holistic approach to this trauma care So I think this is it from me. I put that picture to show you the chest wall that we use. So we want to do better than this for our simulations. So with those few words, maybe I put a picture here of Prof. And that's Professor Doruk, for those of you that don't know him. So Prof, you're most welcome. That's it from me. Thank you.
We can have the screen. Okay. You're welcome, Professor Doruk, to give your talk. Thank you.
Thank you, Martha. Thank you, Treasurer. Can you hear me okay on that side? Yes? Okay. I'm going to just share screen and see if... Can you see my screen? Is that a thumbs up? I can't hear. Okay, great. Okay, great. Thank you. Thank you so much. And I'm sorry, I'm really sorry I can't join you in person. I'm in California, and it's actually much more important you hear from Jackie, Martha, and Treasure than from me, but it's a real honor to be included in the program. I just wanted to say a few things. One is just the journey we've had with the Lowercase Trust, which Jackie, Martha, and Treasure alluded to, and really gratitude to them for supporting this work for so long, and then some of the lessons I think we've learned. And I'll highlight, I think, a few things that have also been highlighted in the meeting, and congratulations on an incredible meeting program. You see a picture here of Laura. Laura was a medical student in training, and just before she turned 24, as Jackie pointed out, back in 2007, she was killed in a road traffic crash in Western Uganda while she was on a visiting rotation. We met Laura's family and the trustees of the charity that they created around the time that we were trying to create some of these programs that Jackie, Treasure, and Martha have been highlighting. I, at the time, had finished general surgery residency in the US, and I was living and working in Uganda. This was a pretty typical Friday at the time, a little bit of a journey down memory lane, but Dr. Kagwa was the surgery department head. You see Dr. Majumbi there and Jackie, and we met pretty much every Friday morning as a joint surgery and anesthesia task force to think about things we could do together to advance surgery and anesthesia care in the country. And part of what came out of that work was a collaboration called the Global Partners in Anesthesia and Surgery, or GPAS collaboration, that many of you have been a part of over the last 15 to 20 years particularly to strengthen the workforce in surgery and anesthesia and work around education and training programs. And this is an older version of our website, but you'll see a lot of familiar faces that were involved in this. And I think we acknowledged that it was difficult to fund initiatives just through a traditional academic approach, and that capacity strengthening was key. I now direct our program here at UCSF called CHESA, which is the Center for Health Equity in Surgery and Anesthesia. We're part of a bigger global health institute here. We have representation from all the surgical subspecialties. We have a shared leadership between Ugandan and UCSF providers and educators, and really the mission of the center is around health equity, which really knows no geographic boundaries. We have major problems here in the US, and inequities are rife all over the world. Where I work here, within a 2-mile radius, we have a 20-year difference in life expectancy due to a lot of social factors. We also don't do well taking care of our kids. We have firearm injuries now actually kill more kids here than road traffic injuries. So we have major issues here at home, and some of the faculty and members in our center are working on issues here. With regards to trauma and trauma care, we've really struggled globally to get funding for trauma care. This is just a snapshot of funding from the US government for global health. You can see this is all millions of dollars where the money is going into the global fund in malaria and TB. This is not news to anybody in the room, but there's really nothing going towards trauma care, despite the fact that many of these avertible surgical deaths globally are due to injury rather than HIV, TB, and malaria. I met Jackie back in 2005, 2006. It's now been hard to imagine, almost 20 years, and many of you in the room who I consider my brothers and sisters proudly. And trauma was always the biggest and most pressing challenge surgically. And these are just some clips from the local newspapers from back in 2007. Jackie highlighted some of these articles and others, which we see still regularly, unfortunately, due to the burden of trauma. And we know there's just not enough resources. This was an editorial, again, dating now almost 17 years ago in the New York Times from a USAID worker in Uganda who stumbled upon an injury in Mbale. And unfortunately, the child was not able to be treated and saved. And they were right next to an HIV treatment center, which was very well equipped, and it was calling out that disparity. And so this was one of the first things that we really focused on in our collaborations was how to improve trauma care. And Jackie was recognized by the president for her leadership in this and other work. You can see her holding the sign there in the old ER. She's still based in the ER. Thank God for her and her service. Jackie, thank you. But this concept of improving trauma care, we saw in multiple phases. The first phase that we took on was pre-hospital care. And I always like to ask, where's the patient? But here's the patient, as many of you know, underneath and the police pick up underneath the seat. And so one of the lowest hanging fruits that we had tackled was actually how to improve this without really a formal ambulance system. And so we started a program, a pre-hospital program together, training taxi drivers, the police, and LC personnel in pre-hospital trauma care that built off some work that was done elsewhere in Ghana and in several other countries. And I have to say, of all the groups that I've had the privilege of teaching over the last 20 years, the police were the most interested and motivated to learn because I think they were frequently in situations where they just didn't know what to do. And so this is just some pictures from some of our trainings. And we tried to show them, if you're going to put the patient underneath the seat, at least protect their airway and make sure that you have hemorrhage control and a few other things to protect their C-spine. So this is what some of those trainings look like. And again, this is dating back to 2007, 2008. We devised a local first aid kit that was very low cost. A lot of these items were purchased at a We Know market or equivalent, and it was very, very cheap. And one of the things that came out of that is that we had an improvement in the care of the patients that the police were encountering. As part of this, we were able to do a cost effectiveness analysis, and we also coupled it with some trauma registry work, trying to, not trauma registry work, but really trauma mortality work, trying to see what deaths from injury look like. And it was a quarter of all deaths actually back in 2007. And that we did this by looking at mortuary data, police data, and really trying to make these invisible deaths more visible. This is just a shot of the registry in the mortuary. And this led to expansion and sharing of this work, the pre-hospital work across Africa to other countries. And it fed into some of the recommendations from the public health organizations like the Disease Control Priorities. So that pre-hospital work is actually where we met Laura Case's family, Melissa, Laura's sister, her father, David Case, and the other trustees, because they wanted to support work related to medical care in Uganda, and they helped support that pre-hospital work. And then, as Jackie and Treasure and Martha have told you, they have supported the trauma training program that has really been developed, has been owned by the surgery department, and in collaboration with other departments in Malago, and spread across the country regionally. Martha and Treasure and Jackie have already covered this, but many of you in the room have participated in these trainings or supported these trainings or received these trainings. And there's so much more to do to be able to make sure that every provider is well-versed in the basic principles to manage injured patients. And all the expertise is there locally, and this can be taught with relatively few resources and can be replicated and scaled. And these are some of the pictures from our trainings. I specifically wanted to recognize Monica Kabagambe, who's been working with us for almost 20 years, supporting trainees and all of these trainings, and the late Harriet Nambuze, who we lost several years ago. You'll see a plaque of her up in the skills lab where a lot of these trainings take place. So thank you to Harriet, and thank you to Monica also for your service over the years. Please check out the KATC website, which has a lot of the content on there. One of the great things during COVID was the development of locally made videos, which many of you participated in, of local leaders and providers demonstrating skills in the local setting with local materials. And that has been used elsewhere. We've tried to look at how to scale this work up in Uganda and beyond, and some of the bottlenecks and some of the barriers. And some of the facilitating factors, and that's what the future that Treasure laid out is really targeting. Just a few other things. I mentioned the GPAS collaboration, and one of the things that when I started working in Uganda and working with all of you, trying to identify what were the highest priorities, the surgical fraternity and leadership and anesthesia leadership really pointed to workforce expansion as being really the most important factor. And this is a paper from Moses and Sam Luboga and others from back in 2005, just identifying the difficulty in recruitment. And so recruitment into the profession. And so we tried to support that area by supporting young leaders, MEd students, and then those who were finishing their MEd and transitioning into fellowship or into their career. Sorry, these are a little blurry, but you may see some familiar faces perhaps in the room who were part of the initial GPAS Scholar cohort back in 2008. Over a decade, we were able to support a lot of young local leaders and champions in their surgical training and anesthesia training, and the vast majority of whom are practicing in the country and are leading now and for the future. And many of those who were part of this program were also part of the trauma trainings and expansion work that you've been hearing about that has been consistently maintained. It was incredible looking at the agenda for this program. I'm sorry I can't be with you in person. There's so much to celebrate in terms of progress. I know there's lifetimes of work to do. When I think of surgery in Uganda, I think about how much progress and advance there's been in what I would say the surgical diseases of neglect in global health and global surgery, ranging from Burkitt's of lymphoma to the amazing work being done by the children's surgery team, the Kids OR collaboration, which started in Uganda and now has expanded to over 80 countries, building operating rooms for kids. I know Moses led the circumcision campaign for HIV prevention. That was a massive effort. All the efforts around maternal mortality, all the orthopedic efforts around clubfoot, efforts around spina bifida and specialized neurosurgical care through CURE, the camps run by Asou and many of the professional organizations, the growth in anesthesia. I think there are so many stories to tell about advance, although I know we are focusing on the work that still needs to be done. And so for me, it's been just so incredibly enriching to be part of these journeys and to learn from all of this work. And I think the work that the Laura Case Trust specifically has supported through their charity has been trying to support areas of neglect like trauma care. And so I think there's a lot to learn from that because when you take on things that are neglected, you have to make them visible, you have to advocate. So maybe I'll just finish, and Melissa, Laura's sister, and her family couldn't join for this lecture, but they were so honored that this was happening. And they were also have been over the years so honored to be working with Jackie, Martha, Treasure, and many of you in the room who have taken on injury. Many of us and many of you have been affected by injury and by trauma and these other diseases and neglect. And so these are just a few things I think in terms of honoring Laura Case and all of this work. One is just that we are all Laura Case, and that she came to Uganda really because she was focused on service and humanity. And we're all in this because we want to serve others. And that's just probably the most valuable thing I think we can do as humans. The second is partnership and our work together. My work with you has been, the most enriching thing I've done in my career, and I continue to learn from all of you. So thank you. And I hope we can continue to partner. And the other one is supporting each other. Doing this work is really challenging professionally, personally, over long periods of time. There are major hurdles. And one way we can make sure we succeed is by supporting each other when we hit these barriers and these snags professionally and personally to help sustain ourselves. And then sustainable systems that are locally led, where there are local champions. And then I think from us, that are based not in country, to be able to support those and to coordinate our support in a way that's coordinated. And then advocacy, just recognizing when patients and families and conditions are being neglected, making the invisible visible, which is, I think, a large part of what we need to do on the academic side with our scholarship, is really get the data and get the action plans in front of the policymakers, and then championing some of the innovations that have been outlined, not just in this presentation, but also in many of the others in the program. The first transplant happened. Many things have happened in the country which are so exciting and need to be championed. And then we'll need everyone's engagement, not just for trauma care, the foundation that Treasure has laid out, the curriculum for the trauma fellowship. But for all these other diseases and neglect, we need everybody's engagement, and Asou is poised to lead. And again, I'm so honored and grateful that you included this in the program. And I look forward to continuing many more years of work together. Thank you.
Thank you so much, Dr. Duruk. As is our tradition, we don't question our lecturers and we don't question our keynote speakers. It helps us to listen so that we can understand. If you have questions to come after the lecture, then most of the people listen to be able to ask questions at the end. But if you don't expect any questions to be asked at the end, you listen so that you can be able to understand. So alongside this annual scientific conference, we hold what we call the landscape exhibition. It's ideally a snapshot of the healthcare, the surgical healthcare of Uganda. So I'm going to ask us to do a simple exercise for our evening tea. We're going to have it in the tent down. There are people who are actually there to showcase what the Uganda healthcare, surgical healthcare does. So we are going to take off. We should be back here by 5:30 to finish the remaining sessions. But kindly, by 6:30, yes. So that we can be able to finish the remaining sessions. Let's take a stretch kindly, and then we'll come back after. I will ask Mr. President probably to lead our guests so that you can give them a guided tour. Let's please slope down. We have only 30 minutes and we should be back. Good evening, and thank you for coming back. Kindly send a text to your colleague who is still down to come in. We are going to start in 2 minutes with the remaining sessions. We usually keep the best for the last, so tell them not to miss.
Wow. Insurance. Difference with you. Okay. Well, this isn't that. She's my best friend. Okay, and she's like, oh, you're my best friend too.
All right, thank you so much for coming back in time. Those ones seated at the back, we are going to kindly request you to sit in front, so that the ones who will come later can sit at the back, so we don't have so much interruption during the discussion. So for the next session, we are going to be looking at advances in surgery. And it's going to be chaired by Dr. Olivia Chituka. Dr. Chituka, you're most welcome.
Good evening, everybody. I think in the interest of time, we're already running very late. I will be chairing the session on advances in surgery. However, we are privileged to have a guest speaker. And this is Professor Gregory Bellman, who is the Associate Dean in the University of Minnesota. He's the chair of surgical research in the Minnesota Medical School. He is a general surgeon, and he's also got a lot of experience in critical care. He's a full professor of surgery and anesthesiology. So I think the anesthesiologists should also know that they have someone who's got both sides. He puts them to sleep, and he also works on them. He's well published researcher with over 300 publications. He's a member of several professional societies in the US. And most importantly, for those of you who may be aware of certain lists, there's something called a top doctors list. A top doctors list, to me, is like the Forbes list for the wealthy. But top doctors list in different states are those doctors, if you come to Minnesota, those are the doctors you must know. And he has made that list for the last 12, 15 years, yeah. So that's a very big recommendation. He's a reviewer with the NIH, so many of your papers, don't look at him badly. If your grants have not been accepted by the NIH, it's not because of him, but he's a person to know. He'll give you some tips about that. He is also a member of the Clinical Trials Steering Committee of the US Army. Needless to say, he's a retired colonel. So with the US Army, he's had a lot of work in Afghanistan, Iraq, and Ukraine, Kosovo. So we have a very distinguished and widely experienced in various fields who's going to speak to us today. Professor Gregory Bellman, you're welcome.
Dr. Chituka, thank you very much for that humbling introduction. The most important title I have is father. And I'm lucky to be the father of 2 children who have now left my home, yay. So I'm not worried about writing too many checks anymore. You might, and I'm hoping my talk will pop up here shortly, but my first talk for this visit is eat when you can, sleep when you can, and I'm going to talk to you about my journey through chronic pancreatitis, acute pancreatitis, and pancreatic trauma. Are the slides available? While those are coming up, I want to thank Dr. Christine Namugenye and Dr. Moses Galakande for the invitation to come speak this year. And I want to point out how humbling it is to listen to the great work that you all are doing here in Uganda and for the real progress that's being made to take care of the patients of Uganda. I started coming to Uganda as a researcher with the NIH 20 years ago in 2006, 2007, working at the Joint Clinical Research Center at that time, and since that time have formed a relationship with one of the small private hospitals in Kampala, the Gary Holmes Hospital, and I've been privileged over the last 15 years or so to form a close friendship with my good friend Moses Galakande. So Moses, thank you. Folks, are you able to bring up the talk? There we go. So many of you who are surgeons will recognize this phrase. It's something that I learned as an intern, and the phrase went, eat when you can, sleep when you can, and don't mess with the pancreas. Of course, as an intern, I used a very different word than mess. And as I mentioned, I started my career here in Uganda at the Joint Clinical Research Center, and have worked over the last 8 years or so with what was called the Ruth Gaylord, now is called the Gary Holmes Hospital. What I'd like to cover in the next 20 minutes or so is pancreatic trauma, acute pancreatitis, chronic pancreatitis, and a crazy operation called total pancreatectomy with islet auto transplant. These slides are available. If you wish, please email me and I will send you a copy of them. It's beelman@umn.edu. I'm going to go through a lot in this next 15 to 20 minutes. The most important thing in the United States for treatment of pancreatitis is that it's a multidisciplinary disease. Requires surgeons, gastroenterologists, diabetes doctors, pain doctors, ICU doctors, nutritionists, and others to help manage these sometimes very complex patients. And this is my team. It started out as a team of one in 2005 when my chairman said, Greg, I need you to head up our chronic pancreatitis program. And I headed up by doing it myself. And since that time, I've been able to spread the work to a whole variety of people who work with me to take care of patients. Let me talk about one of my patients from about 4 years ago. This gentleman is a 27-year-old male, an intoxicated, belted driver involved in a head-on collision with a large truck, what we call a semi-vehicle. In the emergency room, he was hypotensive, had an open left tib-fib fracture, a right femur fracture, and a right acetabular fracture, and got a CT scan, which showed this, and you can see where that pointer is at is what used to be the head of his pancreas and the duodenum. We took him to the operating room where we opened him up, ligated several bleeders in the head of the pancreas. There was a pancreatic disruption with the intrapancreatic common duct completely blown out, and we ligated the duct above the pancreas, drained him and closed him and ran for home. He went back to the ICU, had an ERCP, and the next day where he got a pancreatic stent placed. The orthopedic surgeon spent the next week or so fixing his multiple orthopedic injuries. He had a percutaneous transhepatic cholangiogram with a drain placed in his common bile duct on day 4. He spent 31 days in the hospital, spent another month in rehab, leaving the hospital. He came back to me about 8 months later where we did a common bile duct repair. And I think this highlights the fact that very seldom do you want to go in and try to remove all the damaged tissue and do a big repair in somebody in an acute setting. This is a very complex slide about how to manage pancreatic trauma. I'm going to summarize this complex slide by saying every patient is different and you treat every patient differently. Shifting gears to severe acute pancreatitis, these are the summaries of the current state of the art in Minnesota at this time in managing patients with severe acute pancreatitis. This includes early aggressive resuscitation with lactated ringers, not normal saline, not using prophylactic antibiotics for patients with severe acute pancreatitis, early enteral nutrition through a nasojejunal feeding tube, close monitoring in patients for development infection by doing both clinical evaluation and CT scans. If you have a patient with sterile necrosis, delay surgery as much as possible. When you do surgery on these patients, you should follow an organ preserving approach. And at the University of Minnesota, that includes endoscopic therapy if you can drain into the stomach or the duodenum, video-assisted retroperitoneal dissection, which sounds fancy and is not fancy. Even I can do it. I learned to do it by watching a video online. I shouldn't admit that, but I did. And then open surgery for patients who fail this. This is the common boards question in the United States. What do you do with the gallbladder in somebody with gallstone pancreatitis and this horrible bomb that's gone off in their abdomen? You remove the gallbladder when the patient is stable and the inflammation has died down, and you're not carving through a whole bunch of acute inflammation. This revolutionized the management of severe acute pancreatitis or infected pancreatic necrosis. When I trained in the late 80s, early 90s, I was told never to operate on somebody with pancreatitis. They would all die. But this guy, Ed Bradley, described his experience with 28 consecutive patients with infected pancreatic necrosis that he managed by unroofing the superior peritoneum and then doing a blunt pancreatic sequestrectomy with multiple reoperations until the dead pancreas and the infected tissue was removed. Many places continue to manage their patients with severe acute pancreatitis with infection in this way, and it's a perfectly safe way to manage our patients. It dropped the mortality from 95% in patients with infected pancreatic necrosis to 11% in Dr. Bradley's early series. This is one of my patients early in my career. This is a patient at the VA hospital in Minneapolis. I was told by the internal medicine doctors, don't touch this guy, you'll kill him with surgery. After literally arguing with them for 4 days, they were finally willing to let me operate on him. This is his CT scan from the mid-90s. I took him to the operating room, and this is his dead pancreas. Literally, I opened up the lesser sac, put my hand in there, did this, and pulled out that. With, by the way, the GI doctor's endoscopic stent, which wasn't doing a lot for this dead pancreas. We managed these patients at the time by a mesh so we could go back in and out without destroying the fascia. And this was my attempt at open suction, if you will, with a chest tube placed through the wound, placed on chest tube suction at the bedside for these patients. And I would take them back and forth to the operating room every couple of days until the dead stuff stopped coming out and the patient started to develop granulation tissue in the wound. We've advanced significantly in management of these patients, and this is one of the first studies looking at minimally invasive approaches to infected pancreatic necrosis by the Dutch Pancreatitis Study Group. These folks are amazing. They are able to do so much work with not a lot of resources and carefully study patients in a thoughtful way. If you're thinking about how to set that up in Uganda, I think they would be a good model to follow to do clinical studies that are relevant. They've led the field in severe acute pancreatitis and chronic pancreatitis without billions of dollars of NIH funding. But in this study where they used a step-up approach, which included a percutaneous drain and then minimally invasive retroperitoneal necrosectomy for patients that did not respond to percutaneous drainage, in 88 patients enrolled using the composite endpoint of major complications or death. You can see here that the step-up procedure was associated with decrease in that composite endpoint, equivalent mortality, and a much lower hernia rate in patients treated this way. The next question is, can you do this endoscopically? And again, they randomized patients in a multi-center trial of endoscopic drainage versus step-up approach, and basically they were equivalent. And honestly, in our institution nowadays, it's endoscopic drainage if it's anatomically feasible, video-assisted retroperitoneal dissection or a step-up approach if that's not. And then what we struggle with is who fails this and who needs to be managed in an open fashion using the technique that I showed you that Dr. Bradley described in the mid-90s. Shifting gears again to chronic pancreatitis, this is an uncommon disease in the United States, affecting only about 1 to 20 patients per 100,000 population. But it's a big deal for the patients that have it, creating 56,000 hospitalizations per year. The most common cause classically is alcohol or gallstones. The most common cause that I see in 40% of my patients is familial pancreatitis. This is something that we knew nothing about when I started my practice in the mid-90s and now makes up, as I said, about 40% of my practice. Other causes include pancreas divisum, drugs, and idiopathic. There are 2 contributing factors that cause pain in these patients, include ductal hypertension. This is the classic appearance that all of you and I have seen over and over again, an alcoholic that's 45 years old with a large dilated pancreatic duct full of dominant calcium within their duct. And then those patients who have small duct pancreatitis, like many of my patients with familial pancreatitis, who have an inflammatory damage to the sensory nerves of the pancreas that's causing pain. For those patients with those patients with ductal hypertension, the 45-year-old alcoholic, for instance, those patients respond very nicely to drainage, the classic Pusteaux procedure or Fry procedure or Bager procedure. those patients who have the inflammatory damage and small duct pancreatitis, they don't respond very well to those classic interventions. The approach to chronic pancreatitis is stopping drinking, stopping smoking. Sounds simple, but still half of my patients show up in my clinic and they're still smoking 2 packs a day, or they're still, when I talk to their husband or their wife, they're still drinking a pint of alcohol a day. Putting them on pancreatic enzymes, antioxidants, doing ERCP and stenting in some patients, and then narcotics is the mainstay of therapy for patients who have failed all of those approaches. The pancreas will typically burn out over about two decades. In the United States in particular, those patients have been addicted to narcotics for that 2 decades, and many patients will die of narcotic overdose with their chronic pancreatitis in the United States. And they will die with endocrine and exocrine dysfunction of the pancreas. The goals of therapy for these patients, number 1, is to treat the pain from chronic pancreatitis so we decrease the complications of long-term narcotics and reduce the death of long-term narcotics, and potentially preserve some pancreatic function, reducing the long-term complications, in particular of diabetes mellitus. Endoscopic therapy works well in about 2/3 of patients long-term, and you can see this meta-analysis, again, published by the Dutch Pancreatitis Working Group, where they saw long-term pain relief in about 2/3 of patients with a complication rate of 8%. The drainage procedures continue to work effectively. Those include the Pusteau, the Fry, and the Bager procedures. All of these procedures, as I talked about, require a dilated pancreatic duct unless you're the one surgeon in Germany who can do the V-plasty, if you will, of the pancreas. Nobody else has been able to duplicate his outstanding results. Resectional procedures are reserved for those patients who have major disease that involve predominantly the head or the tail of the pancreas, or in those patients who have a strictured duodenum, common bile duct, and pancreatitis. You can consider doing a distal pancreatectomy in patients who have a disconnected duct or disease involving the tail. And when you look at the trials of surgery type, and again, this is from Dr. Hartman from, you got it, the Dutch Pancreatitis Working Group, 9 studies that he put together from 95 through 2013. The Fry is better than the Bager, with as good an outcome and reduced perioperative complications. The Bager is better than the Whipple, again, because of decreased perioperative complication rates, and the Fry is better than the Whipple. So about 7 or 8 years ago, most of my patients who come in with the classic chronic pancreatitis, large duct, lots of stones, one of these beautiful anatomies, I'm doing Fry procedures on those patients. The other important thing is not let these patients suffer too long. And international consensus guidelines for surgery and the timing of pancreatitis suggest that surgery early in the disease process is favored over surgery in a more advanced state of disease in order to achieve optimal long-term pain relief. If patients are on narcotics for more than about 18 months to 3 years, it's very difficult to get those people off of their narcotics. This complex diagram here that I put together gives you my idea of the approach to how to make surgical decision-making in these patients with chronic pancreatitis or recurrent acute pancreatitis who have failed medical and endoscopic management. I'm going to talk momentarily about what we do at the University of Minnesota, understanding that we are able to do this in a setting that allows us to spend $50,000 to isolate islets from a pancreas. That's not available to everybody across the world, and I realize that. We reserve this for patients who have small duct disease or familial pancreatitis with risk of cancer, or those patients who have recurrent acute pancreatitis, or those patients who have disease that involves the entire gland. This was first described by my colleague and former partner David Sutherland, who back in 1974 was working in the lab of John Najarian. David was passionate about finding a cure for diabetes mellitus, and was interested in doing islet transplant in patients to treat patients who had diabetes mellitus. David ran into the problem that every time he did an islet transplant in a patient, the islets would die, and he didn't know if it was because he was putting the islets in the liver, in the portal vein, if it was immunosuppression from the islets, or maybe there was some other factor. And you could get away with this in the United States. In 1974, he designed a study where he looked at one patient with chronic pancreatitis, isolated her islets during a total pancreatectomy. It was very effective at curing her long-term pain, and she died 28 years later with islet function, off of narcotics, died of cardiac disease rather than either diabetes or chronic pancreatitis. And he figured out that it wasn't the portal vein, it was the immunosuppression that was causing the failure of the islets in his patients that he was doing allo transplantation in. What's funny about this is islet autotransplantation is now used not commonly but routinely in patients that I described, small duct pancreatitis with no medical response to therapy. Allotransplantation, giving somebody else's islets to another patient, still is experimental and not approved by the FDA. Autologous islet transplantation is the patient's own islets. There is no risk of rejection, and the patients do not require long-term immunosuppression. And when we're doing this work, we standardize islets based on the islet mass, based on the size of a medium islet. The magic sauce in this procedure is not the surgeon. I could train any surgeon to do a total pancreatectomy and islet autotransplant. It's the islet lab, and we have an islet lab that does 300 or so islet isolations per year. They do it day after day after day. They get very good at it, and that's the secret sauce of our program at the University of Minnesota. Does it work? 20 years ago, I would stand up and give talks about total pancreatectomy and islet autotransplant, and I would get horrible comments about how I was damaging my patients and abusing my patients. But indeed, we've done more than 900 of these operations, more than 700 since I took over the program in 2007, with 0 perioperative deaths, with, you can see here, significantly decreased pain scores, significantly decreased opioid use post-op, with many survivors, like several of mine, being more than 20 years out off of insulin and off of narcotics. So in appropriate patients who have failed other medical therapy in small numbers, we're talking, maybe 2,000 in the world have had this operation ever, it makes sense to consider doing that. Otherwise, acute and chronic pancreatitis is a multidisciplinary disease, with acute pancreatitis being best treated with lactated ringers resuscitation, with complications being managed with endoscopic, percutaneous, and video-assisted retroperitoneal dissection. And chronic pancreatitis should be operated on only for life-affecting pain, with the operation tailored to the anatomy and the patient. I've appreciated, again, the chance, Moses, to come to one of my favorite places in the world, Uganda, and thank you all for the opportunity to speak today.
I think for me the penny has just dropped as to why I was asked to chair this session. And I'm glad I waited and been able to listen to pancreatitis as an HPB surgeon. It's really, thank you for demystifying pancreatitis with such military precision. I think we'll go into the next presenters. And at this moment, I would like to welcome again Dr. Francis Basimbe. I don't know if he's around, yes? Who is going to be talking about percutaneous endoscopic gastrostomy by the pull method, and looking at the short-term outcomes at St. Francis Hospital in Zambia. I hope you're ready. Yeah, Dr. Francis Basimbe is a surgeon, the head of Department of Surgery at St. Francis Hospital in Zambia with Uganda Matters University. And he's specializing a lot in endoscopic techniques and minimally invasive surgery. Welcome, Dr. Basimbe.
Thank you very much, Dr. Olivia, my teacher. I have a very big privilege to be here twice in one day, and I don't take that lightly. Thank you, Kakunguru. I don't know how this happened. And I'm going to go straight into our presentation. Like it has been mentioned, my interest is endoscopy, surgical endoscopy, endoscopic surgery, and minimally invasive surgery. And I'm going to present some of the things that we've been doing, and the reason for me presenting this is to sort of create awareness about some of these things that we are doing, because many of these we are getting them in my facility as referrals from other places and doctors, and I feel this is something that can benefit a bit more patients than what we are seeing. PEG, percutaneous endoscopic gastrostomy, has been around since 1980. And I think the inventor, Ponsky, I don't know whether he's still alive at the moment, but I think he is. And he discovered this accidental. I happen to have listened to one of his talks, and he discovered this accidental, I think, as they were trying to radiate, because the abdomens in children are quite a bit easy to transilluminate. And that's how the idea came to him that, oh, can't we place a tube that can help feed these children endoscopically? And so ever since then, it has been very popular. There are over, I think, 300,000 PEGs done in the US. When you come to Africa, it's still a bit rare. I know I think in South Africa, it's far more common, especially in children, but in our setting, it's something that we are yet to take up generally. So gastrostomy feeding is indicated for feeding both in children and adults, especially if you anticipate that someone will need prolonged enteral feeding for more than 2 weeks. They need that support for more than 2 weeks. So what that means is that many of our patients in our setting that you see with NG tubes for a month, probably many of those patients need to be evaluated for PEG tubes. So PEG feeding, like I've said, should be considered in case you you find that you need to support this feeding for more than 2 weeks. And the case for this should be made looking at several things. One is the clinical situation, whether it really warrants to have a tube. Look at the diagnosis. Most of the indications, as you will see later on as I present the results of our retrospective review, you will see most of the ones that we are doing in our setting are mainly children that have cerebral palsy. Look at the ethical issues, and here I want to highlight issues of end of life care. And this is one of the areas that has been a bit controversial. Or the patient is very ill, is dying, why are you taking them, and starting to insert tubes and things like that. So that is a bit, there's a bit of discussion there as well. But also look clearly at the effects of quality of life, and this is where most of the patients that we have done that are adults come in, especially for their indication, and we have seen very significant improvements. But also the other thing is I've had many patients with oral maxillofacial tumors that have been resected, some of them that can actually speak and can't initiate swallowing, and actually they wish, they actually ask to have an alternative, and in these patients, that is what we have opted to do for them. Now, the superiority of PEGs has been demonstrated in many studies, and it has been shown to be very superior to surgical gastrostomy, the stems, the genuine. And the reason for this is mainly because a well-perfected PEG procedure can be done in under 5 minutes under local anesthesia, so you don't need to put your patient to sleep. And in fact, many of these are usually very critically ill, so you can comfortably do it endoscopically with just minimal sedation. And many of them, even at intubation, for those that can speak, they cooperate quite well. So our aim was to review the indications, complications, and 30-day mortality in children and adults who underwent PEGs in our facility And so what we did, we conducted a retrospective cross-sectional study where we looked at patients who underwent PEG in our setting over the last 6 years. And so we reviewed the charts, looked at our endoscopy records, and retrieved data on many aspects: demographics, indications for the PEG, associated comorbidities, and any complications, including 30-day mortality that we had noticed. And so a little bit more about the procedure. So the technique we use in Zambia is called the pull method. And it is where you insert an endoscope, like how we normally do an endoscopy, go up to the stomach, and then you transilluminate the anterior abdominal wall. And then you look for a one-to-one sign where you can actually dent the abdomen with the scope facing up at the anterior abdominal wall, and you can actually transmit it and see it on screen, that actually this is the point. Of course, over time, you have to be careful because there are many other viscera within that area. The liver is one of them, especially in children. The left lobe can be very big, and it can cause a bit of challenges. And so one of the fundamentals is to make sure that you have good insufflation, so you're fully distended that stomach such that that procedure pushes away all the other viscera. And then all you have is skin, the anterior abdominal wall, and then your stomach right there. Of course, as a percutaneous procedure, we know that there are challenges with that and the risks can be there, but that's why I'm presenting this and showing you what we have done and also the outcomes. So that is in summary what I'm looking at, what I'm talking about. You pass the scope, you look there, and then you're able to actually indent and see. And if it's a small-bodied person, you can transilluminate. In children, you definitely can transilluminate and see your light, especially what we do in my practice is we switch off the lights in the endoscopy room so you can actually clearly see what you're doing. So then a guide wire is passed through a puncture, and that's where we use the local anesthesia. First, they spray through the mouth as we are passing the scope, but then also at the puncture site on the abdomen. And as we do that, we are able to pass a 14-gauge needle and through the puncture site and down through. So then when we pass the needle, we pass a guide wire that we can then hook with our snare, and then we get it through the mouth. And when we get it through the mouth, we connect our PEG tube that we then pull retrospectively back into the stomach, and then we make a very small slit where we put our local anesthesia initially, and then we deliver the tube, and then the rest is just to fashion it, and then the procedure is done. So just wanted to take us through that. In my setting, what we do for the first 6 weeks, with good traction, we are able to replace that, especially when they need this tube for longer than 6 weeks. We actually replace it with a baton peg, which is more cosmetic. So for patients who are ambulant, and even for mothers to aid with care, they actually opt to have it changed to a baton peg. This is how the baton peg looks like. It's not a long tube like the normal gastrostomies. And that one, the advantage is the connecting tubes are usually kept separately and are only connected during feeding. So after feeding, they disconnect everything and they can even move around comfortably and do other things with it still there. So a total of 94 PEG tubes were placed within the study period, and the majority of them were males, and the average age of patients was 5.2 years. So we are doing more pediatrics than adults. So in pediatric group, that was our range. We've placed PEGs from 3 months to 12 years, and the average age in adults has been 52, so we have even placed them in 94-year-olds. The other controversy in the very elderly has been dementia, and that has also been a point of discussion on the relevance of a PEG in advanced dementia. And so there are a lot of challenges there as well on what to agree on whether they are really relevant. So the common indication in children we noticed was recurrent aspiration pneumonitis in 62% of the children we saw. And this was followed by failure to thrive. Recurrent aspiration pneumonia, especially in those children with cerebral palsy, because most of them are unable to control those secretions, so they keep coming in. So in my hospital, we work very closely with a pediatric neurologist, and so most of the patients come from the pediatric neurologist because he sees them in his clinic and actually advises them to come and have these tubes done. So, and the underlying condition in these has mainly been the neurological disorder, like I've mentioned before. While in adults, the commonest indication has still been aspiration pneumonitis, but we found the commonest indication being cerebrovascular accidents, patients who have had stroke, and then, of course, that has been followed by dementia in our setting. So the major complications we're seeing over the years in 5 patients, all have been adults, and minor complications we're seeing in about 24 patients. And here, the commonest minor complications is usually infections around the site of the tube. So we've developed a protocol based on the international guidelines for PEG tube placement that has mitigated on that. So we have standardized, and that one we have seen it reduce. 30-day modality over the years has been about 2%, and in this, and that is, we've had 2 patients that have developed one of the complication is called the Barrett bumper syndrome, where the peg migrates into the abdominal wall. Sometimes if that happens when the attendants are not aware and are giving home care, you end up having content spilling into the anterior abdominal wall and sometimes tracking. And because they are very sick people, it's sometimes very difficult to overcome that sepsis, and that's one of the worst scenarios we have seen.
2 minutes.
However, in conclusion, PEG tube placement by pull method can be performed safely in our setting, and for the purposes of this presentation, I would like to encourage many of us who have patients, especially stroke patients. In our hospital, we've seen many of these stroke patients are discharged with NG tubes, only to come back 2 weeks later with aspiration, and then they die, and yet these are some of the things that could have been prevented. Thank you very much.
Thank you, Dr. Basimbe, for keeping time. We'll go on to our next presenter. Our next presentation is going to be by Dr. Andrew Marvin Kanyike, and he's going to be talking about prevalence, clinical, and endoscopic characteristics of hiatus hernia. So we're in the endoscopy world for now, and looking at those among dyspeptic patients in a tertiary hospital in Uganda. He's doing this is a retrospective cross-sectional study. He's worked with Dr. Bright Anderson Mwanje, and Dr. Kanyike, you're welcome.
Thank you, moderator. Good evening, everyone. It's an honor to be here. It has been an action-packed day, full of knowledge, and I'm happy to be here. Yeah, I'm going to be presenting about, no, it's not this. It's the one about hiatus hernia. So the whole day we have been talking about big data and utilizing all this data that we have in our hospitals, looking at surgery registries to see the conditions that we commonly see. And what we are doing at Mengo Hospital, where I work as a medical officer and research associate, is to look at this big data that we have had over the years at the hospital and make scientific sense out of them. And one of these retrospective studies looking at hiatus hernia. So I'm going to take us through a 6-year retrospective study at Mengo Hospital. I hope I know how to use this technology. Okay, hiatus hernia is a protrusion of abdominal viscera into the thoracic cavity, and it has dated back in the years. It can be classified into 4 types, from grade 1 to grade 4, depending on what is herniating through the diaphragmatic the phrenoesophageal membrane. So we see that prevalence of hiatus hernia varies largely globally from 1% to 70%, but we have very limited studies in low and middle income countries. One study that was done in Nigeria showed a prevalence of about 2 to 28% of people with hiatus hernia. Sorry. think I need some help here. Okay. So patients with ADAVNCIng mostly present with symptomatic reflux disorders, postprandial discomfort, dysphagia, aspiration, and hematemesis. And it has been majorly correlated with increasing age in elderly, obesity, and congenital intestinal abnormalities. Irrespective of the fact that ADAVNCIng is a common disorder, which is actually often treated for a long time with refractive symptoms on PPIs and painkillers, we have very limited research in low and middle income countries, and almost we found no study that has been done on this in Uganda. So, sorry, where do I point this? Can I get some help with this? Okay, yeah. So we set out to determine the prevalence, the clinic and endoscopic characteristics of patients with hiatus hernia who were undergoing upper GI endoscopy, and also look at what are the predictors of this. I don't know what's wrong with this. Okay, thank you. So this was a retrospective cross-sectional study, 5 years from 2018 to 2022 at Mengo Hospital, which is a private not-for-profit hospital with a dedicated endoscopic unit where we averagely do 6 endoscopies in a month and about 500 annually. And all these endoscopies, where biopsies are taken, histologies are done within the Mengo Hospital lab. We included those patients that we are presenting with dyspeptic symptoms, and we are undergoing upper GI, and basically excluded only those with missing information. We included all records there is, and these records were extracted both from the electronic database, that is the clinic masters, and the paper-based endoscopy and histology reports using a designed Kobo toolbox form. We obtained patient demographics, their clinical presentations, endoscopic findings, and basically looked at the prevalence of hiatus hernia, clinical presentations, endoscopic findings, and factors that were associated with it. I don't know why the thing keeps jamming. Okay, in our results, we analyzed 2,111 patient records, and the patients had a mean age of 49 years. Most of them were above 60 years, and the majority were females, at least with a tertiary education level. We found a very high prevalence of hiatus hernia, 58.9%, and also the majority of these were in grade 4, which is really an advanced stage. I don't know if that's clear, but this is looking at the clinical presentation. For patients who had hiatus hernia, most of them presented with globus pharyngeus, which is like a feeling of a lump in the neck, regurgitation, chest pain or retrosternal chest pain, epigastric pain, belching, and nausea and vomiting. And these two side-by-side graphs are trying to look at the endoscopic findings, both at the esophagus and at the stomach. At the esophageal level, we see that most of these patients also had esophageal webs. They were found with strictures, GERD, which is gastroesophageal reflux disease, esophageal tumors, esophageal candidiasis, and ulceration. And at the side of the gastrium, most of them had chronic gastritis, atrophic gastritis, and gastric ulcers as well. when we did a modified positional regression analysis, this is what we found. Individuals under 45 years of age were significantly more likely to have hiatus hernia compared to those over 60, which is a bit surprising and different from what is within the literature. And also, females were marginally less likely to have hiatus hernia than the males, as you can see there. So we see that hiatus hernia is really highly prevalent, though I can say a neglected disease among patients with dyspepsia that are undergoing endoscopy. And this prevalence is higher than we saw that was reported in Nigeria and in the Western population. And surprisingly, this is being found in people who are below 45 years of age. So we have to consider the unique things that we may have that are causing our young people to have hiatus hernia instead. Things like lifestyle, genetics, maybe occupational exposure, and health-seeking behaviors. But in consonance with other studies, we found that actually, males are always at a higher risk of hiatus hernia, and we can attribute this to so many things, but mostly with the kind of occupational and struggles that men go through, heavy lifting and all that. So in conclusion, we see that hiatus hernia is really a highly prevalent disease, and all clinicians should have a very high suspicion index for patients that are presenting with dysphagia, dyspeptic symptoms that they have been treating for long without response, to be able to initiate early diagnostic intervention so that this hiatus hernia is caught on early before it advances to the great stages. Thank you so much.
Thank you, Dr. Kanyike, for managing the challenges of technology and going through the presentation. Thank you very much. Our next presenter is going to be online, and he's called Dr. Nicholas Mwesigwa. He's currently working in the UK, going through his thoracic training program, but he's trained from Makerere, but he went on to work to do his master's in surgery at University of Buckingham. And he's going to be presenting something not from the thoracic region, but now we are going to the other end of the GIT. He's going to be looking at the review of the success and recurrence rate of hemorrhoids following rubber band ligation in Blackpool and the Clyde Coast area of England, where he works. I don't know if Dr. Nicholas is online. Dr. Nicholas, you're welcome. And can you hear us? We can't hear you. We can see you, but we can't hear you.
Yes, I think I've unmuted myself. Can you hear me now?
Yes, we can. You can begin. You're
Thank
welcome.
You. Thank you, Dr. Olivia, my teacher. Thank you for having me. Thank you for the organizers of this conference. I do appreciate the opportunity to present at the conference subject back home. And it's very, I find it very critical that we, the diaspora, get involved with our colleagues back home and speak with them regarding what's happening here as well. So I'll share my screen, and I'll be quick in my presentation. I hope we can all see the presentation. Okay, so as Evelyn introduced by Dr. Olivia, I'm presenting a review of rubber band ligation. And many ask why I chose this topic. It's a topic I did during my surgery in Blackpool at our facility. And well, basically, we looked at our practice in management of hemorrhoids. Rubber band ligation has been heavily investigated in the Western region and in the Asians and in the Americas, and it's a common form of practice. I kept asking myself why I'm not too familiar with it, even if I had done a good surgical rotation, both in internship and in medical school. And I found it It was a very simple technique, however, I had no recollection of it to my knowledge. So I went back in the literature and I tried to find out what we do back home, and there was not much literature going on, and I noticed that it was dependent on the practitioner in the area we're in and the facility you're in, whether public or private, and it was not clearly defined how we're managing simple things like alleviate hemorrhoids. And going back to the theme of our conference, which is delivering safe, affordable, and effective surgical care to everyone and the global surgical perspective, I found it important just talk about this and not the topic per se, but the concept of doing things and going back to the basics and doing things easily so you can provide this service to everyone. Treat. It will be a quick presentation. So I'll begin with a quote from one of our known surgeons who clearly states that it's not just about your technical ability as a surgeon, but also on how appropriate on what you're doing. And that's Ben Casson, well known for his neurosurgical techniques. We all know what hemorrhoids are, most of us do, and the different classifications, which is mainly enlargement of anal cushions in the hemorrhoidal plexus and the rectum. And we can either have external or internal hemorrhoids, depending on which level of the dentate line they come out from. And across the world, the current prevalence is 4.4%. However, I'm not sure if this is correct because we don't have much African data to classify or to characterize the prevalence of hemorrhoids in our setting right now. Before, as I was preparing this presentation, I made a few phone calls back to my colleagues who are doing postgraduate. Kindly, Dr. Orumusi was able to give me some information. And he's one of the current postgraduates is actually currently doing a study on prevalence. Hopefully, we'll have that and we'll have some information. And I also understand there is a bit of a pitfall because most of the people who present or tertiary centers present with late grade or grade 4 and grade 3 or grade 4 hemorrhoids. So is it really capturing the current prevalence? We're not sure. We'll wait and see what happens. So I couldn't find much data regarding prevalence or published data to be what can work back home and what we can do back home. I found two trials or two investigations done in Mulago in the late 90s and early 2000s, which were done by our kind colleagues, our senior colleagues. And these were just comparing the types of hemorrhoid management procedures out there with each other and the efficacy. So the first trial, which basically compared open to structural hemorrhoidectomy, showed no difference in outcomes. And then the second trial conducted by Dr. Iga and his colleagues also compared Ferguson technique with the staple hemorrhoidectomy, which showed no difference in outcome complication rates. And like one of our previous speakers stated in the beginning of this conference that we have lots of short-term outcomes, but does that really translate to what we should be focused on our practice, given our population need, the affordability of care? What should we focus on in terms of delivering safe and affordable care to our population? So a quick background with management of hemorrhoids depends on the grade, and we can come from conservative management to sclerotherapy, banding, laser, hemorrhoidopexy, OPED, you name it. There are all sorts of things out there right now coming up. And depending on where you are in the setting you're in Uganda, you've done different things. I know colleagues in private are doing more of laser, from here say laser and hemorrhoidopexy, and few are doing bandings, but I didn't have much data or not much information regarding that. Currently, we have little data regarding hemorrhoids, and this is an area which I think which is easy to identify, which I think would require private collaboration, because I think some of the patients present early with earlier grades present to the private facilities. Most of our population wait until they are collapsing, and we cannot take them back before they present to the tertiary centers. So I think there is need for education and advocacy to find out the prevalence of this condition right now. And this is tapping into the global surgical perspective of our talk this morning. In the Uganda clinical guidelines, which I know it's mostly referral for maybe the clinical officers, but it still leaves it open that what's the current management method for hemorrhoids are conservative, and if conservative fails, refer to the hospital for surgery. And it still leaves it open to what is done, and that depends on the practitioner going forward. So we need more data, and we need to reassess and kind of tailor what we do our population. And that brings me to my topic right now. Currently, when I was in Blackpool doing general surgery, before I moved to thoracic, we were not doing stapodimodopexy. When I was back in Uganda privately, it's what we were doing, and I had seen it for the first time in private. I did see it during my training. Maybe now it's being trained upon. I asked my consultants why we don't do much of it. They said from their data, there was lots of anal stenosis and lots of complication. You couldn't know when you picked up the internal sphincter, and so the NHS really stopped funding the stapodimodopexy. And they went to their local data to maintain the mainstay of management is first to third grade, including third grade, is probably ligation. And if you have prolapse in hemorrhoids, they're going to do the transanal hemorrhoid arterial dearterization. And so it's mainly the two, RBL and PhD. And being in the RBL clinic, I tried to assess the efficacy of this RBL in our local setting. And I looked at their data to see how effective has band ligation been. Outpatient procedure, patient comes in the morning, you cancel them, you consent them, you put a band using an endoscopic ligator transanally, and you send them home. And it looked to me like in an ultrasound that we could apply locally if we have the need. Because like I said, I don't know the prevalence right now. Maybe it's not an actual need, and it's something that I thought we could discuss and the different surgical teams should look into going forward. So it's been investigated generally all over the world, and the success rates for band ligation range is between 68 to 92%, depending on the grade, depending on the technique. That's the average range, with recurrence coming between 20 to 6% of recurrence of hemorrhoids after 1 year. And our study, we included third-degree hemorrhoids because we wanted to know the third degree, the prolapse hemorrhoids, are we effective in that as well? Can it be applied to that? And is it comparable to literature that's out there right now? And a quick background of RBL, it's how we did it. We did the office procedure, and we had only one admission due to postoperative pain, and out of the 94 patients that we studied. And this is a quick schematic to show how the procedure is done. It's you identify the hemorrhoid, you grasp it, and use a simple endoscopic instrument that has the bands attached to it. And with the gun-like fashion, you simply apply the band to it. And patients are usually let home that same day with no other issues. Some patients with multiple hemorrhoids would plan for further rebanding because the protocol is only do a maximum of 3 bandings per session. So some patients require further rebanding in this procedure. So we did a retrospective analysis at Blackpool. This was over a 2-year period, and we looked at 94 patients between a 2-year period that underwent rubber band ligation. And we looked at the extensive electronic data, the follow-up of the specialists, those who came back with pain, or those who came back with the recurrence of symptoms. The main presenting symptom being PR bleeding for the majority, 80%, and painless, to be clear, painless PR bleeding, which has been investigated to be only by hemorrhoids and no other proximal colon pathology. And some had pain and also mucosal protrusion. Those are the main indications for doing this. We looked at the data and the review. Each patient had a review at 3 months. After the procedure, you have a 4-week appointment. We looked at the review at 3 months, 6 months, and followed up with a telephone appointment at 1 year. So patients done over 2 years, followed up for a 1-year follow-up after that, and looked at how many of these recurred with these swellings or the symptoms of PR bleeding. So around 55% were grade 1 and 14% were grade 3 hemorrhoids. And we noted that at recurrence, which with 6 months recurrence was only 8.2%. However, when we say that maybe we're giving ourselves a bit of a short term and it could be more after that, and indeed it was more after that. At 12 months, we found that 11% of the 94 patients had recurrence of this. And in our small setting or small clinic of 94 patients, this data tied in with international data, whereby there is almost the ranges of recurrence between 20 to 6%, depending on the grades and depending on how we're doing it right now. The main thing of advantages about band ligation was the elimination of dire complications, mainly anal stenosis and loss of sphincter control, and which would lead to incontinence. So for that reason, it's still recommended in the NHS at least as a first-line management for up to grade 3 hemorrhoids. And like I said, one patient had we had only 1 readmission, for post-operative pain control, and 3 planned rebanding sessions. So we didn't consider the planned rebanding as recurrent because these were planned to come back for further banding. And in conclusion, I know we're running late on the talk. It's still, even in the West, even in the developed world, RBL remains the most economical and first-line management. Saves hospitalization and operative room time. And it has the main thing I noticed about it, having things for the first time, possibly is the quick learning curve. The way our colleagues have talked about, you see one, you do one, and this is literally, you see one, you do one, you see one, you do one, so, and you have the same outcomes. So I feel like if there is a need, if our local data shows there's actual prevalence, it's something we need to advocate for in our training, in our earlier training, we can put in practice with our young surgeons. And it's a recommendation to adopt RBL in the general surgical setting. And conclusion, I'll conclude with the quote that we can only stay on top if we remember to go back to the basics. And if we understand the pathology and what leads to hemorrhoids and the mechanism of pathology, I think we'll make step to management and to give affordable, safe care to our patients in Uganda. Thank you.
Thank you very much, Dr. Nicholas. We are supposed to have a session with Dr. Lekuya, but I think he's not able to join us. He's supposed to be joining us online. I would like to, first of all, put your hands together and thank all the presenters for their wonderful presentations. Most importantly, for keeping time, and also clap for yourselves for staying here up to this time. For many of you, it's past your bedtime, but it's okay. So we will not be taking discussions now. We'll have the remaining presentations being done. The next session, which is about harmonizing multidisciplinary teamwork. And I think this is chaired by Dr. Lydia. I don't know if she's here. So she's going to be presented by Dr. Banjo. Mnyaga Banjo. Bianjo, Dr. Bianjo, sorry. My apologies. Dr. Bianjo will take us through the next session, and then we'll field questions after all the presenters have done this. I know this is a marathon, but we hope we'll be able to have all those who have prepared able to present. Thank you.
Good evening, ladies and gentlemen. It's a pleasure to be in front of you. Without wasting a lot of time, we are going to be discussing how to work in teams, basically, a multidisciplinary approach to manage in surgical care. And allow me to introduce our first presenter for the day, Mr. Alan Mutibwa. I've worked with this gentleman in Nakaseke, so he has experience in the village setting, as do I. He's a physiotherapist with a Bachelor of Science in Physiotherapy, and also works with Healers Physical Therapy with significant experience in scar rehabilitation. Thank you very much. You're welcome.
Thank you so much. Good evening, everyone. My name is Alan Mutibwa. I'm a physiotherapist. I work in Nakaseke Hospital. I also run a private practice in Mengo called Healers Physical Therapy. and I'm so glad to take you through my presentation. How do I start with this? Is it on? So I'm waiting for my PowerPoint. I think it's... Okay. Thank you so much. This is my presentation. I'm presenting about scar rehabilitation following surgery. So this is a surgical conference, and I'm talking about all the kinds of surgical procedures that are done, whether it's ankle surgery, knee replacement, hip replacement, cesarean section, an abdominal scar, hernia, could be shoulder surgery, breast surgery, basically any kind of surgery. So I'm talking about how we do the rehabilitation in physiotherapy after the patients have seen you. So, surgical procedures are very important because they help save our patients' lives and prevent disability. But however much they are good, they come with some cost to the patient. It could be on a physical or mental and emotional level. And that's where physical therapy comes in. Let me move. Okay, so let me talk about the effects of surgical procedures to a patient. So number one, there is scar formation. Like you can see the image there. We have scar formation. We have pain and itching, mainly on the scar itself. We have swelling, or edema can form. We have temporary loss of function to the patient. We have nerve injury and general injury to the body. And then we have the emotional, basically the mental and the psycho-emotional effects to the patient. Okay, and then next I want to talk about the goals of scar rehabilitation. What do we want to achieve with physiotherapy? We want to improve nerve, lymphatic, muscle, and joint function. Basically, with the surgical procedures, when they are done, there's always a deep cut done deep into the tissues. And this interferes with both the nerves, because nerves are under the skin and deep into the tissues. We have the lymphatics are also under the tissues. Then the muscles which are cut through And of course, if muscles can't move, even joint function will be affected in this case. So we want to improve both nerve, lymphatic, muscle, and joint functions. If you look at the image there, it shows artery, then the nerve, and then the veins. So the blood vessels, the lymphatics, and the nerves hang out together. They move together. They're all interconnected in the area they are traversing through. So with surgery, if it is done, it's affecting all these structures in this area. And that's why we have to do proper rehabilitation of both nerve function and the lymphatics, plus also blood saturation. So another goal for scar rehab, we need to want to enhance the aesthetic skin presentation, improve the color, texture, and visibility of the skin. Because people don't like how their scars look like. So we want to improve the appearance of the skin with the scar rehabilitation. That's another goal. And then we want to improve the overall quality of life of our patient. Am I going backwards? I don't know. No. This is, yes? The second one, eh? Okay. Then I want to talk about the strategies we use in scar rehabilitation. We do scar rehab after the scar has healed. We don't do scar rehab when the scar is still fresh. So wait until it has healed, then we can start the process of rehabilitating it. So first of all, what we do manual therapy. Manual therapy to work on the local nerves, like I talked about, the nerves, and also improving the saturation. Because unlike healthy skin or healthy tissue, scar work is mostly avascular. Doesn't have good blood saturation. So we want to improve the saturation in this area. And also, the nerves are affected. So if nerves are affected, even the muscles they supply are also affected in the process. So we want to improve nerves, the sensation of the nerves in this area. Most patients report itching or loss of sensation in this area. So that's what we do with the nerve work. And then we do cosmetic repair work. That's improving the mobility of the scar, helping it dissolve, improve its hydration, and helping and making it disappear and dissolve in the skin. So normally there's a good combination of cosmetics we can use. It could be, I found this to be a good combination. Aloe vera, magnesium cream, and vitamin E oil have helped my patients with their scars, softening them and improving how soft or how supple the skin around the scar is. There are some other cosmetics for scars which you know about, but I found this to be very helpful, very good for my patients. And then we do lymphatic massage. After the surgery is done, the lymphatics in the area are affected, so the lymphatic channels are blocked. We know lymphatics drain all this extracellular fluid and edema back to the lymph nodes, but if the lymphatics are affected, then this process will be inhibited. And that's why patients have edema, swollen legs, swollen feet, swollen arms. So we want to help map and drain this lymph or extracellular fluid back into the lymph nodes where they drain. So that's the lymphatic work we do, or the lymphatic massage. And that's the image showing how we do scar work. Basically, we try to mobilize the scar by following what you call the direction of ease, where the scar wants to go. That's where we take it. It could be maybe either up or down, left or right, or maybe round, clockwise and clockwise. So if we do it that way, the scar becomes more softer and mobile. The skin around becomes more mobile and more supple for the patient. So we can do this and even teach the patient how to do this by themselves. And then we offer psycho-emotional support for the patient. After surgery, mainly with C-sections, our patients normally have a range of emotions around how they feel about their scar. It could be a feeling of shame about their scar. It could be a bit of worry or fear about their scar. So we do psycho-emotional therapy for the patient to help them reconnect back to their bodies.
2 minutes.
And then we do movement therapy to help strengthen the muscles around the scar area, which have been weakened. So that is core strengthening. We teach them how to breathe, how to move, do squats, lunges, basically all these core strengthening exercises to help strengthen their bodies. We do red light therapy. That's the red you see. That helps bring blood into the local area. Because like I said, scar is mostly avascular. So we want to bring blood to the area, and this promotes healing. Then we want to do patient education about their scar, inform them about what they should expect, their homework, and then their compliance with their work. So this is a picture of one patient I was treating. So the first image is how they were before, and then the second was how they were a few sessions after doing therapy. So you can see the swelling, which was mainly in the knee, reduced, plus the entire size reduced after implementing all these scar strategies. And then I'll talk about the challenges I've seen with scar therapy is that we don't get enough referrals for patients who have done all these kind of surgeries, and mainly C-sections. So, and what I would like to request is if we can have surgeons working together, bringing therapists on board with every patient you work with who has had surgery, so that the patient can get proper rehabilitation after surgery. That's what I'm calling upon. And mainly for C-sections, because people think C-sections are less debilitating, unlike, for example, a hip replacement or a knee replacement, because the patient can still walk and move, but they're still in pain. Actually, the research says about 7 out of 10 of patients who have had C-sections report back pain, increasing back pain. So they might come to us for back pain treatment. So I would like us to, if we can refer more patients for therapy, we can help them a bit better. Yeah, thank you so much. That was.
Thank you, Alan, for the wonderful presentation. Now, Ms. Sendagala was in the house. Yes, can see you. Let's have the next presentation. It's about physiotherapy, both pre and post-operatively. Ms. Ida Sendagala has a wealth of experience dealing with refugee children with disabilities. So I think that will come in handy. You are very welcome. And we pray that you take a few minutes.
Thank you so much. I'm very privileged to be here. I'm honored to be the final presenter for this evening, I think. It's an honor. My name is Ida Sendagala. I'm a physiotherapist. I have a master's degree from the University of Cape Town. The question I am asking this evening is physiotherapy an essential part of effective surgical interventions? And I hope that at the end, we shall answer it together. There is a scarcity of research about physiotherapy in surgical interventions in Uganda, but this is not just in Uganda, worldwide. We need to do more to know how physiotherapy is contributing to the management of surgical patients. So what is physiotherapy? So I thought that for this audience, it is helpful for us to not assume that you know who we are and what we do and how we can contribute to surgery. So basically, we are movement specialists. Our main focus is on improving movement and restoring function. So anything where there is functional deficit, physiotherapists are instrumental in improving that.
So I have a kind of schematic here that I was thinking that demonstrates how we interact closely in surgical interventions. When a patient has a surgical deficit, they may go to the physiotherapist or they may go to the surgeon. The surgeon will focus on the pathoanatomy, the physiotherapist will focus on the pathokinesiology. And then depending on the findings, we may refer to each other. The surgeon may go ahead and do a surgical intervention. The physiotherapist, if it's not necessary, will go ahead and do a movement intervention. But our goal is the same, to improve functional, to return the patient to normal function. And how do we work? We have a framework that is proposed by the World Health Organization. You may be familiar with this, the International Classification of Function Framework. And on top of this framework, we have the health condition that the patient comes to us with. We have the body functions, which are the impairments that come with the health condition, the activity limitations, the participation of the patient, the environmental factors, and the personal factors. I gave an example of this, and this is a patient who has a surgical problem, a patient who has been operated for breast cancer. They may present with, for example, cervical or thoracic pain, shoulder pain, and deficits around the shoulder girdle. They may be limited in lifting things, for example. If the patient has an occupation that requires them to work with their arms, this may be affected by this. And the environmental factors, what is the support they have physically and from the people they live with, and the personal factors. So the reason why I include this here is to show you the whole scope of how we may come in. And we want to look at the patient's problem from a holistic point of view. So this is all important in our intervention. So in the goals of physiotherapy, before surgery, we want to improve baseline function so as to optimize recovery. We want to introduce the use of assistive devices so that compliance after surgery is easier. We want to prepare the patient for the rehabilitation journey. It's often a journey. After surgery, we are then coming in to improve movement or restore it to the baseline that it was at. So we want to increase muscle strength, range of motion, improve muscle tone, etc. We want to help to reduce pain and increase cardiopulmonary endurance, as well as restore function, and a few others that I may not have mentioned here. These are some documented benefits of physiotherapy in surgery. Physiotherapy may be instrumental in pain reduction, in increasing mobility, restoring function. Because we help patients go back to their baseline function quicker, it may reduce hospital length of stay and reduce the costs of hospital care. It may be helpful in optimizing cardiopulmonary function after surgery and preventing postoperative complications. And what we do some of the interventions we use may include, the font is too small, sorry about that, but we do exercise therapy, manual therapy. My colleague talked a little bit about some of these. Mobilization. The research demonstrates that our best line of intervention with the best evidence of efficacy is therapeutic exercise. So we want to utilize this more than the others, but we have others that you may or may not have seen us using, like soft tissue manipulation, electrotherapy, etc. Some people have been bold to call us the mechanics of the body. We are getting in there. The physiotherapist is to the body what the mechanic is to the car. I don't know about that. It sounds a little bit, but yeah. Hopefully you get the point. We are getting in there and getting things moving and helping patients return to baseline. Sorry. So in which surgeries may be best optimized by physiotherapy? We want to weigh the risks of causing harm over the benefits and where the benefits outweigh the risks, most surgeries may benefit from physiotherapy intervention, especially if there is movement deficits. So I listed a number of those here: orthopedic, cardiac, etc. But any surgery that causes movement deficits or functional deficits to the patient may benefit from physiotherapy. And physiotherapy exists on a continuum of rehabilitation, and we work within a team. So we do not work alone. The rehabilitation team must include other people like occupational therapists, psychologists, speech and language therapists, orthotists, etc. So rehabilitation is a whole team in which physiotherapists are part. And what is the evidence of efficacy? We are talking a lot about what we can do and how, but what does the evidence say? So the biggest support for our modalities is through functional restoration using exercise therapy. It has the highest evidence of efficacy. The use it or lose it principle. This one is because it mimics function and normal body movement. There is a big need to improve the evidence that we need, that we use to support our modalities, especially with regard to dosage, frequency, intensity, and mechanism of action. I just put a few studies here. I couldn't exhaust them, but for example, this study was a systematic review of pre-surgical exercise intervention in cancer patients, and it found that patients who got pre-surgical physiotherapy exercises had better functional outcomes. And this was a randomized control trial for patients who underwent lumbar spine surgery, where there were greater benefits for patients who had pre-surgery physiotherapy as well. There were many, I couldn't list them. But as I've mentioned, there's a need to improve the research that we have in Uganda and in low-income countries supporting our methods and our treatment modalities. And I ask this question again. Is physiotherapy an essential part of effective surgical interventions? And I think we can all, I hope we can agree that it is. Thank you.
Thank you very much, Ida. Do not go very far away. At this point, the presenters of the past two sessions want to welcome a few questions, 1, 2, 3, and then we have the presenters maybe tackle them before we call it a day. Unless there is anything. Do you have any questions in the house before I do call back the presenters? Or you are very tired and want to go home? Okay, maybe you will answer the questions tomorrow. Prince, please come and take over. And thank you very much, everyone. Let's give them a round of applause for their presentation at this late hour. Before I forget, Francis, first come back here for a photo. Ida? Yes. First come back here for a photo. And we shall also call the President Asou to join you. Because, I mean, it is evening. Yeah, to make up the number. And then we shall call it a day.
You've always wanted a photo with the President, but it's fine. You can have it. Thank you so much. Let's clap ourselves. I want to thank Professor Bailman, first of all, for his very wonderful lecture on pancreatitis, but also he was the first person in the room who is still in the room right now. So we thank him so much for being with us. Thank you so much for being here up to this time. I want to implore you to come early tomorrow, because even tomorrow's program is quite lengthy. Try to wake up early, and it might rain, so please plan for that as well, so that we can begin tomorrow at 8. We still have a lot on the menu, and we still want to listen more from our invited guests. They traveled from very far, so we can't just have just a 30-minute speech. We need more from them, more than that. So we still have to engage with them in many other sessions. Thank you so much for traveling. Thank you so much, Professor Maswime, for coming all the way from South Africa. We are eternally grateful. We are eternally grateful, Professor, as well, even to Dr. Ricard. All right, see you tomorrow. Let's have a wonderful evening. There's a... Hello? 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 Someone lost their Nokia phone, a Kability. Kindly pick it from the front desk if it is yours, or if you know who it belongs to. Thank you.